नमस्कार दोस्तों, मैं हूं कमल नारायण और आप सभी का स्वागत है तीसरी आईवीएफ समिट में। दोस्तों, निसंतान होना हमारे समाज में एक अभिशाप से कम नहीं है। हालांकि हम में से ज्यादातर लोग इससे जुड़ी पारिवारिक, सामाजिक और मानसिक कठिनाइयों को शायद ही समझते होंगे, लेकिन क्या आप जानते हैं कि हमारे बीच ही लगभग हर 10वां कपल इस समस्या से जूझ रहा है और बच्चा न हो पाने से जुड़े तमाम तनावों, इमोशनल उतार चढ़ावों और सामाजिक एवं पारिवारिक छींटाकशी का हर दिन सामना कर रहा है। इनफर्टिलिटी, या जिसे हम बांझपन भी कहते हैं, आज के समाज के लिए एक गंभीर स्वास्थ्य समस्या बन गया है। वर्ल्ड हेल्थ ऑर्गेनाइजेशन के मुताबिक भारत में करीब 3 करोड़ कपल इस कंडीशन से ग्रसित हैं। हालांकि इस बात में दो राय नहीं है कि यह नंबर और भी बड़ा हो सकता है, क्योंकि हम सभी जानते हैं कि बहुत से लोग समाज और परिवार के तानों के डर से इस पर खुलकर बात नहीं करते हैं। भारत में लगातार बढ़ रही इनफर्टिलिटी की समस्या और इसकी वजह से बढ़ रही तमाम और स्वास्थ्य चुनौतियों को कम करने के लिए आम लोगों तक सही जानकारी पहुंचाने और सरकारी नीतियों में इससे जुड़े विशेषज्ञों, वैज्ञानिकों और इंडस्ट्री प्रतिनिधियों की सहभागिता को बढ़ाने के उद्देश्य से ISW काउंसिल पिछले 3 सालों से वर्ल्ड IVF डे यानी 25 जुलाई को इंडिया IVF समिट का आयोजन करता रहा है। IVF एक ऐसा वैज्ञानिक तरीका है जिससे दुनिया के करोड़ों चाइल्डलेस कपल को बच्चा होने में मदद की, और कई मायनों में देखा जाए तो इस प्रोसेस को साइंस की सबसे चमत्कारिक उपलब्धियों में से एक माना जा सकता है। इस टेक्नोलॉजी का पहला सफल प्रयोग लगभग 4 दशक पहले आज ही के दिन तब देखा गया जब इंग्लैंड में लुइस ब्राउन ने दुनिया की पहली IVF चाइल्ड के रूप में जन्म लिया। तब से दुनिया भर में 80 लाख से ज्यादा बच्चे इस टेक्नोलॉजी की मदद से जन्म ले चुके हैं। आज इस टेक्नोलॉजी का सफल उपयोग भारत के छोटे छोटे शहरों में भी हो रहा है, जहां अमीर गरीब हर तरह के लोग इसकी मदद से न सिर्फ संतान का सुख पा रहे हैं, बल्कि अपने स्वस्थ और सुखी जीवन को कई तरह से प्रभावित करने वाले इनफर्टिलिटी टैक्स से भी बच रहे हैं। IVF की बढ़ती जरूरतों को देखते हुए आज भारत के लगभग हर कोने में IVF क्लिनिक्स बन गए हैं। हेल्थ मिनिस्ट्री के मुताबिक देश में लगभग 40,000 IVF क्लिनिक हैं और आज IVF और दूसरी असिस्टेड रिप्रोडक्टिव टेक्नोलॉजीज एक बड़ी इंडस्ट्री बन गई। जाहिर है, जब कोई भी एक्टिविटी इतने बड़े स्तर पर होगी तो उसमें तमाम इरेगुलरिटीज और रॉन्ग प्रैक्टिसेस पनपने की संभावनाएं बढ़ जाती हैं, और ऐसे में जरूरत होती है कि सरकार ऐसे कानून और नियम बनाए जिसके माध्यम से न सिर्फ अनियमितताओं को रोका जाए, बल्कि देखभाल और सर्विस के हाई स्टैंडर्ड्स को सभी के लिए समान रूप से मुहैया कराया जा सके। और इसी उद्देश्य से भारतीय संसद ने पिछले दिसंबर ART रेगुलेशन एक्ट बनाया। इस एक्ट के 2 साल पहले सरकार ने सरोगेसी रेगुलेशन बिल की भी शुरुआत की थी, जिसका उद्देश्य भी ART से जुड़े कुछ पहलुओं को रेगुलेट करना था। हालांकि ART रेगुलेशन एक्ट में IVF और दूसरे ART प्रोसीजर से जुड़ी कई गतिविधियों को रेगुलेट और स्टैंडर्डाइज करने का प्राविधान किया गया है, लेकिन तमाम जानकारों और प्रैक्टिशनर्स का मानना है कि इस एक्ट और सरोगेसी बिल दोनों में ही अभी भी तमाम सुधार की जरूरत है, जिससे न सिर्फ सभी निसंतान दंपतियों को बल्कि बच्चे की चाह रखने वाले हर इंसान को बिना किसी भेदभाव के इस तकनीकी का फायदा पहुंचाया जा सके। और आज इस 3rd IVF समिट में इसी मुद्दे पर अपनी राय रखने के लिए भारत में बढ़ रही इनफर्टिलिटी एपिडेमिक को रोकने के लिए जरूरी कदमों को हाईलाइट करने के लिए हमारे साथ पब्लिक हेल्थ और ART के कई एक्सपर्ट्स जुड़ रहे हैं। द मोटो ऑफ टुडेज समिट that we are hosting in partnership with BSV is let's talk fertility with a pledge to create awareness and advocate the best practices around IVF. और आज के सेशन का माध्यम हमने हिंदी रखने का इसलिए सोचा है जिससे कि इस संदेश को हम ज्यादा से ज्यादातर लोगों तक पहुंचा सकें। तो इसी के साथ मैं स्वागत करता हूं डॉक्टर के मदन गोपाल का, जो कि भारत सरकार के प्रमुख पॉलिसी थिंक टैंक नीति आयोग में हेल्थ संबंधित विषयों के वरिष्ठ सलाहकार हैं। डॉक्टर मदन गोपाल पिछले लगभग 3 दशकों से देश के हेल्थ सिस्टम में सुधार और उसे मजबूत करने की ओर काम कर रहे हैं। देश की तमाम प्रमुख स्वास्थ्य योजनाओं, जिनमें से भारत सरकार की महत्वाकांक्षी आयुष्मान भारत योजना भी शामिल है, में डॉक्टर मदन गोपाल की प्रमुख भूमिका रही है। मैं स्वागत करता हूं IVF को भारत में सही मायनों में लाने वाले डॉक्टर ऋषिकेश पाई का। डॉक्टर पाई देश के जाने माने IVF ब्रांड ब्लूम आईवीएफ मुंबई के मेडिकल डायरेक्टर हैं। डॉक्टर पाई फॉक्सी जो कि लगभग 40,000 स्त्री रोग विशेषज्ञों का संगठन है के प्रेसिडेंट इलेक्ट भी हैं। मुंबई से ही आज हमारे साथ लीलावती अस्पताल में ब्लूम आईवीएफ की मेडिकल डायरेक्टर डॉक्टर नंदिता पालसेतकर भी जुड़ रही हैं। डॉक्टर पालसेतकर इंडियन सोसाइटी ऑफ असिस्टेड रिप्रोडक्शन ISAR जो कि देश में ART और IVF एक्सपर्ट कप की प्रमुख संगठन है की प्रेसिडेंट हैं और फॉक्सी की भी प्रेसिडेंट रह चुकी हैं और भारत में IVF के प्रचार प्रसार में इनका प्रमुख हाथ रहा है। डॉक्टर पालसेतकर करीबन 30,000 से ज्यादा कपल्स को IVF के माध्यम से इनफर्टिलिटी के चैलेंज को ओवरकम करने में हेल्प कर चुके हैं। राजधानी दिल्ली से हमारे साथ जानी मानी IVF स्पेशलिस्ट डॉक्टर सोनिया मलिक जुड़ रही हैं। डॉक्टर मलिक वसंत विहार स्थित नोवा IVF फर्टिलिटी की प्रमुख हैं और लगभग 3 दशक से भी ज्यादा अपने कार्यकाल में 7,000 से ज्यादा सफल ART प्रोसीजर कर चुकी हैं। हमारे साथ जुड़ रहे हैं डॉक्टर जयदीप टैंक, कंसल्टेंट अश्विनी मैटरनिटी एंड सर्जिकल हॉस्पिटल, सेंटर फॉर एंडोस्कोपी एंड IVF फ्रॉम मुंबई। डॉक्टर टैंक फॉक्सी के सेक्रेटरी जनरल हैं एवं मुंबई ऑब्स्टेट्रिक एंड गायनेकोलॉजिकल सोसाइटी MOGS के वाइस प्रेसिडेंट भी हैं। साथ ही में दिल्ली से SCI IVF हॉस्पिटल और SCI इंटरनेशनल हॉस्पिटल की फाउंडर डायरेक्टर डॉक्टर शिवानी सचदेव गौर भी हमारे साथ हैं। डॉक्टर गौर ने लंदन और स्कॉटलैंड में करीबन 4 साल तक IVF की ट्रेनिंग और प्रैक्टिस के बाद भारत लौटकर IVF के क्षेत्र में सराहनीय काम किया है। डॉक्टर गौर लगातार मीडिया के माध्यम से IVF पर जागरूकता फैलाने का काम कर रही हैं। सो विद दिस लेट्स बिगिन टुडेस सेशन। तो जैसा कि मैंने कहा कि थोड़ा हिंदी इंग्लिश मिक्स करके बात करेंगे आज, जिससे कि जो कंटेंट है वो ज्यादातर लोगों तक पहुंच सके और उसको समझ सकें। तो इससे पहले कि डॉक्टर मदन गोपाल को बुला करके समझना की कोशिश करें कि जो रेगुलेटरी फ्रेमवर्क है और उसमें भारत में बढ़ती जो इनफर्टिलिटी के चैलेंज हैं उनको कैसे एड्रेस करने के लिए सरकार कदम उठा रही है, उसके पहले मैं डॉक्टर नंदिता पालसेतकर जो कि ISAR की प्रेसिडेंट भी हैं उनसे रिक्वेस्ट करूंगा और समझने की कोशिश करूंगा कि डॉक्टर नंदिता पालसेतकर वी आर टॉइंग लॉट ऑफ नंबर्स। तो करीबन 28 मिलियन कपल्स आर लिविंग विद इनफर्टिलिटी। कई नंबर्स में हमको लगता है कि वो 10% कपल्स, 15% कपल्स तक के नंबर्स, देयर आर मल्टीपल रिसर्च एंड रिपोर्ट्स। एक्चुअली इनफर्टिलिटी कितना बड़ा चैलेंज भारत में बन चुका है और उसके बहुत सारे कारण हो सकते हैं, ना कि सिर्फ इन्वायरमेंटल, मैनी अदर काइंड ऑफ अंडरलाइनिंग डिजीजेज एंड ऑल। और इस चैलेंज को एड्रेस करने के लिए IVF एज एन इंडस्ट्री और ART एज एन प्रोसीजर्स और एज अ trait, how do you see we are poised to address this problem and where are the challenges being faced?
I think, Kamalji, if you look at it, as a president of ISAR, I have realized that over the last 44 years since the birth, Louisa Brown का जन्म हुआ है, और ये जो IVF का सक्सेस रेट जो था 1%, 2%, अभी सक्सेस रेट अबाउट 50 to 60% तक गया है। एंड हमें रियलाइज हुआ है कि अगर पेशेंट्स जल्दी आए तो उन्हें सक्सेस जल्दी मिल जाता है, और ये जो टेक्नोलॉजी है उसका जो नॉलेज है वो बहुत इजीली स्प्रेड हो चुका है। एंड इंडिया ऐसी कंट्री है जहां मेड इन इंडिया है, और you have people who are spreading the knowledge, who are teaching other people, so the knowledge has been spread very widely and the whole country has become बहुत acceptable कि हम ये कर सकते हैं। ये एकदम हाई टेक नॉलेज है। मेडिकल फील्ड में जो एडवांसेस हम देख रहे हैं ऑल अराउंड इन ऑल द फील्ड्स, तो ये जो फील्ड है इसमें भी नॉलेज बहुत ही आगे बढ़ चुका है। एंड ये जो नॉलेज है पर्कुलेट हो रहा है इवन हमारे रूरल एरियाज में। एंड एट द सेम टाइम जैसे आप बोल रहे हो कि इनफर्टिलिटी बढ़ रहा है ड्यू टू वेरियस रीजंस, जैसे आपने पोल्यूशन एक रीजन कहा, दूसरी चीज है हमारा एजुकेशन लेवल। लड़कियों का एजुकेशन लेवल बढ़ रहा है, लड़कियां एजुकेट हो रहे हैं, लड़कियां एम्पावर हो रहे हैं, दे आर गोइंग फॉर फाइनेंशियल इंडिपेंडेंस। तो शादियां लेट हो रही है, चाइल्ड बेयरिंग लेट हो रहा है, ये अर्बन पॉपुलेशन का है। रूरल में थोड़े अलग प्रॉब्लम्स हो रहे हैं, काफी डिजीजेस है जिसके वजह से बच्चे नहीं हो रहे। तो इनफर्टिलिटी नॉट ओनली इज अ मेडिकल प्रॉब्लम जो WHO ने डिफाइन किया है कि ये एक NCD में, अभी डॉक्टर मदन गोपाल जी यहाँ हैं तो उनको हम रिक्वेस्ट करते हैं कि इनफर्टिलिटी एक्चुअली NCD है, नॉन कम्युनिकेबल डिजीज है, आप हमें प्लीज हेल्प कीजिए कि ये उस डिजीज एरिया में ये जाए, कि NCD में ये चला जाए तो बहुत ही आसान हो जाएगा। और आई एम वेरी हैप्पी, हम 2003 से डॉक्टर पुष्पा भार्गव के हेल्प से पूरे ये कमेटी 10-15 साल से ये हेल्प करिए। और सर आपने देखा होगा कि काफी कंट्रीज में जो बहुत प्रोग्रेसिव है वहां सब जगह पे एक लॉ होता है, कंट्रोलिंग बॉडी होती है जो ये IVF प्रोसेस को कंट्रोल करती है, एंड बहुत ही एथिकल प्रैक्टिसेस इसमें आती है। सो वी एज अ बॉडी आर वेरी हैप्पी कि ये लॉ आया है और एथिकल प्रैक्टिसेस हमारे प्रैक्टिस में आ जाएंगे। ऑफ कोर्स ये लॉ आने में, ये एथिकल प्रैक्टिसेस आने में थोड़ी दिक्कत तो हो जाएगी। हम इंडियंस को डेटा मेंटेन करने में बिल्कुल आदत नहीं है, बिकॉज बहुत क्वांटिटी वर्क होता है, बहुत सारे पेशेंट्स आते हैं। आपको मालूम है OPD में आप गंगाराम में जाओ या एम्स में जाओ या JJ में जाओ, हमारे 100 पेशेंट्स होते हैं, तो इतना सब डेटा मेंटेन करना। सो वी हैव टू चेंज आवर माइंडसेट एंड वी हैव टू मेंटेन द डेटा। सो आई थिंक द लॉ इटसेल्फ, Kamal ji, is going to bring about a lot of change in all of us. थोड़ी बहुत दिक्कतें हैं जो हमने as a group, हम IVF वाले गए थे and we have kind of sorted it out. There are some problems which we are ironing it out. But मुझे लगता है overall the IVF scenario in India will change. और इससे क्या होगा कि हम इतनी अच्छी प्रैक्टिस कर रहे हैं कमल जी, पूरे देश में बहुत अच्छे IVF डेटा निकल रहा है, बहुत अच्छे सक्सेस रेट्स आ रहे हैं। इतनी टेक्नोलॉजी, हमारे जो टेक्नोलॉजी है इंडिया में जो फोरफ्रंट में नहीं है, बिकॉज अननेसेसरी कई चीजों को ज्यादा न्यूज में आ जाते, जो अच्छी चीजें हैं इस लॉ के वजह से अच्छी चीजें आगे आ जाएंगे। एंड इंडिया टुडे, आई एम टेलिंग यू, 5 साल के बाद इंडिया विल बी एट द फोरफ्रंट ऑफ IVF, आई फील, बिकॉज वी विल बी एबल टू ट्विच इट। सो मुझे आपसे सिर्फ ये रिक्वेस्ट है कि काफी कुछ टेक्नोलॉजिकल एडवांसेस जो हमने हमें उन पे ख्याल रख के, we have to release a little bit of the things. We'll discuss it as the discussion goes, but वो technological advances के बारे में हमें आपसे definitely discussion करना है। But I think this is very wonderful, and जो infertility rise देख रहे हैं हम, उसके लिए IVF is the answer, and बहुत सारे IVF सेंटर्स खुल रहे हैं, और ये रेगुलेशन बहुत जरूरी था कि हम वर्ल्ड प्लेटफॉर्म पे हमारी क्रेडिबिलिटी दिखाए जरूर द वर्ल्ड को।
थैंक यू सो मच डॉक्टर पालसेकर। बहुत इंपॉर्टेंट पॉइंट्स जो आपने बोले कि 4 दशक पहले जब IVF की शुरुआत हुई थी तो शायद 1 या 2% उसका सक्सेस रेट होता होगा, तब भी वो बहुत चमत्कारिक प्रोसीजर था। आज भी उतना ही चमत्कारिक प्रोसीजर है, बिकॉज जो शायद लोग निसंतान लोग, जिनको बच्चे की चाह है, किसी तरीके की इनफर्टिलिटी, चाहे प्राइमरी या सेकेंडरी इनफर्टिलिटी से जूझ रहे हैं, उन सब के लिए शायद ये मतलब इट्स ऑलमोस्ट अ एक्ट ऑफ गॉड टू काइंड ऑफ गेट this help from the medical science. Now, today we have that around 50-60% of success rate, which shows the remarkable improvement, and we have seen in the medical science in this space. दूसरा बहुत important point जो आपका था कि infertility should be considered as NCD, because many time it is an outcome of certain NCDs, maybe diabetes or maybe many other diseases. So this is very important point, and I think the kind of this number we are seeing in India, हमें इस तरफ कदम जरूर बढ़ाना चाहिए, जिससे हम इनफर्टिलिटी से जूझ रहे लोगों को ज्यादा एम्पैथेटिकली समझ सकें, उनकी प्रॉब्लम्स को, शायद जो कि कई बार एक पर्सनल ब्लेम के तौर पे देखी जाती है, उसे एक डिजीज के तौर पे देखना शुरू करें। Before I go to Dr. Madan Gopal, let me just take a quick inputs from all the doctors here. Dr. Madan Gopal, I believe that will be okay, because it will give you a little bit of kind of a glimpse of how our industry is thinking. But these are the people who are kind of providing these treatment day in day out, and kind of accepting and welcoming the law which has been created. And I'm sure that is wonderful. It's very important step. But yes, every act and law sometimes requires maybe some modification, and they may have some point on that. So let me go to Dr. Rishikesh Pai. Dr. Rishikesh Pai, you have also seen a lot of water has flown under the bridge since you kind of gave a impetus to IVF procedures in India. How do you see it has changed over the period? And also, what is the need of ensuring important aspect of affordability, accessibility, and quality in the IVF space? Because as I said, when the number of clinics are kind of going anywhere, the quality gets compromised sometime. So what are these areas which you look, and how do you see the new act kind of addressing this challenge?
Thank you for calling me, Kamalji. ISW has been at the forefront of healthcare, and all of my friends are there. Madan Gopalji, I know for a long time. Nandita, of course, my partner, and so many of the other colleagues of mine, Sonia ji, Shivani, Dr. Tank, all of them are there. So I have been fortunate enough क्योंकि मैंने जब IVF चालू किया इधर, तब 7-8 लोग ही थे इंडिया में. 1989 I came back from मेलबर्न, एंड 91 में जब मैंने चालू किया 7-8 लोग थे IVF करने वाले इंडिया में. जब जैसे डॉक्टर नंदिता ने बोला, वो टाइम 1% अराउंड 5% वाज द रिजल्ट. एंड सलीम दया करके मेरा अच्छा दोस्त है, वो एक उसका टॉक था, उसने बोला था कि IVF का जो इंक्रीज है वो इट्स इन अराउंड basically every year 1% pregnancy rate has increased. So now present pregnancy rate ये बहुत ही important है. और ये देखो, regulation is to be followed properly and implementation has to be proper. Now in other fields they are now clamping down कि advertisement करेंगे तो बराबर करना. 60% pregnancy rate नहीं है. यूनाइटेड स्टेट्स का रजिस्ट्री जो है उसमें 3,50,000 procedures were done in 2019. The success 70,000 live births were there. Success rate is 30-35%. So it is important. जब ये एक्ट अभी आएगा, proper information is it. Disinformation is not acceptable. Disinformation should be clamped down on. So because I believe in that. In India जो कुछ भी अभी है, access to technology बहुत अच्छा है, but disinformation should be totally avoided because that causes unhappiness amongst patients. अरे patient बोलता है, अरे मेरे को तो बोला 60% रिजल्ट है 2 साइकिल में, तो 100% होना मांगता है, but pregnancy rate तो 30% है. So the important thing, so what I feel is that the act which has come now, this act brings responsible behavior is very important. Responsible behavior from our fraternity. Fraternity जो है उसको responsible, internal ethical behavior has to be responsible. And if suppose someone breaks that responsible behavior, obviously they have to be punished. And that is very important because that will cause confidence amongst the patients towards the doctor. Doctor patient जो relationship जो important है and confidence building important है, और ये regulation रखना बहुत जरूरी है. Overall, I feel that the India is a binomial society. India में there are two types of people. One are the people who are important, poor people. Our country has 850 million to 1 billion poor people, and we have 200 million well-off people, middle-class people. Some of them may be rich, but most of them are well-off. Now, what is the biggest problem Indian healthcare industry is facing is that it is facing a problem of expectation. Because of digital explosion of information, क्या हुआ है कि patient expectation बहुत ज़्यादा है, but अपने जो cost है वो Indian है. So I always say costs are Indian, but expectations are westernized. So that there's a disparity between what people expect and what the doctor community can give them. Because obviously, you know, if you see IVF, we are 1/5 the cost of what is there abroad. So obviously we cannot give that care. we are striving, and I would say that many of us have given that good care to them at a lesser cost. So there's a disparity in the cost. So that is one area where there can be conflict between the consumer and the provider. So doctor and patient conflict can occur because of disparity in what you provide them and what they expect out of you. So that is as far as the upper class is concerned. As far as the, let us say, not so well off class, that is 900 million. I, as president of the federation, I totally believe in selfless service. Those 9, and ये हमारे प्रधानमंत्री मोदी जी का जो कॉन्सेप्ट है वो हमको दोहराना ही पड़ेगा. वो 900 मिलियन लेवल लोगों के लिए हमको सैक्रिफाइस देना ही पड़ेगा. We have to do it free. We have to do it subsidized for them, because then only people will respect the doctor. See, the doctor fraternity, we are well off fraternity. I personally feel as doctor, मेरे को गवर्नमेंट ने इतना कुछ दिया, my education was free, everything was free. So that freedom that they gave us, that ability to earn that day, we have to, what is known as, pay back to the society. It's very important, and that's why we have to have a binary functioning by now. And मैं मदन गोपाल जी को रिक्वेस्ट करना चाहता हूँ कि प्लीज नीति आयोग has to bring IVF under Ayushman Bharat. It has to be, not for the 300 million at the top, forget them, but for the 1 billion at the bottom. They have to be brought under the Ayushman Bharat scheme, so that we can serve them also. They are our people. They are our main fabric or the pillars of our society, and that is very important to serve them.
Thank you so much. Thank you so much, Dr. Rishikesh Pai. So, the key message which you are delivering, that while the Act is definitely going to improvise the standards of the care and, kind of plug out a lot of irregularities if there are. Affordability is one area, and then the accessibility of, infertility care, which might have not been, or which has not been taken care of by this Act. So this Act will, kind of regulate the services, but what about those people who are still out of the ambit of, any cover, whether it is a private insurance cover or whether it is a government-sponsored scheme? While some of the government hospitals are offering, these services on much lesser or subsidized price, but that is too small a quantity available. Yes, Dr. Rishikesh Pai, any point you want to add?
One important point I wanted to make here is that the problem is that there is a big problem of, as Dr. Nandita had also said, that there is a decrease in the ovarian reserve, and there is also a big issue in India in the poor class, that is the damage of the uterus because of tuberculosis. So for these people, the third party option of surrogacy and egg donation is very important. And what I foresee in the law, I'm really a bit perturbed about it, is that because of this law, the cost of provision of these two particular areas, the egg donation and the surrogacy, will go up, and it may become inaccessible, and it may break the philosophy of our beloved Prime Minister, and that is to give access of care to the poorest of the poor. So this law, we'll have to tweak it somewhere. That is why I was taking of the Ayushman Bharat, and we will also have to.
Sure.
I feel that we are under stress. I mean, I'm ultimately a nationalist. I believe I love my country. So we are under financial stress, and we must also have tweaking of this law, so that it's like export zone होता है ना. अपने पास एक export zone होता है industry में, जहाँ आप बनाओ और export करो. So we need to have a more lax zone where other servicing of foreign patients can be done. We have tremendous potential to bring the rupee value down with the dollar, with medical care. That is what I want. The Niti Aayog has to look at this law again. We have to tweak it, because what is happening, migration of medical tourism is going to Thailand. Thailand is taking all the tourism, all other countries are. I'm not saying that break the laws, but I am saying don't make the law such that our revenue loss for us, or for our country's development, revenue at present is very crucial. The revenue loss may be there because of this law.
Yeah, thank you so much, Dr. Rishikesh Pai. Important point. Let me just quickly, and I would request to be quick in the your comments, so that Dr. Madan Gopal can also share his side about as a public health expert. He's very passionate about that the care and all that required care should reach to everyone, whether it is any other disease area or infertility as well. So Dr. Sonia Malik, so we have seen that, and since we are discussing more in the context of the new law, act, which is definitely has come into the, kind of existence with a very clear objective of enhancing the quality of care and ensuring that there are no irregularities in between. How do you see your practice, going forward? Does this act enables you to, and people like you and many other practitioners, to deliver a better care? Also, at the same time, when you are ensuring that a certain level of responsibility is maintained, how do you see that?
Thank you very much, first of all, for having me here, and thank you very much for giving me this opportunity. Actually, this is a much needed regulation which we were waiting for the last so many years. As Nandita mentioned, we have been trying to get into it since Dr. Bhargav first thought of it, and it has taken about 15 years for this law to come in. Yes, a lot of water has flown since then, as Rishikesh has also mentioned, that things have changed tremendously. The biggest misfortune that I think has happened to this particular segment of medicine is that we have been called an industry. It is called the IVF industry.
I also used that word.
You also used it, yes.
Yeah.
So there is no other section of medicine which is called an industry. It's not a cardiac industry or an orthopedic industry it is a much more expensive industry, I would say, segment of medicine. But unfortunately, IVF has been named an industry, probably because of the third-party reproduction angle that came in, the donor and surrogates that Rishikesh was mentioning. It was essential, it happened, but somehow it changed the perspective. So that, of course, yes, but now with the regulation, what is going to happen is there is going to be a sort of a consolidation of good forces, I think. The good people who have been actually practicing IVF the way it should be as a science are the ones who are going to do well. And the ones who have just sprung up, and just started to do it because they wanted to make money in the industry, those people are probably going to get out because they will not be able to maintain the kind of standard that is required by the law, So that part is good. And I think that, people who are law abiding, people who have been, always conscious of doing science rather than just trying to make it some kind of a mockery, those people will do well. And as far as affordability is concerned, as Dr. Rishikesh and Nandita both have said, there have to be changes in this act so that it becomes affordable. And I think for that, the public sector will have to take a larger role. They will have to play a larger role. Today, we do not have trained personnel in the public sector for IVF. Unfortunately, it's the private sector which is doing well. And that is where the discrimination, or that is where the dichotomy is. Since we are much ahead in technology in the private sector, but in the public sector, they are still struggling to establish even small units. So that is something that will have to be rectified, and the government will really have to look into it, because the bulk of our population goes to the public sector hospitals. They do not visit us. They cannot afford us. So therefore, that kind of a thing will happen. And I'm sure, as Dr. Rishikesh said, if it comes under the Ayushman Bharat scheme, it will definitely rectify things for everybody.
Certainly. Thank you so much, Dr. Malik. Let me just take two more doctors and then Dr. Madan Gopal. Dr. Jaideep, so we have kind of seen that almost everyone is welcoming this new act, and I'm sure it is going to help. And with certain riders, as Dr. Rishikesh Pai and Dr. Malik and Dr. Palsitkar also highlighted about, that affordability need to be also taken care of. The access also need to be taken care of. In this, act also, there are certain, kind of prescriptions or the clauses which kind of, there are certain, voices which are being kind of articulated that this particular act also exclude certain people, from the possibility of getting a ART service, maybe, kind of a live-in partners, or maybe, sometime LGBTQ partners who are looking for, similar kind of services to be available. What is your opinion on this area? Do you find that this law is excluding certain people out of, the ambit of getting this miraculous, scientific support, or do you find it, good at the beginning at least?
I think as a beginning, this law is good. शुरुआत के लिए ये लॉ अच्छा है, ये लॉ की जरूरत थी, इसमें तो कोई डाउट नहीं है। लेकिन ये लॉ की जरूरत क्यों थी, ये एक सोचने की बात है। जैसे आप पहले कह रहे थे कि, और जैसे सभी कहते हैं कि जो प्रैक्टिसेस है वो अच्छी नहीं थी, उसका डेटा कहाँ है? एक बात होती है जिसको परसेप्शन कहते हैं, और एक बात होती है जिसको डेटा कहते हैं। और मुझे लगता है कि ये जो सारी वर्ड्स यूज किए जाते हैं, आईवीएफ इंडस्ट्री है, एक इंडस्ट्री वर्ड है। एक वर्ड ये है कि ज्यादा करके लोग जो आईवीएफ करते हैं वो सर्विस के लिए नहीं, पैसे के लिए करते हैं। दूसरा ये है कि आईवीएफ में बहुत सारी मैल प्रैक्टिसेस है। डेटा कहाँ है? आप ये सब चीज जो आप बोल रहे हो, आप यानी आई एम नॉट टेलिंग यू स्पेसिफिकली, ये सब परसेप्शन बेस्ड है। थोड़े मीडिया रिपोर्ट्स आते हैं, आप ये देख नहीं रहे हो कि जो मीडिया रिपोर्ट आते हैं वो आईवीएफ की प्रैक्टिस का लेस देन 1% रिफ्लेक्शन है। जो 99% डॉक्टर्स अच्छी प्रैक्टिस कर रहे हैं, और जो इस बात का जिक्र नंदिता ने भी किया था, वो कहाँ है? शायद ये एक नैरेटिव आईवीएफ के लिए बन गया था, और मेरे मुताबिक एटलीस्ट ये लॉ में डेटा से ज्यादा परसेप्शन का इस्तेमाल हुआ है। देखिए, बात ऐसी है, आप जब भी इंक्लूसिविटी की बात करते हो, और मैं आप ज्यादा टाइम नहीं लूंगा, 2 मिनट, 11:34 है, आई विल स्टॉप एट 11:36। आप जब भी इंक्लूसिविटी की बात करते हो तो उसमें क्या इंक्लूसिविटी सिर्फ कम्युनिटी की आती है? इंक्लूसिविटी तो सभी स्टेक होल्डर्स की आनी चाहिए लॉ में। जो रेगुलेट करने वाले हैं, अथॉरिटीज है, उनकी इंक्लूसिविटी आनी चाहिए। जो लोग सर्विस प्रोवाइड करते हैं उनकी भी इंक्लूसिविटी आनी चाहिए। आई ऑलवेज से कि डॉक्टर्स डोंट स्टॉप हैविंग ह्यूमन राइट्स बिकॉज दे वेयर अ वाइट एप्रन। ये जो लॉ बनाया है वो अच्छा लॉ है, मैं वापस बोल रहा हूं, मैं वापस दोहरा रहा हूं कि ये अच्छा लॉ है। लेकिन इसमें आप सोचे कि एम्पावरमेंट किसकी हुई है। आप जैसे एमटीपी एक्ट देखते हो, अबॉर्शन लॉ है, क्लियरली एम्पावरिंग फॉर विमेन एंड प्रोटेक्टिव फॉर डॉक्टर्स, राइट? आप वो कॉन्टेक्स्ट से, रिप्रोडक्टिव राइट्स के कॉन्टेक्स्ट से, आप डाइवर्स जेंडर फ्लूइड ग्रुप्स के कंटेक्स्ट से आप ये लॉ में देखें तो इसमें एम्पावरमेंट कम है और रेगुलेशन ज्यादा है। शायद ये बिगनिंग है, इसीलिए है। शायद जैसे डेटा ज्यादा आएगा वैसे ये लॉ में अमेंडमेंट्स आएगी, ये भी पॉसिबल है। ये हम नहीं बोल रहे कि पॉसिबल नहीं है, लेकिन एज ऑफ नाउ जैसे ये लॉ है, इसका जो टोन, इसका जो टेनर, इसकी जो लैंग्वेज है, ये एम्पावरिंग नहीं है, ये रेगुलेटरी है। दूसरी बात यह है कि जैसे ऋषिकेश बता रहे थे कि कॉस्ट्स विल इंक्रीज, होने ही है। जैसे लॉ ड्राफ्ट किया है, कॉस्ट तो इंक्रीज होने ही है। कॉस्ट इसीलिए इंक्रीज नहीं होंगे कि पहले प्रैक्टिस बुरी थी और अभी प्रैक्टिस अच्छी है। कॉस्ट इसीलिए इंक्रीज होंगे कि शायद जब ये लॉ बनाया गया था तभी इनपुट्स तो बहुत सारे प्रैक्टिसिंग डॉक्टर्स के लिए गए थे, लेकिन जब ये लॉ फाइनली ड्राफ्ट हुआ है तभी वो शायद प्रैक्टिस की जितनी कंसिडरेशन होनी चाहिए उतनी नहीं है। एक क्लासिक एग्जांपल एग डोनेशन का है, जो डॉक्टर ऋषिकेश भाई, आई थिंक डॉक्टर मलिक ने भी अभी कहा कि यू हैव टू डिजाइन द लॉ एज पर करंट प्रैक्टिस, नॉट एज पर करंट परसेप्शन। और एक लास्टली मैं ये कहना चाहूंगा कि जो ये एक लॉ में जो है, और ये सिर्फ ये लॉ नहीं है, काफी सारे लॉज हैं जो डॉक्टर्स को रेगुलेट करते हैं। आई डोंट नो आपको पता है या नहीं, लेकिन गायनेकोलॉजिस्ट आर द मोस्ट रेगुलेटेड स्पेशलिटी इन मेडिसिन। हमारे ऊपर एमटीपी एक्ट है, पीसीपीएनडीटी एक्ट है, अभी ये एआरटी बिल है। मेरा बॉम्बे में एक नर्सिंग होम है, और ये नर्सिंग होम चलाने के लिए मुझे 27 लाइसेंसेस और रेगुलेशंस फॉलो करने पड़ते हैं, 27। और इसमें से काफी सारे एनुअली रिन्यूएबल है। आप सोचे कि अगर पब्लिक प्राइवेट पार्टनरशिप जो वे फॉरवर्ड है, नीति आयोग भी मानता है शायद कि पब्लिक प्राइवेट पार्टनरशिप वे फॉरवर्ड है, तो आप थोड़े नॉन फाइनेंशियल इंसेंटिव्स के बारे में क्यों नहीं सोचते हो? जैसे हमारे 27 लाइसेंसेस और एप्लीकेशंस, अगर एक सिंगल विंडो आप बना देंगे और कहेंगे कि ये सिंगल विंडो आप जो डॉक्टर पब्लिक प्राइवेट पार्टनरशिप में पार्टिसिपेट करता है उसको ये सिंगल विंडो अवेलेबल होगा। तो ये सब इनिशिएटिव्स है पर्टिकुलरली ईआरटी बिल में जो बहुत जरूरी है इंक्लूसिविटी बढ़ाने की, क्योंकि इंक्लूसिविटी सिर्फ कम्युनिटी की नहीं होती, सारे स्टेक होल्डर्स की होती है। तो ये इंक्लूसिविटी आप प्रोवाइडर्स के लिए इंक्लूसिविटी बढ़ाओ, रेगुलेटर्स के लिए इंक्लूसिविटी बढ़ाओ, और कम्युनिटी के लिए भी इंक्लूसिविटी बढ़ाओ। ऐसे लॉ सक्सेसफुल होते हैं ना। ये लॉ तो सक्सेसफुल होगा क्योंकि इसमें और कोई चॉइस नहीं है, लेकिन इसे और बेहतर बनाने में और इंक्लूसिव बनाने में और बहुत सारी चीज कर सकते हैं। और लास्टली एक लास्ट पॉइंट में कहूंगा एक ही मिनट में कि 10 से 15 साल तक ये लॉ का डिस्कशन चल रहा था, लेकिन जब ये लॉ आया तभी हमने ये देखा है, और ये हमने रेगुलर प्रैक्टिस में देखा है कि ये लॉ का इंफ्रास्ट्रक्चर अभी तक रेडी नहीं है। फॉर एग्जांपल स्टेट बोर्ड अभी तक बनाए नहीं गए हैं। आई डोंट थिंक एक भी स्टेट में, शायद एक पंजाब में बोर्ड बनाया था, लेकिन वो भी फंक्शनल है या नहीं मुझे पता नहीं है। इसकी वजह से काफी प्रॉब्लम्स होती है। जैसे आप कहते हो कि एक आप स्टेट बोर्ड अप्रूवल के बाद सरोगेसी करो, लेकिन स्टेट बोर्ड ही कहाँ है? तो अगर इतने साल लग गए थे लॉ बनाने में, तो कम से कम ये इंफ्रास्ट्रक्चर आप अगर तैयार करके बाद में लॉ प्रोमलगेट करते तो शायद इतने सारे क्वेश्चंस और कंफ्यूजन होते नहीं। या कम से कम हमें एक टाइमलाइन दे दीजिए कि बस भाई ये लॉ जनवरी में आया है तो अगस्त या नवंबर तक आपको ये स्टेट बोर्ड फॉर्मेशन हो जाएगा या आपका रजिस्ट्रेशन हो जाएगा। तो कम से कम हम पेशेंट्स को बता तो सकते हैं कि भाई आप रुक जाओ, आप नवंबर तक रुको, स्टेट बोर्ड फॉर्मेशन होने दो, रजिस्टर होने दो, तो हमें सारे अप्रूवल मिल जाएंगे और आगे हम काम कर सकते हैं। तो ये अगेन आई लेट मी रिआइटरेट, it is always better to have a law than work in a vacuum. Yeah. But at the same time, the law has to be inclusive for all stakeholders. You cannot concentrate only on the inclusivity of one group of stakeholders.
Thank you so much, Dr. Jaideep. It should be inclusive. It should be empowering for the people working in this space, people who are getting benefited out of it, both the community as well as the practitioner. Dr. Sivani Sachdev Gaur, your input on this, how do you see? Is it going to, kind of enhance the overall, standards of the care under this law, apart from these teething trouble which has been highlighted by all of them? How do you see, this one?
Thank you very much. आपने मुझे invite किया इतनी important meeting में. I'm very grateful. पहले जैसे डॉक्टर जयदीप ने बताया कि कुछ स्टैटिस्टिक्स आप कह रहे थे 40,000 सेंटर है। एक्चुअली अगर आप रजिस्ट्रेशन का बोर्ड देखिए तो 1,933 1933 सेंटर्स हैव अप्लाइड फॉर रजिस्ट्रेशन फॉर आईवीएफ इन द होल कंट्री। सरोगेसी के लिए 412 और एआरटी बैंक के लिए 370। ये एक्चुअल परसेप्शन में और डेटा में कहीं हमारा गैप है और शायद थोड़ा गैप वाइड है जिसे हमें नैरो करना है, जैसे डॉक्टर जयदीप बोल रहे थे और जैसे डॉक्टर पाई बोल रहे थे। लोग थाईलैंड जा रहे हैं कमल जी, क्योंकि मेरे पास सरोगेसी के केसेस आते हैं लगातार काफी। तो हर हफ्ते हमें पेशेंट्स बोलते हैं कि लॉ बन गया है बट पता नहीं कब इम्प्लीमेंट होगा, हमारी उम्र बढ़ती जा रही है, हमारा लास्ट चांस है, हम नहीं खोना चाहते। हम या तो थाईलैंड चले जाएंगे, जॉर्जिया चले जाएंगे, बाहर चले जाएंगे। इनका एक बच्चा है, उनको लगता है हमारा परिवार कैसे पूरा होगा, फैमिली हमारी सोसाइटी का बेसिक यूनिट है, वो अपना सपना कहाँ पूरा करेंगे, तो वो विदेश जाना चाहते हैं। तो ये बहुत ही इम्पोर्टेंट बात डॉक्टर पाई ने रेज की थी। कहीं मुझे ऐसा लगता है कि जैसे डॉक्टर जयदीप ने बोला एमटीपी पॉपुलेशन कंट्रोल है और आईवीएफ एक दूसरी डायरेक्शन में जा रहा है पॉपुलेशन के लिए, तो कहीं ये तो थिंकिंग नहीं है कि अगर ये इतना स्ट्रिक्ट हो जाए तो हम उस एस्पेक्ट पे ध्यान दे पाएंगे। आई एम नॉट श्योर। और कुछ चीजें जैसे मैम ने डॉक्टर नंदिता ने बोली थी कि पेपर पे सब बहुत अच्छा लगता है, बट प्रैक्टिकली क्या आपने पेशेंट से पूछा है वो खुश है? आर द पेशेंट्स हैप्पी कि ये लॉ आया है? क्या उनकी तकलीफें कम हुई हैं? कॉस्ट और पेपर वर्क इतना बढ़ गया है कि उनका खर्चा बढ़ेगा, तो क्या वो जेन्युइनली हैप्पी है, वो खुश हैं? तो बहुत सारी ऐसी चीजें हैं जिस पे हमें ध्यान देने की जरूरत है। थैंक यू।
Thank you so much, Dr. Gaur, and thanks for highlighting certain numbers. But the number which I quoted was from the Health Ministry's, kind of inputs. So, Dr. Madan Gopal, you have heard a lot of, so let me, I think we have also become so used to about using word industry. I will try to refrain from that. So you heard, the people from the fraternity, the practitioners and all. So first of all, as a public health expert, as somebody who wishes to fix the issues of public health, at large, and you have been trying to, through multiple contribution in multiple schemes in that space. Infertility has become a major challenge in our country. Now, this has multiple, contributors to it, and then it need to be addressed, at multiple level. IVF is one, or maybe ARTs are one way of addressing that, problem. Now, in this space, first of all, I would like to understand that how do you see infertility as a growing challenge, and like Dr. Nandita, kind of requested for or suggested that it should be considered as NCD, so that there is a better, attention from the policymakers to address this problem. So, on that side, and apart from that, as you have heard that जो law हमने बनाया है उसकी जरूरत बहुत ज्यादा थी, ये सब एग्री करते हैं, और आई एम श्योर इट हैज बीन क्रिएटेड विद द इंटेंट टू improvise the care for the people. It should also consider the factors which impact the kind of care providers as well, and I'm sure it has been considered up to a certain extent. But yes, there are multiple aspects which has been highlighted by them, and especially the aspect of perception versus data, or perception versus reality. Are we making act with certain biases in our mind, or we are making an act with a clear, open kind of mindset, with the inputs coming from all the practitioners? So I would like to hear from you in these two areas, infertility as a challenge, and how do you see country and then the policymakers, the government, trying to address this challenge? Have we taken infertility seriously, or we just want to regulate one industry which is called IVF?
कमल जी, थैंक यू। पहले तो एक चीज स्पष्ट करना चाहूंगा कि हेल्थ केयर हैज बीन अकॉर्डेड एन इंडस्ट्री स्टेटस। तो 2017 के जो बजट स्पीच देखेंगे तो उसमें हेल्थ केयर में इन्वेस्टमेंट्स लाने के लिए तो हेल्थ केयर हैज बीन अकॉर्डेड एन इंडस्ट्री स्टेटस। तो आपने जो कहा है कि IVF इंडस्ट्री इज नॉट रॉन्ग इन दैट, from that context, because in the document itself it has been accorded healthcare industry status. That's one thing. Second thing, IVF रेगुलेट करने की क्यों जरूरत पड़ी उसके बारे में हमें थोड़ा समझना चाहिए। जैसे आप देखेंगे जो एक ट्रेंड है, कोई भी ऑप्शन गायनी प्रैक्टिस करते हैं बिकॉज इनफर्टिलिटी काफी बढ़ रही है वेरियस रीजंस के साथ। स्ट्रेस फैक्टर बढ़ रहा है, आपका टैबैको यूसेज बढ़ रहा है, प्लस दूसरे अब्यूसेस भी बढ़ते जा रहे हैं, प्लस आपका जो सेडेंटरी लाइफस्टाइल है, लोग डेस्क पे काम करते रहते हैं। आप देखेंगे टैबैको एंड उसके स्टडीज चल रही हैं, तो उसके कारण दैट इज अफेक्टिंग द स्पर्म काउंट। तो बहुत सारी चीजें हैं उसमें। तो एनसीडी प्रोग्राम है, दे आर ट्राइंग टू एड्रेस द प्रिवेंटिव एस्पेक्ट्स ऑफ दैट। अगर आप जैसे कोई पब्लिक हेल्थ प्रोग्राम में देखते हैं, यू हैव टू बैलेंस बिटवीन द प्रोग्राम प्रायोरिटीज एज वेल एज प्रायोरिटी, लोगों की क्या प्रायोरिटीज है, जो ज्वलंत समस्या है पहले उसको देखेंगे, प्लस दूसरी चीजों के बाद में लेकर आएंगे। जैसे आप देखेंगे पहले जितनी भी बात हुआ हमारे जो नेशनल हेल्थ पॉलिसी है उसमें हम बात करते हैं प्राइमरी केयर के ऊपर 60% आपका खर्चा होना चाहिए, तो उस तरफ फोकस है पूरा का पूरा। प्लस आप जीडीपी का जो खर्चा देखते हैं, जो खर्चा प्राइवेट सेक्टर में बहुत ज्यादा खर्चा होता है, जो एक्सपेंडिचर ज्यादा होता है, लेकिन जो फुटफॉल है, यूटिलाइजेशन ऑफ सर्विसेज प्राइवेट गवर्नमेंट में दोनों में बराबर ही होता है। लेकिन गवर्नमेंट अपना एक्सपेंशन कर रहा है, आप देखिए कैसे एम्पावरमेंट करना है, तो उसके कारण स्कीम्स चली हैं। ये थोड़ा कंटेस्ट समझेंगे देन यू विल अंडरस्टैंड कि आईवीएफ में गवर्नमेंट क्या कर रही है। जैसे आप कंटेस्ट देखेंगे कि हम लोग ने यूनिवर्सल, जैसे हम लोग ने बात किया था यूनिवर्सल हेल्थ केयर के हम लोग सिग्नेटरी हैं, उसकी तरफ ले जाना है तो फाइनेंशियल कैटास्ट्रोफ से लोगों को रोकना है, उनका जो फाइनेंशियल एक्सपेंडिचर उसके कारण वो गरीबी में नहीं जाए उसको रोकना है, दैट्स द फर्स्ट प्रायोरिटी। उसके कारण आयुष्मान भारत आपका पीएमजे प्रोग्राम है, आयुष्मान भारत हेल्थ एंड वेलनेस सेंटर वाला स्कीम है, प्लस आयुष्मान भारत में दो चीजें और जुड़ गई हैं, आयुष्मान भारत आपका डिजिटल मिशन एंड आयुष्मान भारत आपका हेल्थ इंफ्रास्ट्रक्चर मिशन, ये दो चीजें और जुड़ गई हैं उसमें। तो बेसिकली ये है कि जो गरीबों का जो केयर है, केयर शुड बी इजीली एक्सेसिबल टू दिस पीपल एज वेल एज अफोर्डेबल बाय देम, सो दैट इसके कारण उनका खर्चा नहीं बढ़े और वो गरीबी की तरफ नहीं जाए। जैसे आप एक एपिसोड होता है आपका कैंसर या हार्ट का, तो आदमी 10 साल पीछे चले जाता है, अगर मिडिल इनकम जैसे पाई साहब ने बताया, वो 10 साल पीछे चले जाता है उसका पूरा परिवार। तो उस कैटास्ट्रोफ को रोकने के लिए बहुत सारी स्कीमें चल रही, उसीलिए जो मेजर फोकस है आपका एनसीडीज में, तो प्रिवेंशन ऑफ द डिसीज, उसमें सब कुछ है आपका, जो टबैको कंट्रोल प्रोग्राम से लेकर सब कुछ है जो कंट्रीब्यूट करते हैं। आपके डायबिटीज का प्रोग्राम है, हार्ट का प्रोग्राम है, कैंसर का प्रोग्राम है, उनके प्रिवेंटिव एस्पेक्ट पे ज्यादा फोकस किया। लेकिन साथ पे साथ जब क्योंकि इनफर्टिलिटी की समस्या आ रही है और जो बेसिक राइट है आदमी का कि आपके फूड, शेल्टर एंड प्रोक्रिएशन, जो बेसिक इंस्टिंक्ट है, बेसिक इंस्टिंक्ट से आप बच नहीं सकते। ये बहुत सारा अभी तक के क्या है, बहुत सारे मैल प्रैक्टिसेस स्लीप इन हो गए थे सिस्टम में। जैसे टांग साहब ने बताया कि 10, 12, 14 सालों से बातचीत चल रही थी कि इसको कैसे रेगुलेट किया जाए। तो परसिव्ड perception at the central level and the data and what is the requirement of the providers, दोनों में मैच और बैलेंस करना बहुत मुश्किल काम है, इतना आसान नहीं है। स्वतः से अगर रेगुलेट करते हैं, जैसे बाहर के देशों में चेंबर ऑफ डॉक्टर्स के चेंबर रहते हैं, वो अपने स्टैंडर्ड्स और अपना रेगुलेशन खुद करते हैं, सरकार कम काम करती है। लेकिन यहाँ पे क्योंकि लोगों के हित के लिए यू हैव टू रेगुलेट द सिस्टम। हमारा जो इंडियन सिस्टम है इज अनरेगुलेटेड सिस्टम, प्राइस भी अनरेगुलेटेड है, सिस्टम भी अनरेगुलेटेड है। काफी कोशिश किया है हम लोगों ने भी कि सिंगल विंडो लाइसेंसेस भी बहुत सारे हैं, राइट फ्रॉम पोल्यूशन वाले 27 उन्होंने कम गिनाए, 27 से ज्यादा लाइसेंसेस लगते हैं एक नर्सिंग होम या क्लिनिक चलाने के लिए। तो उसको सिंगल विंडो के लिए भी कुछ वो काम कर रहे हैं, लेकिन सिंगल विंडो जैसे जैसे इवॉल्व होगा, मैच्योर होगा सिस्टम, अभी सिंगल विंडो में एक जगह में सबके लिंक्स दे देते हैं, वहां से आप करिए। सिंगल विंडो को समझने में भी थोड़ा टाइम लग रहा है, लेकिन सिंगल विंडो की तरफ हम लोग आगे बढ़ रहे हैं कि एक ही जगह सब कुछ हो जाए अगर काम कर रहा है तो। एक तो वो अलग बात है। जो क्लिनिकल एस्टेब्लिशमेंट एक्ट बना था जो रेगुलेट करता है, 2011 से है, उस फॉर्म में बहुत सारे स्टेट्स ने अभी तक अडॉप्ट नहीं किया। रेगुलेशन बनाना एक अलग काम होता है, रेगुलेशन को इम्प्लीमेंट करने के लिए वी हैव टू बिल्ड कैपेसिटीज, वो धीरे धीरे बढ़ती हैं, एक दिन में बनाकर सब कुछ नहीं हो जाता। जैसे एक्ट आएगा, जैसे गवर्नमेंट कैसे काम करता है समबडी अंडरस्टैंड, एक्ट आएगा, रूल्स बनेंगे, रेगुलेशन बनेंगे, उसके बाद बजट का प्रावधान होगा, उसके बाद फिर वो इम्प्लीमेंट स्टार्ट होता है। साथ साथ में उसका टेम्पररी व्यवस्था भी रहती है। अभी जैसे एक्ट बना है, ART एक्ट बना है 2021 में, उसके रूल्स बने हैं, रेगुलेट हुआ है, उसमें मुख्यतः प्रोवाइडर्स की भी बात करी है, पेशेंट्स की भी बात करी है और रेगुलेटर की भी बात करी है। तो क्लिनिक्स के लिए जैसे स्टैंडर्डाइजेशन ऑफ वर्क फ्लो, अभी तक की स्टैंडर्डाइजेशन वर्क फ्लो नहीं, कोई बोलता 60% मेरा सक्सेस रेट है, भाई साहब ने बोला कि अगर देखेंगे डेटा देखेंगे तो 30-35% सक्सेस रेट है। अगर स्टैंडर्डाइज वर्क फ्लो होगा तो कहीं भी वो अपना वो कराएगा, काम कराएगा, तो उसका एक रिजल्ट उसको पता है कि 30% मिलेगा या 40% मिलेगा। इट कैन नॉट बी 60%, 70%, 100% क्लेम बाय अदर्स। तो एक स्टैंडर्डाइजेशन ऑफ वर्क फ्लो आएगा, राइट फ्रॉम पेशेंट के काउंसलिंग टू फाइनल आउटकम जो होगा उसका IVF का, उसके बारे में बात होगी। देन उसके बाद एक और चीज जो एनेबलिंग प्रोविजन हुआ है कि हेल्थ इंश्योरेंस कुछ प्रोडक्ट्स अभी बन गए हैं विच कवर्स द covers this IVF, उसमें कवर होने लगे हैं। पहले नहीं होता था, अब करने लगे हैं। आप देखिए, दिस इज जो इंश्योरेंस पार्ले में यूज्ड टू बी अ फिजियोलॉजिकल प्रोसेस, वो हम लोग खाली असिस्ट करते हैं उसको। इज नॉट अ डिजीज कंडीशन। वो परसेप्शन जब तक के चेंज नहीं होगा कि डिजीज कंडीशन में है, हम लोग को इसी उसमें अभी थोड़ा सा और आगे काम करते रहना। फिर उसके बाद एक और चीज जो आई है क्लिनिक्स में, एटलीस्ट क्वालिटी, सब लोग बात करते जिसकी क्वालिटी अच्छी नहीं है, एटलीस्ट यूनिफॉर्म क्वालिटी वुड बी डिलीवर थ्रू मिनिमम स्टैंडर्ड्स ऑफ ART आपके इसमें IVF क्लिनिक्स के लिए उन्होंने स्टैंडर्डाइज किया। देन पेशेंट के लिए एक जो मेन चीज आएगी, पेशेंट के प्रोफेशनल काउंसलर्स मिलेंगे आपके IVF क्लिनिक में, दैट इज एंटायरली नाउ, पहले वो डॉक्टर से बात करें लेकिन प्रोफेशनल काउंसलर भी रहेगा वहां। तो उसके अलावा एक रिटन इन्फॉर्म कंसेंट की भी व्यवस्था है। पहले कहीं होता था, कहीं नहीं होता था, रिटन इन्फॉर्म कंसेंट होता था। क्योंकि हमें जितने भी हमारे जैसे स्टैंडर्ड्स बने हैं, देयर इज ऑल पेशेंट सेंट्रिक स्टैंडर्ड्स, लोगों का हित हो सके, लोगों की सुरक्षा हो सके। ऑल द एक्ट्स, ऑल द इवन जो NABH के स्टैंडर्ड्स हैं, दूसरे स्टैंडर्ड्स हैं, दे आर ऑल पेशेंट सेंट्रिक एंड पेशेंट सेफ्टी के ध्यान में रखते हुए बनाए जाते हैं। दैट्स द होल फोकस। उसको कैसे एनेबल करना है, कैसे इवॉल्व होना है, साथ साथ उसी के चलना है ताकि बैलेंस हो सके दोनों चीजें। देन उसके बाद ग्रीवांस रिड्रेसल मैकेनिज्म की भी काफी अच्छी व्यवस्था करी। अभी जो ग्रीवांस रिड्रेसल का ज्यादा उतना कोई मैकेनिज्म है नहीं, इट इज बिटवीन द डॉक्टर एंड द, कोई ऑर्गेनाइज्ड मैकेनिज्म नहीं है। धीरे धीरे जैसे अभी इवॉल्व होगा, अभी नोटिफाई हुए हैं आपके रूल्स नोटिफाई होकर इंप्लीमेंट होंगे, इन अनदर फ्यू मंथ्स यू वुड बी सीइंग दैट द स्ट्रक्चर्स वुड बी इन प्लेस और अल्टरनेटिव मैकेनिज्म वुड बी इन प्लेस। देन एज ए रेगुलेशन एक ऑथेंटिक नेशनल रजिस्ट्री क्रिएट हो ताकि हमें डिसीज बर्डन समझ में आएगा। मोमेंट ये बर्डन ज्यादा आएगा, देन उसके बाद पब्लिक हेल्थ प्रायोरिटी में आ सकता है। जब तक वो डेटा नहीं होगा, वी कांट टेक अ कॉल दैट कि पब्लिक हेल्थ प्रायोरिटी है या नहीं। अभी प्रोवाइडर बोल रहे हैं अच्छा, हमारे पास दूसरे भी आते हैं, वो भी बोलते हैं कि ये हमारा आ जाए। तो यू हैव टू सी दैट जो बर्डन जो आ रहा है, जिसपे हमें ज्यादा फोकस करना है, जिसमें ज्यादा से ज्यादा लोगों की सेवा हो सके, यू हैव टू फोकस ऑन दैट एस्पेक्ट्स। देन उसके बाद एक आयुष्मान भारत डिजिटल हेल्थ मिशन आ रहा है, जिसमें अभी एक ब्लूप्रिंट तो हम लोग ने 2 साल पहले बना था, ब्लूप्रिंट अभी इंप्लीमेंट हो रहा है डिजिटल मिशन का। उसमें एक पेशेंट आईडी क्रिएट हो रही है, डॉक्टर की आईडी क्रिएट हो रही है, प्रोवाइडर की आईडी क्रिएट हो रही है। और पेशेंट की आईडी जब क्रिएट होगी तो उसके साथ इलेक्ट्रॉनिक हेल्थ रिकॉर्ड, जो हमने 2011 में बात किया था, उसमें आपके एस्टेब्लिशमेंट एक्ट में कि हर अस्पताल एक इलेक्ट्रॉनिक हेल्थ रिकॉर्ड बनाएगा, वो इलेक्ट्रॉनिक हेल्थ रिकॉर्ड इसके साथ बनाएगा। प्लस उस समय हमने ये स्नोमेट सीडी जो क्लासिफिकेशन होता है, उसका लाइसेंस भी लिया था कंट्री भर के लिए, लेकिन वो इम्प्लीमेंट नहीं हो पाया, क्योंकि वो आप समझ सकते हैं कि क्योंकि एक्सेप्टेंस ही नहीं रहा है एस्टेब्लिशमेंट का, जिसके कारण ये इम्प्लीमेंट नहीं हो पाया। लेकिन वो मंशा अभी भी है, अभी भी उसी तरफ प्रयासरत है। आयुष्मान भारत डिजिटल मिशन में आईडीज तो प्राय सबके बन गए होंगे, जितने वैक्सीनेशन लगाया है आधार कार्ड के साथ, सबको एक डिजिटल आईडी मिल गई होगी। दैट वुड बी ट्रांसलेटेड इनटू द इलेक्ट्रॉनिक हेल्थ रिकॉर्ड। वो हमें डेटा रिपोजिटरी और डेटा रजिस्ट्री बनाने में और मदद कर पाएगा। काफी काम होना है इसमें, बट लेकिन प्रोवाइडेड इट इज ब्रॉट टू द मेन स्ट्रीम, सेइंग दैट दिस इज अ problem of the masses, and public health and the government intervention is required to address this issue. जब तक कि वो डेटा नहीं आएगा, जब तक कि वो डेटा जनरेट नहीं होगा, एनालिसिस नहीं होगी और पब्लिक हेल्थ प्रॉब्लम नहीं बताया जाएगा, जब तक कि हम लोग को ये देखना है कि कैसे पेशेंट सेफ्टी के हिसाब से इसको आगे बढ़ाएं। तो आई विल स्टॉप हियर ओनली।
थैंक यू सो मच डॉक्टर मदन गोपाल, आपने बहुत डिटेल में इसको डिस्क्राइब किया, एंड आई एम श्योर एंड ऑल ऑफ अस हैव kind of appreciated and agreed that there was a need of such an act, because that's where you start, kind of putting things in the mainstream, and also, and obviously, as the data will keep rolling in, there will be modifications or add-on needed, and they will keep coming. One small point was, kind of coming to my mind, that when you said that the public health is primarily addressed towards taking care of the major issues which the people are facing, especially reducing the possibility of catastrophic healthcare expense, which they have to come across for many things, and it can be cancer, it can be heart attack, or many things. But what we have seen, and that's what when talking to various practitioners, somebody who is suffering from, let's say, infertility, that may become the biggest issue for that family or the individual, and may also lead to some kind of catastrophic expenses, where we have seen people and all of the doctors here can share the stories, from ready walas to rickshaw puller to trying to pull together some money somehow to get that, because this is again this is something which is very, very human. Procreation is something which is which is important for the overall mental health of the people also. Now, many of these diseases, this is also coming because of the many of the other diseases which are the public health, let's say, priority for that. We also see that certain government schemes, like for example, your CGHS, do have provision to support IVF treatments. Certain states have kind of volunteered or came forward and have started covering it. Some government hospitals like AIMS is providing a much more subsidized care. So when it comes to, even if let's say we have less data, but we do understand that there are enough numbers rolling in from here and there from multiple reports, and because of multiple factors. What is the one step which can be taken by the government towards ensuring that those who are suffering from this problem also get supported? Because it also becomes a little bit of discriminatory that CGHS gets this, others may not. If it can be a priority under CGHS, it should be the priority for others also. Maybe the mechanism can be different. How do you see it as a public health expert?
You see, Kamalji, it's a very, very, very tricky question. One way we are grappling with the issue of population explosion. ठीक है, तो उसके बारे में कुछ करने की बात कर रहे हैं. तो गवर्नमेंट इज ग्रैवलिंग वी आर ग्रैवलिंग विद द इशू ऑफ पॉपुलेशन एक्सप्लोजन. तो उसके बारे में सब बात कर रहे हैं, पॉपुलेशन बिल की भी बात कर रहे हैं. एंड द सेकंड टाइम यू आर ट्राइंग टू प्रमोट कि ये दिस चॉइस शुड बी देयर, दिस शुड बी राइट,
at least one child for every couple.
वो तो ठीक है. दिस इज, मैं उसीलिए इनिशियली जब बात किया था, तो इज अ बेसिक इंस्टिंक्ट. प्रोक्रिएशन इज अ बेसिक इंस्टिंक्ट, आप कोई मना नहीं कर सकते. कोई चाइल्ड चाहता है तो उसके बाद CGHS में क्या ऐसा कंट्रीब्यूटरी स्कीम, दे हैव टू कंट्रीब्यूट, एंड दैट्स व्हाई दे कुड इन्फ्लुएंस फॉर गेटिंग द ट्रीटमेंट हियर. बट इन द आयुष्मान भारत अदर थिंग्स, अनलेस सम डेटा इज देयर, सम रिक्वेस्ट इज देयर दैट दिस नीड्स टू बी सपोर्टेड, जिसके कारण ये नुकसान हो रहा है.
Small point. Even I believe the private insurance is also a contributory scheme only. No, we contribute to get covered.
Private also, private they are contributing for the Ayushman Bharat. Is the government is paying for that. The state and the center are paying for the people. And उसको जैसे आपके यहाँ 100 रुपए है, 100 रुपए में आप क्या करोगे? 100 रुपए में आप जो आपकी मेन इंपॉर्टेंट चीज है उसको देखोगे, या फिर जिससे आपके 1000 लोग का इलाज होता है, या फिर 2-3% लोगों का देखोगे आप? You have to focus, you have to prioritize your money accordingly. It's not that जैसे डेटा आएगा, पब्लिक हेल्थ प्रॉब्लम सामने आएगी, बहुत सारे आएंगे, तो I don't see that कि why it should not be considered that it should be a package can be made for. Till that time, जब तक कि हमारे ये आएगा एक्ट में, रजिस्ट्री बन रही है, डिजिटल बन रहा है, डेटा आने लगेगा, अपने आप ही वो डेटा will influence the policies and the governance mechanism. जब तक कि let us see that how it evolves.
Certainly, I think that would be the best scenario when the data start influencing and playing an important role in the policy making, and I'm sure that it's going to happen. Yes, but as a public, as a health enthusiast, as somebody who believe that every death from a preventable causes is too many, any suffering because of any health related issues is too much. I believe it is our responsibility to advocate for that, but I'm sure gradually we will reach to that state where we will be, kind of getting those important, kind of support from the government as well as the other agencies and organizations. Thank you so much for all of you for, being with us, keeping in mind that we are, kind of at the end of our allocated time for this session. I would like to, hand this over to Dr. Mahima Bakshi for the next session. And we were trying to, kind of understand, this was more focused on the ART Regulation Act, which has been, created last year. But there are multiple aspects associated with infertility as a challenge or as a problem which we are seeing in our country. Dr. Mahima Bakshi, who is a maternal child wellness coach and also a women right advocate as well as an author, will be hosting the next session about what are the causes of infertility which we are kind of facing at present, especially whether it is a lifestyle change or it is into genetics and it is underlying disease burden. She will try to kind of go deeper in that with another set of experts who are joining us on the second session of third IVF Summit, which we are hosting in partnership with BSV. Thank you so much, all of you, for joining us on this session this morning. And we believe that infertility is a disease, and the care for this disease will certainly be kind of reaching to all those who need it sooner or later. The fraternity is already working a lot on this. Government is trying to kind of facilitate that, but the gaps which we see will also be overcome sooner than later. Thank you so much, all of you.
Thank you.
Thank you.
Thank you.
Dr. Mahima Bakshi, over to you.
Thank you.
Thank you.
Good morning, ma'am.
Good morning, everybody.
Good morning, ma'am.
Good morning, sir. Good morning, ma'am. Abba, ma'am. Good morning.
Good morning.
Hello, Jindal, sir.
Good morning, everybody. Good morning.
Good morning, Jindal, sir.
In the morning in their clinics.
Good morning. Good morning, sir.
Hello, Deepak, sir.
Good morning.
Hi, how are you?
Am I audible? Okay. So, good morning, everybody. Hope you all are having a great Monday. And I welcome you all for the India IVF Summit organized by IVF Council. I'm Dr. Mahima Bakshi, a maternal child wellness consultant, women activist, author, and a communication specialist. We'll be discussing about different challenges related to lifestyle when it comes to infertility. So we'll start with the session. Let's discuss about lifestyle changes or genetic disorders, the reasons for rising infertility among the youth. I welcome all my dignitaries. So I take the pride in introducing them one by one. Dr. Abha Mazumdar, Director and Head of the Center of IVF and Human Reproduction, Sir Gangaram Hospital, Delhi. Dr. Vandana Hegde, Clinical Director and Chief IVF Consultant, Consultant Reproductive Medicine Specialist, Hegde Fertility Unit of Hegde Hospital. Dr. Deepak Goenka, Director, Institute of Human Reproduction, Guwahati. Dr. Sunil Jindal, Andrologist, Lab Surgeon and Scientific Director, Jindal Hospital and Fertility Center. Dr. Lakshmi Chiru Mamila, Consultant, Nova IVF Fertility Clinics, Hyderabad. And Dr. Nisha Bhatnagar, Medical Director and Senior IVF Consultant, Avea IVF. I welcome all of you to our panel discussion today. Thank you.
So let's start with talking about what are the common causes seen in today's time when we talk about infertility. And I present my first question to Dr. Abha Mazumdar.
Hi, Mahima. I hope you can hear my voice clearly.
Yes, ma'am.
Yeah. See, when we talk about infertility, we have to understand that it is always not a disease which is underlying as the reason of infertility. So broadly, we could say infertility could be because of male factors, it could be because of female factors, and then there is a subgroup which would be because of no factors which are known to us. There could be absolutely normal man in every respect and a normal woman in every respect, and yet they could present to us as infertility. So this is a very broad classification. Then we can go up to causes in the male starting from problems in sexual contacts to semen deficiencies in every respect, whether it's count, motility, or the structure of the sperm. And in the woman, it could go either her tubes are affected and they cannot transport the egg from the ovary to the uterus. Either they are blocked or they are stuck somewhere so that they cannot function. And they can be stuck due to any pelvic disease, any pelvic pathology where there are adhesions, endometriosis. And then maybe she doesn't ovulate regularly, or she just does not ovulate. And this also could be either reversible or irreversible. I mean, she could be made to ovulate with drugs, and there are cases where drugs will not work anymore. On the broad, I can only think of these many reasons. And if we go into nitty-gritties, we'll find many more reasons.
Thank you so much, ma'am. Yes. Now I would like to have my next panelist, Dr. Vandana. So, Dr. Vandana Hegde, ma'am, what do you think are the lifestyle changes linked with infertility in today's time? Ma'am, please unmute yourself.
Yeah, hi. Can you hear me?
Yes, we can.
Yeah. So putting across lifestyle, so there are two major components when we talk about lifestyle. One is the genetics that we are born with, and the other is the environment. So whenever we talk about lifestyle, we see people around the world now, lifestyle is changing for everybody. But we are seeing few people are getting pregnant, few people are facing difficulties in conceiving. So where do we draw the line? That means it is the susceptibility to the change. So some people probably are not able to cope up with the change, and that is probably the genetics and how the environment affects their genetics. So any exposure, whether it is the lifestyle, when you talk about sleep, for instance, some people can just sleep 2 hours, 4 hours like a Prime Minister Modi and then still function the whole day. But some individuals do want 8 hours sleep to be normal. So that depends on each individual's adaptability. When you talk about stress, some people can work in the most stressful environment and still be very healthy actually. So what actually drives this is basically probably the genetics and the susceptibility. So whenever you have an environmental change happening, I think it depends upon at what stage of their body the change is happening, what dose of the exposure they've had, for how long that exposure has been, and how best they can modulate it. See, the lifestyle, I think we cannot change because this is a fast moving world that we are in. But I think we need to identify today collectively and identify a few important things which has changed the scenario today, because what we as fertility specialists have realized that yes, infertility is increasing, and to come to it in both female and in fact even the male factors are increasing very drastically. Looking at the number of cycles that we're doing and the reasons that we're doing, male factor is also contributing to a lot of problems. So this is probably in this session we are going to come across so many changes in the environment and probably the genetics, which is a very good topic that we're taking out today.
Right, thank you, ma'am. I would also like to ask Dr. Deepak Goenka now, sir. So if we talk about lifestyle changes and we look at the effect of modernization and Western culture in India, and especially if you look at the corporate sector, lots and lots of MNCs are opening up in India, and the corporate sector is taking over, whether it's male or female. A lot of people nowadays are, having alcohol issues and smoke issues. And if you look at the percentage of people who are into smoking regularly or having alcohol regularly, so according to you, what do you think the impact of this is on male or female infertility?
Dr. Mahima, I feel you are hitting the nail at the right place. These are very, very important topics which are affecting the fertility of the couple. We had some data 20 years back, the incidence of smoking among the male and among the female. And today we live in a denial stage. If females doesn't smoke, females alcoholism among the female is less, or it is a taboo. No. There was a time we used to talk only the very lower middle class, the labor class used to take BDs, but no longer. Alcoholism and tobacco consumption, whether it is any class, it is rising. in one of the data 2 years back during the COVID time, it was shown that alcoholism and tobacco consumption among both the sexes, both the genders of the society in India, I am not talking about the Western country, is same. There is a drastic increase in the alcoholism and the tobacco consumption. The government is doing a lot regarding the tobacco consumption. Somehow alcoholism became a priority for the government also during the COVID time. We have seen everything else was lockdown, but alcohol shops were open the first. It was a source of revenue. That was very, very disheartening to see that. It is affecting the quality of the sperm. It is affecting the quality of the oocyte. These things are making a lot of difference, and we need a urgent measure to stop these things.
Dr. Mahima, can I add something?
Yes, ma'am, absolutely.
Ma'am, please. Ma'am, please.
Sure, you go ahead, Nisha.
I just wanted to add one thing, that not only the exposure, the starting point has also changed. Like, for example, in schools now, kids are exposed to. A few days back, in my daughter's school, she's in 11th, and they had a random check in the school for the bags and everything, and they found those e-cigarettes in the bags of many students. So it's not only earlier we were exposed to these things when kids were reaching colleges, but now they are exposed to these things because of internet, because of Instagram and all that. They are exposed to these things, and they are available in schools as low as high school. Ma'am, please go.
I have just one thing to comment, that I think late marriages or postponing childbirth is the biggest problem which is coming to us for IVF today. And they just go on postponing having a childbirth by the time the ovarian reserve is gone, or they have developed diseases like endometriosis has advanced, or if they had a small fibroid that has grown out of proportion. So according to me, it's not only late marriage, it is also marriage at the right time, but postponing a child. My own children postponed it till they developed fibroids, which I had to remove before they could get pregnant. I mean, they just said 5 years we need to take to know each other. So these are very important problems in my mind, that what is happening to the newer generation, which we are talking about. However, the villages are still not susceptible to these changes, and so they don't need IVF for aging related causes. It is mostly the urban population who comes up with this, and including what Nisha said, smoking, early smoking, it's lifestyle, it's fashion, it's Insta picture or whatever they want to post, looking at their parents doing the same.
Just continuing what ma'am is saying, just sharing my experience. I started my practice in year 2000. At that time, the age group, the patients who used to come to our clinic used to be somewhere between 26 to 28. Today, majority of the patients which comes to our clinic is between 34 to 36.
35 to 40. Girls are getting married at 40, and then at 41 they arrive that
all
they
of
want
us
to
seeing
the
a
child.
visible transition among our patients age group itself. Jindal sir, you have to
but one thing,
unmute.
sir.
Yes, please go ahead. I'll speak after you.
No, one thing what I am getting a lot of patients coming is with early thelarche, early puberty. So we are now still dealing with this infertility population. But there is a younger generation which is probably changing faster to this reproductive endocrinology. You know, there is definitely something happening there. We need to address, because I think infertility is what the next generation is getting ready for. It's going to probably shoot up a lot.
Yeah.
That also, Dr. Vandana, is because of the early exposure to all these things. Like nowadays, even a 6-7 year old knows on Instagram that what is menstruation, how, they have been exposed to all those. I don't know if it's right or not, but the material is available at the click of finger.
Very importantly,
maybe this is a good change, Nisha. Maybe this is a good change, that girls are aware of menstruation. They don't hide it in their families. They know how to handle it. I mean, whatever age they get it. I think it's a welcome change that girls know about menstruation before they start menstruating.
a few lifestyle changes which are very pertinent and very simple, which have happened in the last couple of years in men, as well as the boys and the girls. One of them is weight. Second is the quality of the food. Weight has increased. Now, the basic weight of most of the people, especially in the urban population, has increased. And this weight is a major factor. Number two, the type of food you eat. Food which was eaten earlier was basically fiber diets with very little trans fats. Now, most of the...
Homemade food. That was homemade food. Now it is...
Homemade food. So I always tell the patient that in case you need to change your diet, आप ये सोचिए कि आपकी दादी क्या खाती थी और आप वो खाना खाना शुरू करिए. 3. Sleep. 7 to 8 hours of sleep is very, very important for the hormonal levels to be okay, for the cortisol to be okay, for the testosterone level to be okay. 4th, just like was mentioned about alcohol and smoking. I mean, alcohol and smoking has become a lifestyle, I would say, issue. I mean, no party without alcohol is a good party. And if you are smoking now has decreased, but that has been in most of the populations, especially the semi-urban populations and like in the city in which I am.
Smoking has reduced, but
eating gutka and tobacco has increased. So what happens is कि पिताजी के सामने आप सिगरेट तो नहीं पीते, पर आप फादर से कह सकते हैं कि 2 दाने पान मसाले और गुटखे का मुझे भी दे दीजिए. And acceptability, the way it is in people. The 5th important thing which has happened is pollution. Very severe river pollution, groundwater pollution, chemical pollution, and pollution even in the environment as say air pollution has increased the level of oxidation, not only in the male gametes, but also in the female gametes. If you look at the population which has polycystic ovarian disease now, in which, if you ask me very honestly, the oxidation level in the ovaries around the follicular fluid for these eggs is much more. It is all affected by the lifestyle. In fact, I was reading this beautiful literature, and I was reading this beautiful literature on ashwagandha. And why was I reading it? I'll also tell you that. Because so many patients would come to me and ask me about ashwagandha. And I always, till the last 3 years, used to think, khana hai to khao, nahi khana mat khao. I don't know anything about it. I'm not interested. But when I went through literature and I found out that this particular herb, which has been eaten for so many years, 3,000 years till now, is actually magical. That's when I made this video on my YouTube channel, which has become viral. I think in the last 2 months, is about 3 lakh people have watched it. And I started eating ashwagandha myself after procuring those roots. So food, lifestyle, something which you can take as a healthy diet, food with fiber, jaw, bajra, homemade food, like Dr. Abha said. Let me be honest, how many people want to eat homemade food now among the young population? But in the villages also infertility is increasing. And it is increasing mainly because of pollution and the quality of food they are able to get.
So, sir, two important points that you've mentioned here, which is going to, make me ask my next question here, is that what about these protein supplements? A lot of men these days want to get into bodybuilding, are going into regular gymming, and are compelled to take protein supplements because their coaches are telling them to take protein supplements to boost up their body. What is the impact of these protein supplements on male fertility?
It's a beautiful question, because most of these protein supplements are, I would say, laced with testosterone. And most of them are not good quality. I mean, the packing is beautiful. They have every kind of beautiful muscles on them. So when these are laced with testosterone, and in a lot of gyms, in fact, I wrote 2 articles on this, in a lot of gyms, it's a routine to have gym weeks, steroid weeks. I visited 3 gyms and I asked people. So what they do is they have a week of steroids where there is somebody who coaches them on how to take all these nandrolone acetates with proteins. Now these extra testosterones which are taken, they knock off the testosterone which is made by the body, and in turn lead to low sperm count, impotence, and every kind of problem. So protein supplements is a big no for anybody. And I think it's a very pertinent question which you've asked. And for whoever are watching this, मैं हमेशा कहता हूँ कि शरीर इतना तगड़ा और स्पर्म इतना कमजोर. आपको याद होगा एक फॉरेंस का ऐड आया करता था बहुत पहले. मैडम ने सुना होगा, फॉरेंस का ऐड होता था कि शरीर इतना तगड़ा और दांत इतने कमजोर. In fact, that's just the way it is. When somebody walks into the clinic who is well built, massively built, लेकिन उसका चेहरा उतरा हुआ है, तो 2 मिनट में समझ में आ जाता है कि ताकत कहीं और है और कहानी कुछ और है. So this is what exactly happens with these men.
Right. Thank you, sir. My next question for Dr. Lakshmi. So, ma'am, since sir was also mentioning about that infertility exists in the rural sector as well. So what do you think would be the major difference in the causes between the urban sector infertility and the rural sector infertility?
And slowly, even the rural sector is taking the flavor of the urban sector. They are changing their lifestyles. They also have these joints where they get their curries from. Added to all this, from the urban sector, I think it's the pesticides. Excess pesticide use in the rural sector by the farmers. Most of the patients who come from the rural background, they are mostly farmers, and they tend to do farming, and they are exposed to these pesticides. So this is one of the causes for male infertility or female infertility. For that matter, if we do IVF in these patients, the quality of the sperm or the egg is quite low when compared to the urban population. Most likely, though we don't have much studies about this, but it could be because of the pesticide, high pesticide use, and also, as sir told, it could be because of the population pollution, air pollution, and also the water pollution that happens in the rural and urban areas as well. And when you look at the urban population, we should also talk about the selective estrogen receptor modulators that we see, or that we are exposed to day in and day out, starting from the aftershave that the male uses, or the perfume we use, or the the makeup we use. All of these have some of these components that might affect our hormones. Our hormone modulation will be done by all these agents. And because day in and day out we are using all this could also be one of the important causes, like how Dr. Vandana was talking about premature tilarchy, premature menarche. These are also one of the factors that are causing all these problems. And also they increase the risk of PCOS, increase the risk of endometriosis in women, and reduce the sperm count in the males. So we have to look at, while looking at the lifestyle, I think we have to look at these parameters also. We have to educate our patients, our youngsters also, about the effect of all these on the life, on the health of themselves.
Right.
Dr. Mahima, may I just add one more point here?
Yes, sir.
As everybody was talking about the early menarche, Dr. Lakshmi was also talking, Vandana ma'am was also talking, Dr. Nisha was also talking about the early menarche. Lately, it has been studied and found that post-COVID or during COVID, lot of young girls are getting early menarche. And one of the reasons which was found is sanitizers, hand sanitizers. Where we are using nowadays hand sanitizers left and right every time. We are encouraging hand sanitizer, yes, definitely. But we must also remember that these hand sanitizers consist of triclosan. There is a chemical called triclosan, which results into early menarche in female, as well as gynecomastia in male. So these are also some new factors which are coming up after this COVID.
Interesting. So since we've been talking about lifestyle changes and lifestyle modifications that is needed in today's time for people to take care of their fertility, related to lifestyle, one more question I would like to ask. This question is for Dr. Nisha Bhatnagar. So, ma'am, my question to you is that if we look at today's lifestyle, especially the food habits, or if we look at the sunlight exposure habits, a lot of people in today's time have vitamin deficiencies. If we talk about the deficiencies of these nutritional elements in the body, till what an extent are the deficiencies responsible to leading towards, I would say, maybe reversible infertility?
That's a very right question, because if we talk about vitamin D, if you remember, when I was in 12th or something, there were times when during winter, everybody, almost all the houses, they used to sit on the roof with the sun exposure, eating all those carrots and mooli, namak lagake and moongfali. Everybody used to do that. Nowadays, everybody comes out of the house, sits in the car, goes to the place, comes out of the car, and then goes back and sits in the car. And during that exposure also, we are using a lot of sunscreen on our skin. So definitely vitamin sun exposure is not there. We try to, we were supposed to be lucky that because of our skin, because of our melatonin, we were the, the good ones. We had a lot of sun exposure. But now if I'm checking vitamin D levels in the couples visiting us, 99% of them have low values. 99% of them, almost everybody. So this is one thing. Second thing is, as you rightly said about the food, also if we talk about our past, like 15, 20 years back, there were hardly a time when we used to go out and eat the outside food. Our food was balanced. There were spices, there were dal, there was turmeric, everything else was there in the food, made at home. So now there is, at the tip of the finger, the ma'am said that it is correct for, for the information and everything. But even if we had to go out, we used to take permission from the parents or something. Nowadays, you don't even know how many times the food is ordered at your home, sitting at home, it is delivered at the tip of the finger, at a click of the finger, and the children are eating that. So this is, science's literature has proven beyond doubt that vitamin D deficiency is associated with infertility. So if we want to correct that, I think we need to start right from the very basics, from the childhood. Though the information is there, teachers are teaching, teachers are telling the value of the food, nutrition. Yes, ma'am, please. Ma'am, please go ahead.
Yeah, I feel that yes, vitamin deficiency is very important, and iron deficiency known to be in rural areas because they don't, because of the financial status, they may not be having access to enough iron. But labeling a certain vitamin like vitamin D, there are controversial studies and evidence which comes out. So if a patient is thought that just correcting vitamin D levels is going to lead to fertility, or because vitamin D was not corrected, that is why the IVF cycle failed, this myth has to be taken out from their heads that yes, it's important, and it is more important when we are looking at pregnancy status, because in pregnancy, adequate vitamin D will lead to a good supply of calcium to the baby also. But before pregnancy and infertility, yes, all deficiencies could contribute to ill health, true, but it will affect the pregnancy more than an infertile woman or man. So we have to remember that. So take home message should not be that vitamin D agar kam hai, so don't take them for IVF, don't give them any treatment till you've replenished it.
No.
Replenish it, correct. If iron is low, hemoglobin is low, replenish it. For hemoglobin, I would say till she doesn't reach 9 or 10 grams, don't start infertility treatment. But for vitamin D, I wouldn't say that.
Ma'am, it is important to substitute. The replenishment is so easy nowadays. There was a time we used to test.
We are talking about lifestyle corrections here.
Yes.
What Nisha said is very good, that lifestyle has to be changed, that we need to get exposed to some sunlight somewhere. The Caucasians go and sit on the sea beach or any park and they expose themselves to sunlight. We don't do this because we may become more dark. We don't want to become dark. We don't like dark skin. But I think we need to expose ourselves also to sunlight like we did it in our early days.
It's also important when we expose ourselves, isn't it, ma'am? Like it should be between 10 o'clock and 3 o'clock. That's when we get most of our vitamin D synthesized from our body. So most of the experts say that it should be between 10 and 3. Not like in the morning, early in the morning. Most of us, if at all we get exposed, it will be early in the morning, between 6 and 8, where the synthesis of vitamin D will be very less. So definitely we should be exposed, but it should be between 10 and 3, and the maximum exposure shouldn't be there beyond the redness that develops on the skin. That is also important, because sometimes we think, okay, the longer we sit, that better it is, but it might not be good for the skin also. So that precaution also should be taken.
Absolutely. I think these are some great tips shared by all of you. Now let's talk about how we can reduce the burden of infertility in the society in India. So I would like to start with Dr. Aba Majumdar, ma'am. How do you think we can reduce the burden of infertility in the society in India?
We will have to start from the grassroots level and then move forward. If we talk about IVF or infertility treatment can reduce the burden of infertility, that will not work. So we have to improve everything when we talk about personal health and environmental health. And apart from that, genetics we cannot change. Yesterday I was in a chromosome microdeletion can now have a child and a boy will have the same problem. But then how did Y chromosome microdeletion come into our blood? It came through mutational genetic changes, which will continue to happen. So if we want to change, we cannot change our genetics. Right from the time our child is born, we have to stop overeating, we have to stop overfeeding, we have to stop junk. Homemade is a must. Early to rise and early to bed was a dictum which doesn't work in today's world because everyone is working online late hours. But yes, sexual contacts are so infrequent in infertile couples who attend my clinic. So we have to make, and then if they have it, they only have it on targeted days, which again makes the man go through a lot of stress to have a sexual contact. I'm jumping from one topic to the other, but it is such a vast topic that what can we do to improve? We can't change genetics, but we can change our lifestyle right from birth till this age by reducing junk, having more food, and by adding some physical exercise so that we can keep our weight almost if not normal BMIs or normal weights. And apart from that, late marriages, if there is a late marriage, try early for a pregnancy. Don't postpone pregnancy to more than 35 years. If you get married at 35, please just look at the initial factors, the male factor 1 ultrasound to see that all looks normal. And if all looks normal, then maybe you can postpone according to your professional priorities. But if there is a problem which you see, 3 is work is important. But if you're living together and you want a child, then it is important to be sexually active. This is the biggest problem I see because about their sexual activity, and the answer I get from 90% of couples is, oh, we know the fertile period and we only have can you hear me?
Yes, we can.
You can. Because Mahima has become still. I think her internet must be a little defective. So I feel that, frequent non-targeted sexual contacts are very important. Targeted sexual contacts impose a lot of stress to the male.
खाली मेरे को सुनाई नहीं, मैम फ्री हो गई है.
Yeah, I think it's ma'am's internet.
Yeah.
I want to add one more thing to this.
Yes.
But ma'am said correct. It's absolutely correct. But I just want to add another thing here is that again I think again the exposure to each other. Like earlier, whatever was happening was that after marriage it was happening. But now all those premarital sex and everything, people don't have an element of mystery. Everything is available on the internet. You can go through it. Then people, they are not interested in, usually even if it's a love marriage, they have been together since years. So there is that element of mystery is not there. They don't want to explore each other. It's like, they have been together since years. So the only time left is to have intercourse when you want to have a child. So this is another factor which has changed over the period of years. And maybe that is contributing to the infertility problem.
Yes, ma'am, you're back.
Mahima, with your permission, may I ask a simple question to all the senior esteemed faculty?
Yes, sir.
Abha ma'am is there, Jindal sir is there. Relevant to your question only regarding the prevention of infertility and late marriages, as ma'am was talking. How many of you feel there is a role of oocyte cryopreservation, selective oocyte cryopreservation in the prevention of infertility? Lately, we are getting a lot of patients lot of girls, unmarried girls, coming to us for the oocyte cryopreservation. It will be very interesting to understand the opinion of seniors here.
Dr. Abha, ma'am, you're back. Can you hear me?
Yeah, I can hear you now.
Yes,
I've just changed over from my laptop to my
To your
phone.
phone. Yes.
Yeah.
Ma'am, इसको horizontal
Yes,
कर लो,
can
full
I
screen
just hear the question again?
Ma'am,
Yeah, now Deepak.
Yes, ma'am. This is better.
Your question again, please. Thank you.
Role of oocyte cryopreservation among the unmarried girls in the prevention of infertility.
Let me tell you, we must have cryopreserved more than 100 for 100 girls oocyte. Maybe one has used them only. Rest of the girls, I don't know, they are waiting for what? They are waiting for the right time, right partner. So for social reasons, if you preserve, then the girl has to be very clear that she will come back to use. And one of my girls who preserved her oocytes became pregnant naturally. So all her oocytes are lying with us, and she got a partner at 40, 41. And she conceived. So there is a role, but how much is it going to be useful in future, we really don't know. At the present moment, over the last 10 years, we have preserved a lot of oocytes. They are all with us, barring for 2 or 3 girls.
Yes, Dr. Lakshmi. Yes, ma'am.
Yeah, ma'am, that is a very valid point. But many a times, what I have seen in my practice is many women come like at the age of 38 or 40. The ovarian reserve has gone down significantly. So one important point I want to mention here as a platform is that whenever they want to preserve, when they don't have a partner, it's better to preserve the oocytes early than later.
That is very correct.
It feels very sad to see these women coming up saying we didn't get a partner yet. We want to preserve our oocytes, but by the time they have lost everything, whatever could be preserved earlier on. So I would feel that this platform should be used to inform all the women who wants to preserve their fertility that the earlier the better. Maybe around the age of 25, 26 or 28. If they come
or Lakshmi, maybe by the age of 35, nobody thinks at 25 at preserving.
Yeah, ज़्यादा जल्दी हो गया वो थोड़ा सा.
But 35, 36 is the right age, not 40.
35, 36 in our Indian scenario, the ovarian
is already low. It's already
it's already they have missed the boat. So what I feel is at least they should start thinking about it. And at least they should start thinking about it, and they should look at their ovarian reserve. Even if they are not thinking of preserving, they should at least get an idea about how their ovarian reserve is and how they should plan their future, especially if they want to have a family and they want to have kids. They shouldn't come to fertility preservation at 38 or 40. That is the important message I want to.
I personally think, it's very true that oocyte cryopreservation, of course, is something which is very niche, in fact, very micro niche area. But apart from that, and it's a beautiful question which was asked by Dr. Deepak as far as this is concerned, but a lot of women need to be educated before they get an oocyte cryopreservation done. It's not that they come to you and you say, please go ahead with it. Age is a factor. When they would get married would be a factor. Would they really use it is a factor. But most these are factors which they have to be counseled about. But there is one very important thing which I think in the conversation we were having before oocyte cryopreservation came in was that people in their lifestyle as children need to be brought up. Dr. Abha was talking about it, how they should be brought up. Early to bed, early to rise, all those things are fine. But one thing which is important is sex education. Sex education is the primary thing which our country lacks. People do not have sex or only have sex at the time when they want to have a child. Normally, these men are overworked men of these corporates. Their testosterones are down. Their cortisol is high. These are men who actually libido is down. I have so many patients of this corporate sector in which the libido is absolutely down. You get their testosterone done, it is low. Cortisol is high. They sleep at the wrong time. Alcohol is rampant. smoking is, sexual affairs are present. They've been treated for infections. All these things are present in them. So my personal submission or thinking is that during classes, school, sex education is most important. Unfortunately, most of the schools do not have sex education, and the education is on the basis of mobile content, which actually desensitizes human beings to the education which should take place. So my feeling is, apart from lifestyle, which is the weight, which is the food, which is alcohol, smoking, which apart from that is burdens of sexually transmitted diseases, good sex, and sex education. These would form
Sunil,
a basis.
I would want to make
Yes, please, ma'am.
just one little thing. Sex education is important for both boys and girls.
Yes,
but
both
for
of
girls,
them.
it is more important because of but for boys, what is important is masturbation is not unhealthy. Discharging while they sleep is not unhealthy. Having sex with a woman is not unhealthy. Wearing a condom doesn't make them less desirous of having sex. That myth of wearing, so many women come and tell me my husband doesn't like to wear a condom, he's a diabetic and I always get this infection, whatever she has. So it has to be explained to them that you have to just try it a couple of times and you will get used to it and you will protect your wife whenever you want to protect, like you said, from infections or diseases or anything. So this education is important, but the youth today needs to be also educated. A lot of women come and they ask me, are we having sex from the right place? Can you examine me and tell me this? This is the extent of, I would say, not unawareness, but a lack of education in the youth. Some of them have this amount, they look so fashionable, they are so modern, and they don't even know whether they are having sex properly or not.
A patient came
So
to me.
all type of education is important. Growing up as a healthy individual is important. Having no vices is important, but then all these people do have children. So they are not absolutes. Whether they are smokers, alcoholics, they grow up badly, they have one targeted sex, everyone gets pregnant also.
I tell you why sex education is so important. The other day, sometime back, this patient came to my clinic and she was a young girl. She was about 24 and her husband was about 35. The husband had a second marriage. And she brought in the husband and she said, you've got to examine him. There is some problem with him and there's a major problem with him. So I asked him, what's the problem which you have? He said, I have no problem. I'm absolutely fine. Then she says that he takes very little time to discharge and it takes only 6 to 7 minutes to discharge. So I kept quiet and then I told her that the normal timing would be less than 5 minutes. What made you think that he's got to last longer? She kept quiet for a minute and she said, no, you are incorrect. Whatever I have seen on the internet is 10 minutes, 15 minutes. There is some problem with it. Now the problem, basically what has happened today is that sex education doesn't take place and the education is in the wrong fashion. And this also has become a major problem for fertility too. And this needs to be taken care of and schools don't allow it. A lot of
you can't stop the Google search of all these people. Google has become our prime educator today, Sunil. So that will always stay with us. You want to have good food, you go to Google, you want to go somewhere.
No, but Google is great because the YouTube is great to give sex education. I've made these videos which are fantastic and seen by so many. I'm so happy. But the problem is pornographic literature, pornographic movies, which every child has an access to.
Which you cannot stop. Which you cannot
do anything.
Yeah.
You cannot, and therefore they need to get proper sex education. That what you're seeing here is incorrect. These are all films. These are all edited films. Please, this is not the way it actually is. This is what education is.
Sunil sir, I will just share a small incident. I think few years back, educated couples in IT sector came to me. I was the second doctor, was referred to me. When I investigated, when I was taking the history, I did the investigation. Most of the investigations were done outside, and it was looking like an unexplained infertility. Everything was all right, and we were almost labeled them, yes, it is a case of unexplained infertility. While talking to them, suddenly they told, we don't really understand why we are not conceiving. We are having sex at the right time. He's discharging at the right place, and everything is all right. I said, what do you mean by right place? He was discharging on the umbilicus.
Oh my God.
So I just told them, please don't do that. Discharge inside and she conceived in the next month. So look at the ignorance among the educated couple also.
Absolutely.
So I think adding to this discussion, let's also talk a little bit about the genetics. So if a couple has had infertility, right, and they plan to have a baby through different infertility treatments, does it mean that there is a high risk of infertility in the children in future also? My question to Dr. Abha, ma'am.
See, we all understand that nowadays infertility, a lot of genetics is underlying infertility, and every day, every year, new genes are being discovered, and we are linking it with not just known disorders which are there today, like Turner's mosaic, Klinefelters and all, but even endometriosis, fibroid, PCOS, there are genes which are connected to these. So I wouldn't say genetic disorders are rising, but yes, the discovery of new genes is linking genetics to environment. Now, about passing of genes to the children. Now, suppose 40 years ago, Louis Brown was born. There was no IVF. Yet, we started discovering males with Y chromosome microdeletion. So they were born. How were they born? Either genetic mutation happened in them and therefore Y chromosome got a microdeleted segment, or the father was someone else. Whatever you may, interpret in those days. Now we have children who would be born out of these fathers, and that son would always carry a Y chromosome microdeletion, which would be of that extent or more severe. So when we treat people of known genetic disorders, then definitely that genetic disorder can be passed over to daughters or sons as disease or carrier status, which would again keep on passing. But then there is a other side of this coin also. IVF has advanced to a stage where if two thalassemic parents, minors, get together and make a child through IVF, we can screen out the carrier embryos, remove them, the diseased one, and remove them, and we can make them have a child with absolutely normal, non-thalassemic child, which in any case naturally also is 25% chance. And through IVF also, we will pick up those 25% embryos, which would be free of the disease. But we could eliminate a disease also by the use of ART. But genetic disorders will definitely be passed over to some extent, depending on whether it's a recessive gene or a dominant gene, whether it is sex-linked or autosomal linked. All this will decide whether the genetic disorder is going to pass over to the generation which is there. But then there are unknown genes also responsible for condition, and we know that PCOS mother has more likelihood of having a daughter which has PCOS. Mother has early menopause, again ovarian function will decline early for the daughter. Mother has endometriosis, the incidence is higher in family. So they have to be candidate genes responsible for these conditions. We need to find them. In near future, we will find them.
So I think a very valid point you've mentioned there, ma'am, because even a friend of mine, when she conceived, her the fetus was tested positive for muscular dystrophy. and hence she was told that in future, she needs to plan an IVF so that the genes can be selected and she can have a baby accordingly without muscular dystrophy. So I think IVF has a big role to play in such situations.
There are now so many diseases now. We can eliminate the disease from the family by selecting not a carrier embryo, but a disease-free embryo, especially in recessive conditions. Even in dominant conditions, we can do that.
Absolutely. I would like to present my next question to Dr. Nisha. So, Dr. Nisha, so in today's time, if we look at the prevalence of breast cancer, there are lots of young women also being, detected with breast cancer. And when they undergo the medical therapy for the treatment of breast cancer, there are studies that show that it can affect the fertility of the woman as well. So in that aspect, I would like to ask you the impact of such situation on fertility in women in India, especially considering women in their 20s and 30s who are suffering from breast cancer and are going through the awareness without having the knowledge of preserving their eggs before that.
I think the onus lies on the onco specialist. They should counsel them for going for at least their egg preservation. And nowadays we have come with such beautiful protocols that we don't have to keep waiting for the periods to come, or we don't have to, prolong this cycle. It can be done as early as within 2 weeks. There are random start protocols. We don't delay the treatment of the patient. We ask the patient to go for stimulation, and then we preserve the eggs. And then second thing, most of the breast cancer are like estrogen dependent, tumors. So we have protocols where we can use drugs in a way that they don't reach high estrogen levels in the body. So fertility preservation is a must for these females. It should be counseled. They should be presented with the choice at least when they are diagnosed, and they should be given the option of freezing their eggs before going for any treatment, because this is without a doubt that the chemotherapy and the radiotherapy and even the surgery, all that affects their fertility later on.
Absolutely. Dr. Vandana, would you like to add something to it?
See, what I feel about genetics, genetics, what we tell that it cannot be changed. There are two important things that happen when the environment is speaking to the body. So one is, endocrine disruptor. So this is a very important because today it is there in every part of our life. See, what we see, we can avoid. What we smell, we can avoid. But it is, I think, ubiquitously present all over our body. We are living in a hyper-estrogenic environment. When Dr. Sunil told about all the pollution that is happening, whether it is through the industrialization, through all the vehicles that we are using, the river pollution. So basically, the entire environment is filled with gases, and these gases are all estrogenic gases. Now, the male body, when it is there in an estrogenic environment, it undergoes genetic changes. This is called as epigenetics. So when the environment acts with the genes. So this epigenetics is nothing but, see, genes is what, it's like an on and off switch. Like you have a gene control for everything in your body, and the body functions. But how it should function, that regulation happens through the environment. So these are called as small mutations. These mutations then get transmitted to the other generation. Now, what happens when a lady is pregnant is, she is pregnant, so she has a baby within her, and the baby again has its own ovaries within it. So that is the reason they tell that whenever there is a pollution or an environmental effect, it affects 3 generations. It is not just that lady alone. It affects the baby and the next generation of eggs that are going to come out of that baby's ovaries also. So it's very important, because what they noticed when they used the DDT, which is almost removed today from the pesticides. But what they've seen is the soil is remaining contaminated for nearly 100 years after it has been used. So it's a very extensive damage that environment is doing. And we, I think, should bring out a very big change if we have to break this connection, because environment is definitely interacting. Regarding endocrine disruptors, yes, again, it is there in every part of our life, because see, it is there in the pesticides that was already mentioned, because it is coming through our food chain. And what happens in the food chain is there is something called bioaccumulation. That means every time it goes from one part of the food chain to the other, the concentration of these pollutions go on increasing. I mean, it increases in very high multiples. It is not just a small increase. So by the time it reaches the human, we are on the top of the food chain, today. So we are having an accumulated effect of all these contaminants there all around us. So these endocrine disruptors, actually, they affect the way hormones function in the body, whether it's testosterone or even the pituitary hormone, which gets
I think she's having internet issues.
Cancer are almost, I think, going on hand in hand. So probably these are the things that we should look at, probably go more organic. You know, the food that you eat should be probably more organic. Yeah. That we are using in our the washing clothes do contain a lot of pollutants. What we are using in our day-to-day life we are surrounded by pollution. So that is something that we should look at how to avoid. Because regarding mobiles now, whether radiation exposure, these are all ionizing radiations. So the use of microwave in our life, the mobiles in our life, how safe are we from all these? I think there are a lot of, and it's very difficult to do research in these areas because you have got a lot of confounding factors. So to come to any final conclusion, it's going to be very difficult. But I think we should become more sensitive to the environment around us, and probably, and it should be a collective effort. You know, one individual change. I think we as complete the humanity has to come across together to change the environment around us. Otherwise, fertility problems is going to take a major issues, especially with epigenetics. You're seeing a lot of DNA fragmentation index, which is definitely increasing in men, and this is definitely related to the genetics. It is not just about the environment or the lifestyle. There are genetic changes happening, which is becoming transgenerational transmission. So I think we should definitely be very.
So I think on that note, I would like to thank Dr. Vandana and all my expert panel here, because we would be wrapping up the session now. It's time for the next session to start. So I would like to thank everybody here, all the great experts, for sharing such great knowledge, for making this such a wonderful interactive session, and most importantly, discussing important points here, because we all wish to preserve the fertility of the future generation and the current generation. And I think lifestyle plays a very, very important role. As much as we need to save our fertility, we also need to save our planet. And I think if we try to save our planet, we are contributing in a lot of ways to save fertility of the current and the coming generation as well. So I thank all of you for joining us for this great panel discussion. And I would now like to invite Anisha, the next moderator.
Thank you.
Hand over the session to Anisha now. Thank you, everybody. Thank you.
Thank you so much, Mayana, for this wonderful discussion. So many of these issues resonate with everyone today. Because we go through these, even if we don't have fertility problems, even if we have a family, you can't run away from the pollution that is affecting you, that is affecting your children, and the lifestyle changes that we are seeing that are going to affect our health in the long term. Thank you all for joining us and sharing your views with us. Let's move on. Now, one would believe that when we are treating patients, it is their health and well-being that is the focus of the treatment. In real life, when it comes to ART treatment, decisions are predominantly made by professionals based on their diagnosis of the patient's physical condition and the medical condition, of course. Similarly, the clinical evaluation research primarily focuses on the effectiveness of treatment and conceptualizes outcomes from the standpoint of professionals rather than patients. Should this now turn on its head? Should patients' physical condition and their mental well-being be taken into account when deciding what would be the right treatment option for these individual patients? In this panel discussion, we'll be talking about empowered and informed choices towards a patient-centric approach in fertility treatment. So please welcome our esteemed dignitaries who are joining us to talk about this very important issue of patient-centricity in ART procedures. Please welcome Dr. Richa Jagtap, Co-Medical Director and Consultation Reproductive Medicine, ART Fertility Clinics. Please also welcome Dr. Pratap Kumar Narayan, Head of Department, Reproductive Medicine, Kasturba Gandhi, Manipal Hospital. Please welcome Dr. Manish Bankar, Medical Director, Nova IVF Fertility, Ahmedabad. Dr. Rohit Kutkutia, Medical Director, Nova IVF East. And Dr. Ratna Devi, Chair of the Board of Directors, International Alliance of Patient Organization. A warm welcome to all of you. Thank you all for joining us. Pleasure to have you with us to talk about this very important issue. All right. Are you able to hear me? Because I think some people are having an issue hearing me. Is there a problem or Okay, I'm going to go on, and if there is any problem, do let me know. So I'm going to start my question. The first question is to Dr. Ratna Devi. When it comes to ART treatments, is it a patient-centric approach, or is it more about, what you see clinically? Because most patients, they only know their problem. They don't know how they got there and how they will get out of it.
Thank you, Anisha, and thank you to the organizers for inviting me to this panel discussion. So, Anisha, to answer your question, the patient-centric approach starts after the patient reaches the hospital or a doctor. But very often the patients meander around before they actually arrive at the right clinic or the hospital. And our systems don't support, patients' decision to arrive at the hospital in the shortest possible time. Considering the environment that we live in terms of the myths and misconceptions around infertility, a lot of stigma around infertility, there are a lot of things that the couples do before they actually seek help. Apart from the fact that, most people think that infertility treatment is extremely expensive and is out of pocket in most cases because it's not covered by insurance. So patient centricity is not just a specific part where the treatment happens, but the entire journey of the patient. And that journey is currently not captured in our healthcare system. So I wouldn't call it very patient-centric. However, once the person reaches the right doctor and hospital, they usually get the correct advice and then things move forward. But reaching that hospital is the biggest challenge.
Right. Dr. Gurpute, do you concur with what ma'am is saying? Once you reach the right spot, then everything falls in place. Because then you're still in the hands of the expert, and the expert has an opinion in your medical condition. But who's going to tell me what is my medical condition? Are there options? Which is the best one for me? Once you reach the right space, you're in good hands, or is there still more that has to be done?
So, first of all, it's good to connect once again with all of you. To take this thread forward as far as patient-centeredness is concerned, getting the patient to come to the clinic is one part of the story, and I'm very sure Dr. Ratna pointed it out. But more than that, it is after that the patient connects with the system. I would not say the doctor itself, the whole system. That's when the centeredness of the patient comes in. And when we talk about patient-centeredness as far as the treatment, as far as IVF or infertility is concerned, because there are a lot of choices and there is no right and there's nothing wrong in treatment of a fertility patient. So that's when the respect for the patient's needs and the choices and fundamental values come into the picture. And to me, that is what is patient-centeredness, meaning you know what you want to do as a clinician or as a team who's providing the care, the healthcare provider. But when you make the plan for the patient, you factor in the patient choices as well, as far as is practically possible. And this is a way of working. This is how you work in your clinic. And that is what is patient-centeredness as far as I'm concerned.
Right. Dr. Richa, you heard what Dr. Rohit has said, what Dr. Ratna has said. Can you give me an example where you have shown patient centricity and, deferred to the choice of a patient, and where that may not have been medically the first, option for you? Can you give me an example?
So thank you, Anisha, for this opportunity and the question that you've posed to me. I think it is two factors. It can never be one thing. So what the patient wants is the crux of the issue, because that's why they have come to us, and that's the main thing that we have to consider. Whether they want fertility, whether they want it now or not, I may have 10,000 things that I can discuss with them, but first thing I have to take in account is what does the patient want? Because fertility is a very elective or optional treatment. It's not that the patient has come to me with the pain in abdomen that I have to treat them. More important is that we make sure what the patient wants. So if to give you an example, I had a doctor couple some years back, and they were young. The wife's AMH was low, and they were planning something about their fertility, but they were not sure that they wanted pregnancy at that point. The doctor herself was supposed to go for a fellowship abroad. And that's when we sat down and discussed together that
she wants fertility, not right now. We thought about making the embryos and freezing them because her AMH was low, her egg reserve was low. And we came to a decision that yes, this is a good way forward where we are respecting their choices of not being parents right now, but their option of keeping the window open for themselves so that they can think about having a biological child in the coming years. And that worked out very well for the couple. I think it's like there are three of us traveling in this boat, and without taking everyone's point of view in perspective, we cannot go ahead with fertility treatments. Okay, thank you for that example. But there are times when those decisions aren't very easy to make, isn't it, Professor Pratap Kumar? Because, the patient wants my child, my genes. But we are seeing that, perhaps the woman is not in a condition to carry the baby, or the husband's sperm count is very low. So then there seems to be some conflict on what is the best way forward and what the patient wants. Then what do you do?
Thank you very much for the question. I think as far as possible, any couple would like to have their own egg and their own sperm, unless it is a terribly imbalanced one. So I would probably convince them to try for techniques which can enhance fertility in our own eggs, their own eggs and sperm. But unfortunately, if the sperms are not there at all, in spite of doing all the tests, then we might offer the third party donor sperm. Otherwise, for a woman, I think up to, as long as the anti-Mullerian hormone is not too low, you can still try for her own eggs. I think that's where the counseling matters, because we have techniques where we can fertilize very low number of sperm count and low number of egg as well. So I think the initial thought and explanation should be that we try with their own gametes.
Okay, Dr. Manish, when we talk about fertility treatment, especially in India, the onus usually falls on women. So how do you make the treatment more of a couple-centric treatment in place of placing all the responsibility on the woman? Because many a times the stigma of infertility is all about the woman's inability to conceive.
I think this is a very valid question, but before I come to that, I think what we need to define on patient centricity is what do we actually mean by patient centricity? Does it mean that we do what the patient wants? No, that is not how you should define patient centricity. The other treatment as opposed to patient centricity is a standardized one-shoe-fits-all approach. So what patient centricity means, you need to individualize for every patient rather than using a cookie-cutter approach. So a patient might want something which is not indicated, which is not in her best interest, which is expensive, which comes at a risk, then you are not obliged to offer it. So patient centricity is to individualize the treatment based on the current medical evidence, based on your judgment, based on your evaluation of the patient, and taking the patient into confidence rather than forcing something on it. So, I mean, just going back to the previous question, if the patient wants her own eggs and sperms, but if her uterus is not fit to carry the pregnancy, or if she herself is not medically fit to carry a pregnancy, we have to refuse or offer alternative treatments. But coming to your question on male versus female, the husband and the wife, all data shows that in nearly 1/3 of the patients, it is the husband who is at fault. In another 10-15%, the husband is a contributing factor. And in another 1/3, it is the female alone. And in the balance is kind of an unexplained. So the only way to approach this situation is to involve the husband in the treatment, and the consultations and counseling have to happen for the couple versus only the female. And this stigma is gradually disappearing. It is decreasing, but in still the urban and the rural areas, it is still a problem. And the only way we can do this is to involve the husband rather than treating only the wife.
All right. I think Dr. Ratna Devi has a point to make. Ma'am, please go ahead.
Thank you. I just wanted to sort of elaborate my previous statement when I said patient centricity is not about just the treatment, but patient centricity is, patient-centric policies, patient-centric environment, patient-centric quality care, everything. And it doesn't stop with just a visit to the doctor. It happens before they visit to the doctor as well as after the visit to the doctor. So it's a care continuum pathway. And if you see how infertility is managed within the ambit of, say, maternal and child health care services in India, then infertility is not really top of the list. And very, very few couples actually seek medical attention for various reasons. So if, fertility treatment or treatment for infertile couples has to be made universally accessible, then patient centricity has to be built within the policies, within the healthcare environment, and within the health systems. And we are a very long way, behind. We have many, many steps, many miles to go before we actually reach that level where patients can, without any hesitation, seek medical attention and be able to receive it without having to struggle for it. That's what I meant when I said patient centricity is still not there in our country.
All right. I take your point, Dr. Devi, but what do we do till we get there? Because who's going to do this? Who's going to build the policy? If you keep waiting for the policy makers to make the policy, then you're waiting forever. But you still have to treat the patients till then, right? So, Dr. Manish, should there be a clear policy framework on giving all relevant knowledge to couples seeking therapy, including the cost, the effectiveness, the risk involved in the therapies, and the other issues by medical practitioners? Because, they're doing it. They're doing the job. They're delivering the goods. They should inform the patients what they're in for, because the patients only want the baby. They don't know the steps involved.
I think this is something which no individual person or association will be able to do it. This will need a multi-pronged approach. Maybe the first step in this direction is by the government formulating an ART Act, which has at least laid down the basic framework on how ART should be practiced. There is also the role of media in creating awareness. There is also the role of all professional bodies, which has to create awareness. And then it falls to the individual practitioners who will have to join in. So it would be a kind of a multi-pronged approach, and every bit of contribution from everyone who can help will definitely help. Having said that, things are improving. Today, with the era of internet, we are seeing a great increase in the awareness. So things are changing. Of course, they need to change faster than at the rate at which they are.
What do you think, Dr. Rohit? Do you think our policy framework is in place now that we have a new law? Or do we need to, on an individual level, as a practitioner of ART, make our own set of rules and explain to the patients what's in it for them?
I think Dr. Banker has set the tone rightly, that we were working in an unstructured way, and there's a structure that has been put in now. And of course, the media has been doing a lot of work on this, and conclaves like these also help, because the education part or the awareness part is happening quite a bit in the last couple of years. Having said that, it is on me as a practitioner to create an enabling environment, because however much we give out handouts to the patient, unless we have a culture where we encourage the patients to come in and ask questions without being judged, that to me is the most important part of, let's say, getting the patient involved in the treatment. She or the couple as such should be comfortable to ask questions and be answered with no bias or with no judgment on this. And then, of course, continually engaging with the patient. As Dr. Banker pointed out, it has to be a couple that has to participate in all the counseling sessions. In fact, even allow the husband to be present when the basic treatment procedures are being carried out, so that there is a sense of equal participation that gets built in. Helps to resolve interpersonal issues also. So these are things, and it has to be multifaceted, multi-pronged. But it has to be initiated by me, the clinician in my clinic, so that I can take the entire team along with me.
Dr. Richa, sorry, I'm coming to you with all the practical examples. On a practical level, how do you do it? You've got hundreds of patients, right? And then if each one you want to sit in counsel, then How will you follow up on the treatments and ensure that, everything is in place? In real life basis, how does patient-centricity work?
So, Anisha, yeah. So I think when we talk about patient-centricness or empowering our patients with the knowledge and their options, the first time that we meet the patient, it can't be a hurried discussion. It has to be a session which gives time for the patient to express their needs, their beliefs, their issues, their traumas, their journey of fertility, and then the consultant to examine and understand their medical issues so that there's a proper amalgamation of medical and social issues. And then once we have come to a conclusion on that, then the options can be enumerated by the patient. It cannot be a one-liner that the doctor writes down and says, start this medication. It cannot work like this. This is a very holistic approach that we take, and that's why the first consultation is very, very important. It should actually be at least 30 minutes so that you can understand the patient completely. And then there should be an option for the patient to address their further queries, their questions. And to that effect, counseling in an infertility center is very, very important and a crucial step. It will be done by the doctor as a first person because that's the first point of consult. But after that, an independent counselor who understands their beliefs, their fears, their hesitancies, and kind of handholds them throughout the entire process. So it's not just one point which helps the patient to get comfortable and understand and take a right decision. It's the entire team framework, and it's not at one day that it happens. It's throughout their journey through a fertility treatment. When they come in, when they start their treatment, while they're going through it, through their disappointments, through their hopes, and finally till the point that they can safely initiate their journey to parenthood with happiness. So it's a multi-pronged approach, and it's a long journey for some people, definitely. But as consultant, as medical care providers, we have to be available to these patients all the time. That's how we can judiciously say that, okay, we did the best for our patient. We gave them the choices. We understood their needs. Then we can make sure that the patients open up to us. That is when we see that the patients come forth with more questions, more queries. And that itself simplifies their path to it, because what we do not know, we always fear. What is explained to us and understood becomes more simpler and more easy to approach. Then fertility treatment or even IVF does not look like this big hill top that you have to conquer. It just becomes a path that you have to take.
All right. Professor Pratap Kumar, medicine has come a long way. And a lot of people are now talking of customization, a tailor-made program for a individual given the condition they are in. When it comes to ART treatments, how much of customization or individualization is present? Because some people believe, this is what happens. Step 1 is this step. Step 2 is IUI. Step 3 is IVF. And this is the rigmarole that everybody will go through. In your mind, how much of individualization is there? And this also then puts patient-centricity in focus.
Yeah, thank you. I think all the practitioners have to form their own protocols, and there are enough and more explanation for every protocol. So when a patient or a couple come to me, I would probably put them into the category of what next is the treatment. So before I do a 101 kind of investigation, I would probably choose the investigation. There is no need to do many investigations in this couple. So I think it starts right from the history-taking examination and the finding, which tells me what that couple need next, because everybody cannot be having IVF. And some cannot be having IUI. So there are some protocols. So we would probably, like a one-stop clinic, I would say, as they come for the first time, after counseling, I would tell them, you need that and you need this. So I think depending on the sperm count, we would probably counsel them. And definitely too many investigations at the beginning will kind of be very bad on their mind. And they would think that it's too much of expense is gone at the beginning itself. So I think we would be very carefully choosing the investigation, and it is customized. Every patient needs a different kind of evaluation and different kind of management. I think we should have a protocol for ourselves as to what has to be done next for each kind of a patient.
Okay. So it seems that ART treatments are actually quite customized and unique for each patient. Dr. Ratna Devi, what can the medical fraternity do? Do they need to do more so that the patient feels that I am the focus. I want something, but in the middle of the way, what happens to me is not irrelevant. Patient centricity is there. Do you think the medical community needs to do more?
So, yes, because the medical community is not just the IVF specialist or the fertility specialist. Very educated or not very educated, do not have the right skills, and may not be, taking the right decisions in terms of a proper referral. So, a proper referral pathway is extremely important. People who do not have the skill and then it does not end in a positive note, and then they lose hope and also a lot of money, and that brings distrust within the system. So I think what we need to do is to establish some kind of a referral pathway or provide the right information. Right now people seek information from Google or from similar internet something like that, or maybe word of mouth. So it is important that people have access to the right information, where to go, what to do, instead of meandering through the healthcare system and facing disappointments before they actually reach the right person, which is why I said once they reach a specialist, then everything is sorted. They know what they have to undergo and how much they have to spend. But usually people spend years before they reach the right specialist. So how can we create those pathways so that somebody who's looking for that information accesses the right portal or the right, the information channel, and then is able to reach the right hospital or the doctor, and then is able to, get the treatment that they wish to receive. So I would say the medical fraternity as a whole has a very large role to play in terms of each person's ability to refer the patient and give the right information. Also, specialists are very busy people. So if you have a referral pathway, follow up and counseling post procedures, because usually people go through a lot of mental health ups and downs, a lot of mood swings because of the hormonal treatments that are there, disappointments, and a lot of things within the family where there could be differences of opinion between the couples or the spouses themselves, and that needs continuous hand-holding. That is currently not possible in the context of our country, because you get your services as long as you're within the clinic. Once you step out of the clinic, you are on your own. So there has to be some kind of a system where maybe, a person can have a helpline or some such procedure where they can pick up if they have doubts, or if they're going through a low phase, they can pick up the phone and speak to somebody and get the support that they require.
So maybe a support group here will help. But Dr. Rohit, I want to ask you. Now, it is important that the patient knows what's coming up. But what is the value of empathy from the doctor? Because, you meet the patient first time, you explain the situation, you take the time, and you lay the road out to them. After that, there's somebody else holding their hand, helping them out, counseling them. When say a cycle fails, whether it's IUI or IVF, they're not going to go and ask the counselor, tell me what happened. They want answer from the doctor. Doctor की जवाबदेही है कि क्यों नहीं हुआ, मैंने आपको सारे पैसे दिए, आपने पूरा किया, मैं तो विलिंग थी, आपने जो बोला मैंने सारी दवाइयां खाई, फिर भी मेरा बच्चा नहीं हुआ. जिम्मेदारी तो आपकी है ना, आपने मेरे को ट्रीट किया. So at this position, how important is empathy? The odds are whatever the statistics tell you, but for the patient, that doesn't resonate. How important is empathy? Because science and statistics is there on one hand. How do you tell the patients that hold on, or show your empathy so that they don't feel that this is just a no, I'm just part of a factory, I'm just a nut and bolt?
It's a loaded question. I'll take some time to answer this. See, the point is, I would agree with Dr. Richa that the first counseling is a very, very important counseling. And if there is a connect that's happening between the clinician and the couple that's come for treatment, the connection is happening that day itself. And while we are going on that journey, or let's say we're talking about this couple's journey on that day, we are trying to make sure that she understands the risks, the treatment burden, the effectiveness of each of these therapies. And please understand, and this is something that is loud and clearly to be understood by everyone, that none of our therapies have anywhere close to even a 50% chance of having a pregnancy. So this is something that has to be established, and these I would say are the ground rules. They have to be established on the first day of counseling. We also talk about the costs or the reasonable costs that are associated, and there's this important factor called the time to pregnancy or time to a live birth. This is what the first day event is all about. For me personally, the moment we've actually decided on a therapy for her, for the couple, based on their inputs, and that is where patient-centeredness is for me is concerned, that they have gone through what we've told them, they have gone through the independent sources of information, let's say like Google, and they've come back and they've confirmed that this is the path that they would like to follow, whether it's their own genetics, it is donated genetics, it's all about their choices, first of all. And I don't intervene mostly as far as their choice making is concerned. So that way they're fully independent. But once they have chosen a path and we've agreed on that, then unfortunately or otherwise, I don't see myself as an empathic clinician. I'm okay to be there. I'm okay to talk to them. But I don't try and bring in any kind of an empathy here. It's a personal thing, and I'm sure the panel would have its own opinion on this. Personally, I feel if you bring in empathy, somehow you're trying to push through a treatment, and these are all expensive treatments. So whatever happens during the cycle is kind of very, very clinical in the figurative sense of the word. And post the cycle, once again, if there is a failure, and there are failures, of course, in our practice, then post the failure, then there is another meeting that happens, and that's where the empathy comes in. So it's kind of a switch on, switch off kind of a thing. First meeting is a long meeting. It kind of sets the ground rules, and then there's the process. And then post-process, there's another meeting, which we call the follow-up meeting. And it's during that meeting is that when we talk about what's the plan for the next time and so on and so forth. So this is what my understanding is.
Right. Dr. Manish, you want to come in here? Because, for most people, IVF is not just, or ART is not just about the money spent, the time given. It is about your hopes, your expectations. And when they come crashing down after a failure, you don't know what to do. At that point of time, many of them look up to their doctors, give them some kind of solution, or even show them a path forward. So what would you like to say?
I think this is the most important aspect of any kind of infertility, and for that matter, any kind of medical treatment, because every patient who visits a doctor will expect that there will be 100% success rate, or even if the success rate is 50%, I'll fall in the successful 50% only. So to me, two aspects to this. And again, this goes to the first meeting. And the primary aim of the first meeting is to set the expectations right. We need to make the patient realize what the problem is, what is a realistic expectation that she should expect out of the treatment, how much time it will take, what exactly we will do, how much it is going to cost. The second important thing is you cannot expect the doctor to do everything. In the IVF treatment, there is a doctor, there is an embryologist, there is a counselor who is specifically trained on the empathy aspects. There will be financial counselors who will counsel them on the financial aspect. So at the end of the day, the consultant is like the conductor of an orchestra who is in control of everything, but he does not have to play every piece himself. So maybe the first meeting is very crucial in setting up all this so that the patient, on the one hand, has the right expectation, knows what will happen, knows what she will have to undergo. And if there is not a desired outcome, she would have some reason to understand that at least the clinic or the doctor has done the best. I have also tried my best. But in spite of this, every treatment need not have the desired outcome. There is something which is much beyond this.
Yes, after all, there's the guy upstairs who controls everything. Bhagwan ka bhi haath hai is sab mein. Ratna ma'am,
If I can just put in a word there, Anisha, that when couples come to us, yeah,
Dr. Richa, I'll come to you. Let Dr. Ratna say something, and then I'll come to you. Ratna ma'am, please go ahead.
Yeah. No, I was just waiting for Dr. Richa to finish. Okay, thank you. I just wanted to say something, and play the devil's advocate here by saying that we work with two patient groups, PCOS as well as endometriosis. And pardon me for saying this because you're all great doctors, but somehow fertility treatment has been very glamorized. So most patients think that fertility treatment can be offered only in private sector. And that is why they, end up spending such a lot of money. Whereas that might not be true. So there is a severe lack of information on where to go if you need these kind of services. Also, maybe something should be done to build trust in the public sector hospitals so that patients who want fertility treatment can go there as well. And, provide some means of managing the cost of the treatment. Because from what we hear, at least from our endometriosis group, which is a very, very large group, most people just drop out of treatment because they cannot afford it after one or two attempts. And that brings a lot of disappointment. So I think we need to make it more, common man's problem than the super rich problem, if I can say that. And because fertility is every woman's dream, every woman wants to be a mother. At least I think so. I think it needs to be de-glamorized a little bit and brought it to the common man so that more and more people talk about it and there is more accessibility built within the public health system.
Right, but it's not the private sector's job to tell them, oh, you can go somewhere else and get it done cheaper. Other stakeholders need to come in there. Sorry, Dr. Richa, please go ahead. Make your point.
So when we were discussing about how to bring in empathy for the patients and how disappointed they would be, most of the patients, when they start this journey, understand the realities of IVF. They understand that it's not going to be magical, yes or no. It's going to be a path that they are taking. They understand the statistics. They understand their chances. They attend support groups and then they take a decision, which is a known decision. And then, like Rohit said, that it's a process, but while throughout the process, they still get an update whether things are going fine, whether things are not going fine, whether things are looking on the brighter side. And each and every point, what the clinician knows, the patient knows. So when there's complete transparency, their hopes are realistic. And they do not feel let down, even when there's a negative report. They do not feel that let down if they have understood the process completely, because as we know, the fertility chances are not going to be 100% in any group. I would love for all my patients to be pregnant, but that's not going to be happening. So as long as I've made my couple understand that this is the reality and that is a path we're going to take, and they understand that and walk on that path, I think this itself is an empathy-built treatment, and then their realizations and expectations are in the same bandwidth.
Right. Professor Pratap Kumar, there is science to it, there is statistics, and there is a way of handling your patients. But in our country, childbirth, family planning is not always only the couple's decision. Many of the decisions are taken by family members, and sometimes it becomes a very lonely journey for the woman. So the husband may be supportive or going along. She feels kind of left out because she's going to take the medicine. She will have mood swings. And sometimes some decisions may not be supported by the family. She will try to hide things. So, when we talk of the larger framework, not just the family, maybe even work, she needs time off, but she's not able to talk to her boss, take the time off to do it properly, in a peaceful, relaxed fashion. Do you think the medical community can do something here so that there is empathy for the woman going through in not just the medical setup, but her social setup as well?
Yeah, that's an interesting question. In this country of ours, I think I agree with you. The family also interferes. In fact, the first consultation, the big load of them come. Sometimes nobody comes. I see mother-in-law, mother, father-in-law, father, everybody is there first consultation. Whereas in another group, I just find the husband and wife coming. So there is a lot of different family support. The group which comes together, I think they are all supporting each other, or maybe interfering also. We can never say that. But I think when they come with a father and mother, we know that the expenditure also can be partly by them also. So that means there's a lot of support. But when they come together, just a couple, and they finally tell me, I have not told anybody, and even if they deliver after IVF pregnancy, they will say, don't tell my mother, don't tell my father, don't tell my in-laws. So that means they're very secretive about it. So there are two sections of people who are open with their family, some are not open. I think it all depends on that woman's right. She has the right to decide, should we tell about this to somebody else or not? So I would probably put the couple onto their own decision-taking method to support from the family or not is their choice.
But Professor Pratap, I'm talking about making this. See, we are having so many IVF clinics coming up now, even tier 2, tier 3 cities. It is a genuine problem. But is the world empathetic towards an infertile couple? Do employers say, okay, take the time off, please be relaxed, have your cycles in peace, don't rush back to the office, whether it's advisable or not, it's secondary. I'm talking about, the entire social structure. Is there empathy there? And how will that empathy come? Will the medical fraternity have to make a difference?
Yes, of course, we play a big role in the doctors play a lot of role, because as you said, we need a lot of counseling sessions as well. Because I feel a medical doctor basically is kept busy in his own clinic, because he'll be doing surgeries, ultrasounds, and so on. That means we should spend more time in talking to that couple at the first sitting itself. As Rohit has said, that the first sitting is a very important sitting, because we have to get the kind of rapport between the couple and the doctor and explain to them why there is no pregnancy happening. And I agree with Dr. Richa, because we can, at the first sitting itself, we should tell that success is never 100%. I always tell, my favorite statement is, we do not know everything in science. We are not gods. And I always say the last thing we don't know is implantation. We know up to implantation, we know how to make the eggs good, sperm good, and everything good, but they put a good embryo there, they don't become pregnant. And at the first sitting, if I tell them the embryo has to develop its own kind of a substance to get stuck in your uterus, and if it doesn't happen, there is no pregnancy. So that stuck glue is not known till now. If I say that, I think they take the failures very well.
Dr. Atta Devi, would you like to come here and give us your experience? Because you've spoken about support groups. Support groups are also new these days. I used to work earlier at an office which had a large number of women employees, and nobody would discuss their fertility problems. There was no empathy, or it was so hush-hush. And, after we left the office, years have passed, every week passed, you talk with them and you realize so many of them have undertaken fertility treatments. So could you tell us, how do we create an empathy, as an ecosystem for women to succeed? Some people have that pressure, they really want a child, but they are burdened with the expectation of the entire family. That is more important. So if somebody from the family went and said, "Beta, we are with you, jo hoga, theek hoga," that whole expectation, the burden will come down. What can be done so that the ecosystem is more empathetic for the couples going for infertility treatments?
This is a very difficult question to answer, because, fertility is a very emotional, social kind of an issue, and lots of myths and misconceptions around it. People are labeled if you're not able to conceive, and especially for men, there is a lot of negativity. People come to know that the sperm count is low, and because it reflects on the man's ability to procreate, they would not like to discuss it within friends and family. In fact, they don't even tell their own mothers about such things. So it's kept a very closely guarded secret, and to come out of that needs a lot of courage.
So that can only happen when more and more people start talking about it, that it's not about you as an individual, but a medical condition like any other medical condition. So if you have diabetes or hypertension, you're not shy of discussing it. Similarly, this is a medical condition that needs to be treated. But unfortunately, our cultural sensitivity around it is so high that whether it's the man or the woman, they would not like to discuss it because of the repercussions it has within the family, etc. In fact, when we speak to women, then, I mean, we don't have so many men in our group, but when we speak to women, we sometimes hear that if there is one daughter who's having trouble, then they keep it a secret because they feel that maybe the younger daughter will not be able to get married if this, problem is discussed openly. So with these kind of cultural beliefs and myths around infertility, it is very difficult to expect a positive work environment. I mean, you don't have it within the family, within the community. So work environment is, far more advanced than starting to talk within the family. So to answer your question, I think the only way to do that is to talk more about it, bring more people who share their stories and come up and say how they overcome those challenges and what they did to be able to bring their families together and discuss openly with them and show success stories. Success stories are the best way to overcome these kind of social taboos that exist within our culture and community. And when you have these women coming out and speaking and saying, I had this problem, I underwent these kind of treatments, whether they conceived or not is a different story, but there could be other positive aspects of how the woman overcame the challenges that she had to face, or the man, for that matter, overcame those challenges, and how personally they have succeeded in living a near normal life. If those kind of stories become more common and are shared in local languages and with people in groups, in forums, in workplaces, etc., I think a more positive environment can be built. Right now, there is a lot of taboo around discussion around infertility.
No doubt. Dr. Manish, do you think that when the patient comes to the ART clinic, that is where patient centricity is going to be the most important, because this whole thing about society, about ecosystem, it's going to take time. As a doctor, would you connect incoming patients with support groups? Do you think that this practice works? Tell the success story. You give them more hope. Would you do it? Would you connect them to support groups?
I think this is a very standard practice of making patients connect to support groups, because whatever the doctor tells, they will always look at it with a pinch of salt. But when they are able to talk and share their experience with patients who have had successful as well as not successful outcomes, that is something which really helps. And they can open up with patients in a completely different way than what they can open up, especially for us male doctors. This is another barrier sometimes which exists with a female patient and a male doctor. So we need to have support groups, we need to have counselors. But going to your question on awareness, I think it would be surprising that even WHO classified infertility as a disease less than a decade ago. So even though this is so prevalent, probably the most prevalent disease in the world, even the WHO had not recognized it as a disease. How many companies or corporates give official leaves to their employees if they are going infertility treatment? They will give for a backache, or they will even give for a cardiac disease. But how many women or couples are supported? The insurance sector in general may not support them, but how many employers support their employees if they are undergoing infertility treatment? How many successful IVF couples come out and tell that, okay, this is what I've undergone. Please don't worry. I have a child who's an IVF child. He or she is as normal as any other child. So the whole taboo and stigma around this is multifactorial. And unless everyone talks about it, we will not be able to overcome this. Support groups is a very important part of this, but it does not begin and end at that. I think a lot of people have to talk a lot more till this stigma goes away.
Dr. Richa, what do you do about all the gossiping that happens? And that is another reason why people don't talk. Oh, she went for a surrogate. Oh, he doesn't have sperms. all this gossiping also then, how do you put in the back as a practitioner? Do you have any role to play here? Because, it does impact a patient seeking treatment, when they hear all of this.
I think when our patients are aware and they are very woke, as I would say, they don't get affected by these things because they are taking it in a stride. They are not looking at everyone what they are speaking, because like they say, people will speak something or the other. And the bigger thing is that the whole society network puts a very big expectation on the women. We don't do that. Once she steps into the clinic, we try to lift off that burden of expectation from the couple's shoulders and say, okay, this burden is ours now. You don't have to be under this stress of conceiving, and we'll try to take the journey. In fact, the patients feel more uplifted when they are at the clinic than when they are within their own social network. So that awareness which we are talking about and the empathy that we are talking about amongst the doctors, I think it needs to permeate to different social criterias also, different social networks also. Their employers, their families, they need to be more aware of these things, that this kind of stress should not be heaped up on the patients. Most of these patients, when they talk about that, what should I be sharing with others, I always advise them that this is your very, very personalized treatment. You have all the right to keep it to yourself, and do not share or discuss too much with others, because there will be thousands of opinions given and not one of them will lead them in the right direction. As long as they stick to the facts and to their right medication and their doctor's counsel, all the other things will fall in place when they have realized their journey one way or the other. And this kind of social gossip network is what kind of pressurizes the patient. There's so many women who say, I feel nice and comfortable when I'm talking to you, doc. When I go back, the whole thing starts again. So that's why it's better for these couples to be away from that kind of tightened network which talks about their expectations and when they are getting a baby and why she's not pregnant till now. And the awareness, as all my panelists have said, it's not only medical awareness and empathy, Anisha, that we are talking about. It's at different levels that we have to talk about it. We have to talk more about it and make sure this kind of stress on the couple is lifted up.
Professor Pratap Kumar, would you like to give us an example? Because when it comes to support group, while some of you are saying, support groups will give hope to patients where their successes are followed and they will be able to manage expectations perhaps better. Dr. Richard is saying that we don't want a gossip session where some of the incoming patients feel disheartened. So how do you look at this?
No, I agree with Dr. Manish Banker and others that the support group is interesting, but it doesn't work well all the time. I think we are the support group. If we are the support group to them, right from the beginning, I tell my patients, you don't talk to anybody else, just talk to me and my team. Don't go back to your house and your office and talk about this to anybody, because they will say, oh, didn't the doctor do that, do this? 101 questions will come in. So I personally would probably tell them, we are the support group for you. You talk to us and my team, and my nurses are extremely good in talking to, and you can either cry with them or don't cry with them, laugh with them, doesn't matter. So I think we are the ones. I think the support group doesn't work in India much.
We have the last 10 minutes of this discussion coming up. So I want to take some concluding remarks from all of you. Let's start with you, Dr. Rohit. Empathy, no doubt, is required in the medical community for any kind of treatment. Anybody going through a disease is having a terrible experience. He wants a way out. Here you want a baby, and you know that the statistics are, the success rate is 30-40%. So how does empathy come in here? What is the importance of empathy and how to go about it for the medical community?
It has been a wonderful session, and these are my asides, I don't know. Number one, you mentioned something about de-glamorizing IVF. I would rather say the society needs to de-stigmatize infertility. So more than us, it is the patient advocacy groups. Dr. Ratna spoke so well. I think it resonated with all of us. It is the patient advocacy groups who have to do a lot of hard work and get this going. One simple example is even my professional colleagues who do not practice ART, they often refer to my treatment modality as artificial reproduction and not assisted reproduction. It's so sad that when you use the word artificial, you're already prejudging me and my patients. So that's something that is so ingrained in our system. So that's where the work has actually got to start. Even our professional colleagues make the mistake of calling what we do day in, day out as artificial reproduction and not assisted reproduction. So that's where it starts. As far as empathy is concerned, to be very honest, to me, to my mind, clear communication is a lot more important than empathy. The empathy has to flow, however, whatever it's worth for, has to flow from the family and the connects. I'm not the right person to empathize with the patient, because the moment I empathize, either I go into overcommitment to the patient, and that's the biggest sin that I can do, or I confuse the patient with empathy rather than with solid scientific facts. I would rather believe in, I wouldn't say teaching, but I would say making the patient or the couple aware about the facts as they exist, because even now, treatment is associated with an outcome. And in most cases, as you said, it's a binary 0 or 1. People would expect a good outcome out of your practice. So they would go to any extent to expect this. And for that, if I empathize with them during my treatment cycle, I may be communicating in a wrong way. So communication for me is much more important than empathy. The empathy has to be there, because without empathy, work cannot happen. And that has to come from the workplace colleagues, the family, the friends, and support groups, which we institute in our clinics. So this would be my summary for the entire thing. Just one more. I think that there's a connect with obesity. Just as persons with obesity are not considered as patients and are generally considered as something that they brought upon themselves, so also our infertility patients also tend to be considered as something that they have brought it upon themselves. So all these are points that need to be pondered and addressed by Dr. Ratna's tribe of people who can actually get this going. And thank you once again. It was wonderful to connect with all of you.
Right. I'll come to Ratna ma'am also, but Dr. Manish, what would you like to say in your concluding remarks? Because empathy is needed. In this is a roller coaster of emotions when it comes to assisted reproduction. So, I mean, one way or the other, family or doctor, we need that. The couples need the emotional support as well.
Fully agree with this, because one of the key to success of any kind of infertility treatment is to undergo repeat attempts, because individual cycles are not always 100% successful. And multiple data points show that the biggest reason for drawback is the psychological burden of the treatment and not necessarily financial costs. So empathy does play a role. The question is, who should be empathetic? I think everyone involved in the team should be empathetic. And by empathetic, I do not mean that you should sit and cry with the patient, but you should act as a friend and a colleague and guiding the patient rightly. That is also a type of empathy. So the entire team has to be empathetic. They need to be sensitive to the needs of the patient. They need to be very sensitive on what to tell the patient at what point of time, because unless the patient undergoes the treatment repeatedly, they will not achieve their goal. If they stop midway, that is a great opportunity lost for them.
Right. Professor Pratap Kumar, what would you like to say in your concluding remarks?
Yeah, I would probably say the same thing again, because when the patient comes to us as a couple, the beginning session, the first session is most important. And we would probably tell them what they need and what to do and what not to do. I probably would tell them. And then they would probably kind of budget it out and say, okay, I can spend on this kind of treatment. And at the beginning itself, as Manish said, we need to be clear with them about the success and the outcome. And I think if you're clear about that in your mind and in their minds, that would be the best. Because as you said, roller coaster, I agree with you. But I think the roller coaster can be a little slow roller coaster and not a rapid one. And that's what is our responsibility. Yeah.
Dr. Richard, what would you like to say in your concluding remarks?
So I would like to say a very realistic expectation, tailor-made treatment, a robust counseling to lighten the load psychologically on the patient, have a clinical clarity so that we are doing the right thing while we are adjusting these 5 things on the emotional aspects, move on the right road, and increase and awareness and talk amongst the community to be able to accept and embrace this couple who's on their path of achieving fertility. That's, I think, the crux of the thing. What we do is one part of it, but we alone cannot act. It's the entire community which has to open up their arms and say, okay, this is something that we do not need to whisper or gossip about. We need to take a step back and let this couple be. I think once everybody does that, just let the couple be, they will be more clinically able to achieve their goals.
Dr. Ratna, your concluding remarks. And I just want to ask, all of you are medical practitioners, does empathy have a tangible benefit? Less stressed, more relaxed patients, do they have better outcomes?
Well, certainly they do. But just to address something that Professor Pratap and Dr. Richa raised, patient groups are officially recognized by the World Health Organization as an integral part of the healthcare system. And WHO has been having a series of consultations with patient groups over the last 1 year. They will come up with a report on what patients feel should be a recommendation to policymakers and member states of the WHO. So in India, also Ministry of Health now recognizes patient groups as an official part of the healthcare system and calls us for all discussions. And we've had several successes in other areas where we work with professional groups. Say, for example, in stroke, we work with the Indian Stroke Association to bring policy change and treatment within the ambit of, say, the NHA, Ayushman Bharat. And similar things can be done if the professional groups and the patient groups work together as, partners and for the same goals, because the objectives are the same. At the end of the day, the patient should benefit from the advanced treatment that is available. It should be accessible. It should be easy on the pocket, and patients should have access to the right information so that they reach the right doctors and hospitals on time. So as a takeaway, I would say that, yes, empathy does have an extremely important role. And I would say as a practitioner that most doctors are empathetic. They would not be treating their, patients if they are not empathetic. Every person connects as a medical professional with their patient and tries to choose the best option that is the best fit for that patient's needs. So I would also say that there needs to be more communication between the professional societies and the patient groups and civil society in general, civil society working in healthcare in general, so that some of these myths, misconceptions, and taboos are removed. There has to be more dialogue on how the couples that are undergoing fertility treatment can be supported, whether within the communities or within workspaces. And that can only happen when more people are talking about it. So maybe more patient stories, more lived experiences, and more, information shared on success stories would be the way forward. And last but not the least, a lot of advocacy around inclusion of fertility treatment into insurance policies, whether public or private. That would ease the load a lot for people who are undergoing treatment. Thank you.
All right. A big thank you to all of you for joining us and sharing with us your thoughts on the important factor of empathy in the entire process of assisted reproductive therapy. Thank you all for joining us. We value the time you've taken out. Your advice, your opinions, your expertise will help everybody. In fact, from our side, this is an effort to increase awareness, to break the myths, to remove the stigma, so that there is a clear way forward for those who are struggling with fertility without the shame that comes. Thank you all for joining us. Very grateful to you for taking the time to join us. I will now hand over to Ruby Lakra, Assistant Editor at she'll be talking about sensitization around stigmas that are related with ART procedures. Over to you, Ruby.
Thank you for having us.
Thank you, Anisha. Continue the good work. Bye-bye.
Thank you. Bye.
Please go ahead, Riddhi.
Yeah, thank you. Good afternoon and welcome to another session of India IVF Summit. I'm Riddhi Lakra, Assistant Editor, IHW.TV. As we discussed in the first session, how the implementation of ART bill will help people ease the way how people see and perceive their assisted reproductive technologies. We also talked about the lifestyle changes and the genetic disorders that contribute to infertility. While we have understood the numerous options for conceiving through IVFs and other assisted reproductive technologies, there is still a misconception around infertility in India. Reproductive health knowledge and awareness is nascent in India, and many couples remain unaware of the available options for conception. There are many myths around IVF. For example, that the IVF results in child born with birth defects, that the process will deplete the eggs from the woman's ovaries, or that the IVF can only succeed in young couples. There is an acute need to disseminate scientific information so that the couples can make informed decisions. And it is important that we create positive awareness around infertility and dispel all the myths. To discuss this, we have with us today Dr. Rajul Tyagi. Dr. Tyagi, she's a director at the Javitri Hospital and the Test Tube Baby Center. Joining us, we have Dr. Mahesh Koregul. Dr. Mahesh is the infertility expert at the Nova IVF Fertility, Bangalore. We also have with us Dr. Amit Patki. Dr. Amit is a medical director at Fertility Associates, Mumbai. We have with us Jayesh Amin. Dr. Jayesh is a clinical director at the Wings IVF Group. And last, we have Dr. Bharti Dore Patil. Dr. Dore Patil is an infertility specialist at the Nova IVF, Pune. I welcome you all for the panel discussion at the third India IVF Summit.
A very good afternoon to you.
Thank you, Dr. Mahesh here, and I welcome you all for the session.
Yes, let me just start with Dr. Mahesh first.
Yes, please.
Dr. Mahesh, to understand, we have seen through the various studies and what we have gone through, it is observed that there is a stereotypical belief and there is an orthodox approach in terms of the medical prevention, in terms of the infertility, which is more oriented towards the women than men. Do you think is there a way we can bring a change amongst people and also talk about the equal responsibilities among both the genders?
Yes, because it is mainly a gender sensitization that is required, and it is so many situations that we see that even the semen analysis is not done by husband, and it is pushed over everything on the wife's head. And this is the attitude that needs to be changed by education, counseling, and now we are seeing a lot of change already than what it was before. I think further education and awareness about the semen analysis and other parameters are something that we need to look at, and we need to educate men also and sensitize men along during the curriculum development itself. When we explain about the reproductive system, I think we need to make them understand and explain that these are the things that can happen even for the men. And I think the gender sensitization is much required, because sometimes you see the azoospermia not tested, but all the tests have been done on the wife. So I think this is something that is not to be woman not to be blamed all the times, and we need to educate and spread awareness about the male fertility issues.
Dr. Amit, you were trying to...
So the biggest myth in infertility that it is female directed. To be very honest, only 40% of all cases are only female related causes. There are 30% of couples where there is male related causes, and the other 30% are where both male and female. So it is an equal that there is male factor in fertility, and that is the biggest myth that it is only female related. And as a practice for the last 25 years, I always tell all couples that the first time they come for consultations, they have to come together, because that means it is an equal responsibility, because both need to come down to me for their consultations. It always happens that the woman comes with some other woman relative because they always feel it is only women directed. I think the small things that we tell them, that the couple has to come together, because then they understand that they're sharing the responsibility and there could be a problem in the male.
Dr. Amit, just to add on to your question, there is a lot of shame associated with male infertility, and men generally avoid the fertility testing. How do you think we can remove the stigma around male fertility?
As I said, 30% of cases are male factor infertility. So, and unfortunately, not only in our country, but worldwide, infertility is equated to virality. So whenever you tell any male that they have a problem to father a child, it is understood that perhaps they do not have that manliness, as they call it, to be the husband or to procure a child. And we must make them understand that male factor infertility has nothing to do with virility or the ability to have sex with his wife. So that is the biggest problem. I think it is important that we bring awareness. It's not only us, but it is family physicians, general gynecologists need to be made aware that a large number of couples have problems only in the male factor. And that is why it is important. The first and the basic test in any couple is to do a semen analysis. It is very easy. It is not very expensive, but will rule out 30% of causes of infertility. And I think it is awareness, as we said, talking about it, scientific articles in newspapers, in lay magazines, where we talk about male factor infertility will bring about a large amount of change in the attitudes of men who may have problems.
Thank you, Dr. Patki. Just to understand, Dr. Amin, coming to you, we have seen that even the lifestyle factors also play an important role. And Dr. Patki was talking about the awareness. So as an IVF specialist, how do you think like a right information can be sent out to people in terms of the various, living a healthy lifestyle? Dr. Jayesh.
See, it's very rightly said by Dr. Amit Patki regarding the regardless of the, and you are sharing about the male infertility awareness. As far as concerned, if you see the basic cause that why we are raising, why infertility is raising, there are two major factors from the society. One is lifestyle, and second is the marital age, right? That marital age is increasing, right? For a female. So in lifestyle, we know that certain things, 2-3 things are, I already used to say my patient. Then when they are having unexplained, undiagnosed infertility and repeatedly asking a question, Dr. Jayesh, what is the reason behind me of this infertility? Then I will always say there are 3 enemies in our Indian environment, that is called pollution, pesticides and radiations, right? So even though whatever the things, we are not get rid of these 3: pollution, pesticide, anything, anywhere we are living, we have our pollutions, we have a pesticides, because we cannot get rid the good healthy diet, even pesticide free diet. It is something, it is very difficult to find out. And radiation, yes, we are using mobiles and towers and everything is there. So this is in our lifestyle. The radiation is always there. We are putting mobile, we are always surrounding our Wi-Fi systems, and we are so techo people at present. So this is one of the involvement. Second thing, another most important in a lifestyle, that because in the career oriented, that people do have some work, maybe we can say something, they have a work in the late nights also, and because of the stress, the stress is so increasing. All the stress busters may be alcohol and smoking. If you ask me that in a last recent year, the survey is saying that in Indian community also, the female smoking is increasing in a bigger way. So that smoking also injurious to health also, especially for the female. Alcohol consumption is also increasing day by day. This is also one of the part of the lifestyle. taking together also, we all are knowing that our kids and also the new generations are having a habit to have a working lunch where they are getting something which is not our staple food. Maybe we are getting more focus on the junk food and the high calorie diet sometimes, right? I'm not talking to all, but these all things make one more obesity, means one more lifestyle in this problem. It is called the obesity, because India is now facing around 40 to 45. If you see the Google search, all the numbers, then we have a 40 to 45% people, those who are suffering from the obesity. At least I think so, where at least around 20 to 25%, which is related to our fertility problems, where we are dealing with the obesity also. So looking to all together, I think so we should be more aware now. Healthy lifestyle is so important. Get rid of this all the stress busters. Use it judiciously, or maybe not to use during the fertile period. That is also important. And how to create that awareness is also increasing, because before 10 years back, I'm not going to take a history, but now repeatedly women is asking me very repeatedly that should I take a drink during this treatment or not? So these all things are increasing, right? So looking together, I think so we should be aware regarding all these lifestyle disorders, which is one of the major part of the infertility, major part. And then other cause, maybe genetic or age, is the second part. Most of the infertility which is arising from the community is lifestyle related involvement.
Yeah, if I can add something, Riddhi, with your permission, I think in lifestyle, what is important is that how it affects the fertility. The first and the foremost is, although our lifespan has increased, now people live for more longer years, but unfortunately the window of fertility has remained the same. And that is something that women have to understand, that their fertility starts dropping down by the age of 35 and definitely by 40, even if we all are going to live till 75 and 80. And that is why it is important that even if they have career goals and aspirations and maybe some reasons to postpone fertility, it is extremely important that they try and finish it off before the age of 35. Women also have a notion thinking that they can get pregnant at the age of 50, 55 because they read that in the media. And this is something which is a misconception. Media puts something which is rare, which is not normal. So we must understand that those who conceive after the age of 45 and 50 definitely are resorting to donor gametes, which lay people don't understand. So I think it is extremely important, in addition to what Dr. Amin has said. I think because of busy lifestyles, different cities that they both live, because of different timings, the first question I ask them is their sex frequency. And believe me, more than 50 to 60% of couples have very, very poor frequency of sex or coitus. And that itself decreases their chance of pregnancy.
Dr. Mahesh, I want to also include you in this topic about like the lifestyle factor. So is it like when we talk about the various lifestyle factors, being unhealthy and living like a healthy lifestyle, so is it both, I mean, only the women to be talked about, or is it the men also? So maybe the drinking habits, maybe sedentary lifestyle also can bring about different change in the men, and their infertility can also be questioned.
Yeah, that's a very good question. In fact, I would like to tell 5 things. Number one, the lifestyle, in the sense, the activity of sex in earlier days used to be for the pleasure to start with. Now nobody is thinking, they are doing it as a duty, as a target, as an activity, which is not possible. And that is not the way that has to be done. That is number one. So unless you have time for it, unless you are relaxed your body, if you go at 10 o'clock in the night at home and you want to try, it's not possible because your body is not cooperating. If you see olden days, the government jobs, or my parents' time, they used to come back home at 5 p.m. So then there was enough time for them to unwind, relax, and then there was time for them to try. But then today it's not happening. And in the urban cities, the travel, the commute from the work to home takes a lot of many hours. And by the time you come, your back is so tired that you just want to eat and sleep. The first thing, first criteria for anybody is a hungry stomach. So once you eat, once you have good sleep, then only you are. It's a third need of the body, not the first need. So if you fulfill a good food and good sleep and good rest for the body, then you'll be relaxed. You can note that when you are on a holiday, you'll have more chance of trying, because that's when you're more relaxed. That's number one. So that's one of the lifestyles in urban cities that we see. Number two, the smoking is the one which causes kind of atherosclerosis and other related problems, and so smoking is more dangerous than alcohol, which needs to be stopped. Number three, there is, you want or you don't want, you have been eating pesticides, insecticides in your food. All the food what you are getting today has been laced with so many chemicals, so many pesticides. So even we used to wonder why these men from the villages are coming with such a low sperm parameters. Then we realized they spray the pesticides to the crop. So then these are the people we are seeing that it's in a big way affected. Even we think that rural area, nice air, nice water. If you see, there was a study recently published. Even the groundwater has so much of chemicals, so much of pesticides what they are drinking. So even villages are not spared. We think that village has a better clean environment. It is not true anymore because of the unscientific use of these pesticides, the fertilizers, and groundwater, as well as the vegetables and all of it spoiled. And number four, the interaction and the harmony between the couple I see is a little bit lacking than the earlier days, because there's a lot of fights and then they take the fights to the bed. So जो होता है एक दिन में, by the time you sleep, Mia Bibi has to forget. It doesn't happen. It drags on. Their parents jump in, and then there is no, whenever you go to the bed, then instead of having a good time, they are going to have these fights in the mind, lingering, and these, we see a lot of social disturbances among the couple. Unlike the olden days, lot of disharmony is there. That is number four. Number five, the couple as such want to plan for a lot of days. They don't want to, they don't even try. They can use a contraception and try, but they don't try, and suddenly they come and say that we have erectile dysfunction, we have vaginal dysfunction, all other things. So whenever God has given an opportunity, we need to try and make good use of it.
Adding to that, in our Gujarat, if you say something, our Saurashtra division is there, and then so many other parts of the India, that tobacco chewing is really very much effective. How it is so effective on the male factor. So if I say something, the priority, then tobacco chewing is having a higher effect than smoking and then alcoholism. So there should be some awareness, because tobacco chewing is directly, and the sperms are so damaged that they are coming with a lot of male infertility in the certain male part, certain southern part also. In our Gujarat, we can consider in Saurashtra part where tobacco chewing is very higher. So that is also one of the part of the addictions of lifestyle, which we have to have a awareness to get rid of that addictions for a better output for the healthy parenthood.
Yes, Dr. Jayesh, thank you so much for that. And I would like to come to Dr. Patki and ask about how they, we are aware about a lot of things now. That one of the things is that the lifestyle factors also play a very important role. And then we are aware about, some of them are aware about the IVFs, that there are IVFs. But then there is still a misconception somewhere that people tend to use, whatever available information is there on the internet, they go and they try to find out the information before going to their the expert. They try and find out that this is what we can do before an IVF, this is the things we can do before IVF, how can we IVF be successful. So what do you think about such approach?
See, Google Doctor is already approached before they come and they see us, so which is there. But we must understand that this is like a double-edged sword. I'm quite happy for them to take some information from the net, from reliable sites, because that way they come a little better prepared, and quite often they ask pertinent questions which they would have perhaps not asked in their first visit. So I think it is the need of the hour that we as doctors have to equip ourselves with the latest knowledge, because sometimes they come with so much of latest techniques that frankly we also do not know that it is already in the market. But they have to understand that there has to be a realistic approach to this problem. They have read about something happened in Mayo Clinic, something happened in Harvard, and those things may not be applicable to our country, to our people. But it is important that I'm happy for them to read, to equip themselves with the knowledge, but I request them to go on reliable sites and not go on any sites which sometimes can be self-promoting themselves with some false information. So it's like a double-edged sword. If they don't do anything, they come too raw to us, then it is a lot of strain on my team to talk and counsel them. Some of them, if they come prepared with their questions, we can at that stage itself remove those myths that are there in them, and they understand that, okay, they have read something, but this may not be in practice in real life, and this is not something realistically possible.
Thank you, Dr. Patki, for that. And
I just want to add something in this. See,
yes,
what happens is, the infertility is something that is really exploited. I mean, a lot of people, they have no idea where to go, what to do. Even you see the babas on the road sitting with a loudspeaker will say that all kinds of erectile dysfunction, because if patients are gullible, they don't know what is best, what is wrong, what is right, and their affordability range also we need to think. So it is awareness that we need to do, that not to fall prey to this unverified scientific data, non-scientific data. There's so many unverified things. Even you see a lot of even the fertility doctors also say, I'll do that, I'll do this, which are not substantiated by the evidence. So I think that is something, that's the reason patient Googles, they find out, can you do this thing from somewhere on the moon, it is being done, kind of thing. I mean, which is not substantiated scientifically, not to be done. But then somebody else is doing or somebody else is promoting it, they will ask it. So there is a need to differentiate from even some non-allopathic doctors will promote that this is this kind of a jadi booty of khao aapko ho jayega, ye ho jayega. You see a lot of people who waste their life doing all these things and they come back at their fag end of their reproductive years wherein no more eggs are left. I mean, these are the kinds of practices we think people should read about and understand what is scientifically evidence-based and what is the right kind of treatment they should undergo, rather than falling prey to a lot of things, ifs and buts, and even sometimes somebody gives an ash out of somewhere and you get pregnant. It's not going to happen.
Thank you, Dr. Mahesh. Just to add on to this, only like the information, like we have a lot of information around IVF. We have a lot of information about infertility. If somebody is infertile, what they should do. But then there is a thing that when you see, as you mentioned about the different things, about the different online portals, Dr. Patki, that they are available. The information there, it's available. But when you see in a vernacular language, we do not have that. Dr. Bharti, if you can you answer this, like, or can I wait for another sometime? I'll wait for
another 2 minutes.
Yes. In meanwhile, I'll go to Dr. Jayesh. Just to add, ask you, Dr. Jayesh. So we have seen that there are international papers, there are English versions of content available for people to understand about infertility and IVF. But when you see in vernacular language, we have nothing. Whereas people tend, and obviously they would go to the roadside people for their infertility treatments. So how do you think we can come up with authentic information for the people around in India?
See, around in India, I can understand if you ask me for a urban area, you rightly said that we can have a lot of information, right? So for urban areas, people are used to read a lot of articles, and there are also people are writing in websites. Lot of e-information is there. Rest of the other than the rural area, still to penetrate, we should have to have some circulations of the we can have some circulation of the writing some about the infertility, the small thing, basic things, that what is infertility and how it occurs, what are the causes, where lifestyle, how it involves, which are the bad habits, which is also include. I think so. We all, as a doctor group, we all are doing certain things and spreading all these things by writing all our small articles and spreading it by pamphlet in the small villages. Apart from that, what our two organizations, maybe ISAR, IFS, we all people are going to take some continuous medical educations to the doctors, those who are situated there. So we are taking a lectures of the primary lectures to the what is primary infertility, which are then whatever the updates are coming, that I think so rightly informed from the bigger organizations. Even our gynec use organization means Foxy is also trying to aware by putting there some awareness program inside the society. So this is all will be done in, already in a process by the doctors and the organizations from our society. I think so. Apart from that, to help and serve to the very poor community going forward, it has been done by the doctors are always there. They are going in the villages and they are giving the free of charge camps where they can treat and give some medications. And again, when they go there, also again there is information, because you are passing the information in the form of their language. That is more important, because they will not catch the language which is you are saying in the metro cities, that all this language which is you are going to give them. So looking to that, I think so these are the awareness program. I slowly and gradually, I think so if the IVF is available for going forward, if available in the smaller villages and everything, where I think so this is one of the part that awareness are spreading. And we as a doctor organizations, part of the organizations, we all trying our hard to put some more and more awareness launching programs, or the camp, or the distribution of the certain literature which will inform the community regarding the very poor community regarding the infertility.
Thank you so much, Dr. Jayesh, for that. And I hope these kind of initiatives of reaching out to the rural India would also help them out. Dr. Bharti is here. I would like to ask her, we were discussing about the various aspects, like how men infertility is not being talked about. We also came to the information part of it, like how there is a lot of information available and it is easily available and people tend to use that. Just to come to a very important aspect, a lot of young women read about that the PCOS is there, so they cannot conceive them. So is it a right way that the studies have shown that almost 1 in 5 women have PCOS in India, but can it lead to infertility, and can with that PCOS can they conceive? So does IVF have a solution for that?
Yes. As you said correctly, PCOS is on a rise and we are diagnosing them because of maybe a lifestyle now. There's so much change in the lifestyle has made all patients who have been regularly ovulating, now they've been having a PCO, they don't ovulate properly. Because of they're not getting ovulation properly, probably the pregnancy conception is a difficult part for them. But PCOS is not a disorder or disease where it cannot be treated at all. It can be treated, but it cannot be completely abolished or taken it out. It can be controlled. So, and with that control, definitely she can become pregnant. Only one has to make aware about themselves that they have to be very, very particular about their lifestyle, their diet, their weight. They have to be careful when they have been starting their fertility options. They should try for, say, maybe an year's time if they have a regular cycles. But if they don't have regular cycles, they must approach to a doctor. But it is not like how you said that PCO once is there and she will not conceive. It doesn't happen. But some PCOS, like PCOS is not one symptom. It's not like a, say, ovarian tumor or ovarian cyst is there. But PCOS is a heterogeneous disorder. It's a multiple things have been involved in that PCOS. So she would not come with one symptom, and that's how she goes to sometimes skin specialist, or she comes to a fertility specialist, or she will go to the common gynecologist, and that's how the treatment starts getting variable. So infertility, if she comes to the fertility specialist, if she's interested in fertility, she sure has the solution, and we may give her the pregnancy, so she need not to worry, but only we have to be very careful about treating her, how things has to be working for her specific phenotype. Phenotype means how the way she presents to us.
Can I add something to this, Riddhi?
Yes.
Now, let me give you some figures. PCOS is a problem which is there in the reproductive age group, and almost 18% of women have it. So, and it is on the rise. And a recent Indian research or an epidemiological study showed that 33% of adolescent girls in India have PCOS. So these are very frightening figures, and most of it is related to lifestyle disorders, wrong eating, less exercise, no dieting, and irregular hours. So I think it is a lifestyle disorder, and as Bharati very rightly put it, it can be treated. You cannot cure somebody from PCOS because it is inherently present in them, and if they do not change their lifestyle, the problem only gets worse. So I tell a woman that she will have to live with her PCOS, she'll have to make friends with the PCOS, but try and walk, diet, exercise, keep her BMI in control, and that is how she'll keep all the symptoms of PCOS under control.
Yeah, that's absolutely right. So she has to deal with it. So she cannot go away with it. She has to deal with it, and she should not be getting frightened because it is going to be there with her. It's a long-term disorder. So she's not going to go away from it, but then she can deal with it.
And most PCOS need multidisciplinary treatment, means it's a gynecologist, a dermatologist. We have lots of PCO girls who have got low self-image, low self-esteem because of their obesity, their hirsutism, loss of hair on the head. So they need a large amount of psychological counseling, and I think the family, the parents also have to be involved in telling them how they will empower this young girl or this adult to deal with this problem.
Yes.
Thank you both, Dr. Bharti and Dr. Amit. Just to add on to the entire topic about the information, we also I want to ask all the four panelists here, the information what we get through internet about IVFs, about infertility is not right. I mean, it's not correct most of the time. And people like us, like a tech savvy person, would just go on internet and find out some information about us because we are scared to visit a doctor. So how do you think we can bring about a change in that, and how people actually can understand that the information available there and what problems we have is different? I mean, there is a huge difference what the generic information is available. So how do we categorize that, and how do you make people understand about that?
It is always not possible to extrapolate the data exactly as they are seeing. If you see as a headache, someone has a headache, they will see a Google headache and they will say that it is a brain cancer. Somebody has a severe stomach ache for 5 days and they will find out that it is a colon cancer. That's how kind of education happens on the internet. So somebody reading about PCOS will think that all are kind of severe PCOS, which is leading to this end of life kind of fertility. It is not like that. So you cannot extrapolate exactly in verbatim what you are seeing on the internet. The PCOS could be a very harmless and small thing that could be there, or so many times it could be misdiagnosed as a PCOS, then it could be still normal, or a mild PCOS, which is not a concern at all. So I think whenever they read something online, whenever they get to hear from somebody that okay, they had this condition, this thing happened to them and all those things, you visit a doctor to check about what you have read. Nothing wrong. Knowledge is power. empowering people with knowledge is education that many would do, and that is appreciated, that they are trying to read about it. But then verification of the fact, it's like fact finding. So verification of the fact is more important, and then it is advisable for them to go ahead and verify what they have read with the doctor, and then try to understand why it is not that, and why it is not this, and why it is not serious, and why it could be this. What are the options available for them to get out of this? So this is something that I would say, everybody, please read up, please read up, please read more. I'm not saying no, but then write down your doubts, ask your doctor why it's not like this, why it is like this. Definitely you'll get an answer.
He's absolutely right. Dr. Mahesh, this is perfectly, because I always tell them that's an information. What you read is an information. You need a knowledge and you have to apply that also. And that's why information is definitely all right. You must, but with that information, you are not supposed to get into the knowledgeable science and start treating yourself. That would be very difficult, because if I have an irregular period, for example, I'm telling, the day before yesterday, patient had come to us. She said, I have an irregular menses, and that's irregular menses means I have a PCO. And that's how she started all PCO information on the net, and she started eating the diet accordingly. And she said, 6 months I'm going to do this all diet, and then approach to a doctor. Somehow one of my patients says, no, you have to approach madam and just see what she's saying. And can you believe that patient didn't had PCO, but she had a POI, that is called premature ovarian insufficiency. That means she doesn't have eggs. PCO has a lot of eggs, and here she doesn't have eggs, and that's why she was getting irregular menses. So information is okay, but from information, if you start understanding whether it is a knowledge and that has to be applicable to you, and you start applying that knowledge to you, that is where the things goes wrong. So lot of information, you must come out with your problems, your queries, and get the correct knowledge or the treatment options from the doctor. Again, you can go back. I tell them one further line, that once you know what is the treatment options for you, go back again and read that whatever you were read, and now you will understand how to correlate between these two things, and then take a decision what doctor has been saying. So this is what we urge to all our patients, not to have the information. You must have the information, but don't treat yourself, don't diagnose yourself. That will be disaster sometimes.
Riddhi, I have a slightly different take on this. Now, information on all medical illnesses, right from your head to toe, are there on the internet, and patients access that. But understand that infertility is different, and because even in the undergraduate syllabus of curriculum, infertility is not given that importance. Forget undergraduate, even in the postgraduate obstetrics and gynac course, infertility is not a big chapter, although in their practice, almost 25% of their patients are infertility. So the patients go to the internet because their routine GP, who is an undergraduate, has no clue about infertility treatment. So that is something which is completely wrong in our country. Infertility, for some reason, you will be amazed to know that 95% of infertility practice is in the private sector in India. Only 5% is in the public. So the government policies are not in favor of infertility. They do not think it is an illness or a disease. And that is why the knowledge is not there. And that is why the infertile couple especially needs to go on the internet, because their routine family doctor, family physician has no knowledge or is giving them some half-baked stories, because unfortunately he has not been trained and taught in his undergraduate days about infertility. So the problem lies there. Knowledge about all diseases is there on the internet, but that sets infertility away from the rest of the diseases.
I can add only that we all doctors, as that we are always welcome, that well-read patients are always good. because they should have some knowledge. So we are not going to say you don't go and don't read, and without coming you are without reading you are coming. So they are reading, they are getting the information. Only to rectification of the informations by the expertise, that is more important. So don't apply in your life. Before to read, it's fine, getting information is fine, but clinical applications in medical science, the clinical application should be only and only in the hand of the medical expertise. So you should take expertise advice and then you implement. That is the only the message that we can say something regarding the Google read patients. Getting information, that's fine, but clinical applications should be always under the hand of the clinical expertise.
Yes, Dr. Jayesh, I would like to thank everyone for that answer. And Dr. Bharti, I would like to come to you that like counseling is a very important part of IVF. So a lot of patients, a lot of couples, if the first round of IVF fails, they generally tend not to come back. So how do you think that part of, like we were talking about the knowledge, though we get a lot of information from internet, but then you also stress on the part that knowledge is important here, talking to your doctor. So how do you think counseling can help people, couples come back and continue their IVF treatments?
Counseling has a utmost important, as you said correctly, they have to talk to the doctor has to sit in front of them, and they must give the time, especially when the patient comes. Three places I always emphasize counseling or doctor visit or consultant visit is very, very important. Number one, first visit. The first visit, the consultant has to be very cool, calm, and he has to give a time to the patient, analyze the whole detail, and that gives your counseling. And counseling always should be with compassion. It should not be what I have learned over a period of time, like last 30 years, that it's not only academic propositions what we give appeals to the patient. It appeals to the patient that how compassionate you are when you start talking to the patient. The moment you start showing the compassion, automatically their attention starts coming to you. And if you just give the figures and numbers, then they go away from, because they will be sitting in front of you, but their mind is not there. And once the mind is not there, they don't focus on what you have been talking. So with your counseling, if the compassion comes, that makes a lot of difference. This is a first visit. Then the second visit, I always tell, during your process, like IVF process or whatever, you must tell them truthful analysis of whatever is been going on. Truthful doesn't mean that you to hurt them, but in a very different and subtle manner, you must tell them if it is going fine or if it is not going fine, so that they start little preparation. You are not going to bang them on the last minute that something is not going right. So that is a middle portion of the process or journey. And the third very important is when IVF fails. If it is positive, then doesn't matter even if you don't talk to them also much, because they are already happy. But especially when they have been failed cycle, we must scientifically give them the answer why it is probability that these are the reasons why you must have failed. Usually what I see in my routine practice, that the patient once failed, they're completely devastated. They don't want to listen also what the logic is behind. So give them little time. Don't call them immediately. Don't call immediately. Let it sink. That failure should sink inside. And then they start logically thinking. I always tell my counselor or my reception front desk people, don't give immediate appointment to them. They are emotionally clouding is there. There's a lot of emotions are there right now. It is a surgeons of your emotions, and they will not understand what you have been talking to, and they may go haywire. So give 1 or 2 days time, and then sit down, give them the time properly, 20 minutes, 25 minutes, and then try and tell them, this is not end of the road. IVF fail is not end of the road. It is still, you have tested up to here. Let's see what next we can do and where we had been gone wrong or where we have been lacking. And this is the next step we have to take. That three parts, if you do, patients, I have seen patient doesn't go. They will keep on with you, but unless you explain them where exactly things are being heading towards, not wrong, not failure. And these all failure patients, very, very important it is for them to be very compassionate, because they feel it is completely hopeless situation now in the life. So this is how I deal my patients. If you look at the counseling,
see, the dropout rates are not always because of financial constraints. Most dropouts are because of the emotional turmoil that has happened. And I think it is extremely important that we give them realistic expectations from the treatment. Most patients think that if they do IVF ICSI, they are 100% going to get pregnant. I think it is very important that you write and you give them what their chances are as a couple. You look at them as the complete package and not only concentrate on their infertility. You look at their emotional quotient, offer them empathy. I think professional counseling is now mandatory by the new ART bill, so you must have a counselor to see them. And the patients who have failed, I see them in a separate OPD, which is not busy. So you can give them that time to think, to explain, to recap what all you said and plan the way forward. So in our clinic, we plan the way forward before we start the treatment with realistic expectations of what the treatment is going to offer them. Patients sometimes don't hear what you are saying because they don't want to hear that. So we in our clinic write down the procedure, and at the end we write down what is going to be the cost and what is their success rate with their treatment, so that it remains with them when they go back home and they read that, they have a sense of what they are going through. Because quite often patients come and they say, oh, then you do IVF, do surrogacy, and they feel that is 100% end of the road. It is not true. And the dropouts are, if you don't give them realistic expectations, very high expectations, you don't tell them the full treatment, because sometimes the treatment is told in such a rush that the patients don't realize the number of times they have to come, visit, see you, injections, all those things matter. So then it becomes too much of, they are overwhelmed with the emotions, and that's why they may not want to go for the second attempt or third attempt.
I will just add on only that counseling is so important in IVF, and it's varies in three parts. One thing is that that is what Dr. Amit Patki says, sharing the right information to the patient. And that's in today's era, I think so we are doing audio video. If you have a one audio video visual impact to the counseling, it will give a best understanding. Because if you say something again and again for a last 20 years, your counseling become again and again smaller and shorter and like that. So you should have an audio video slide presentations for the counseling. Second, I think so what a patient need, it is called connect. I will say this is the second part, that whatever the counselor, that their job is to connect illiterate people in a different way, the literate people in a different way, the poor people in a different way. So you should have to have a connection to the patients in different scenario, demography. And last, third point is more important, that Dr. Bharti Patel is saying, that sympathy. The last part is sympathy, because you need that. The failure is bound to occur in 50% of the all IVF patients, and it will be not addressed by the main clinician in a proper way, and that it will kill, means it will increase your dropout ratio also, and it will kill your impressions also. So these all three things, I think so, right information. Second thing I say, the connect, and third thing I would like to say, sympathy. This three part, if it is managed by the any counseling part, then I think so patients are always very open to do to work again and again with you, even they fails.
Thank you, Dr. Jayesh, for that. Dr. Mahesh, I want to come and ask you, and to other panels as well. So there are different multiple myths around IVF that people can, it can cause multiple births. I mean, in terms of triplets or twins, and then I mean, even the children born can be premature or there can be defects in them. So how true is that?
It's a good question. What happens is, earlier days, why I'm telling earlier days is, as per new ART Act, you are not supposed to transfer more than 2 embryos. So that is one advantage. So new ART Act clearly says that at the maximum you can transfer 2, nothing more than 2. There were days when people used to transfer 4 embryos, 5 embryos, 6 embryos also, because they were not sure about the success. So these were the days. But then this misnomer or the twisted fact that came along with the IVF is, when there is IVF, there is going to be twins. Because the multiple birth order was very common because more embryos were transferred. So that is not wrong for them to think. But then with the onset of the new ART Act, we are going to transfer 1 embryo or at the maximum 2 embryo, and chance of multiple pregnancy are going to come down drastically than before. That is there. So we have to counsel the patient that it is possible to have only 1 baby if you wish. You can transfer 1 baby only, and there is a good chance, and it is more healthy. As a matter of fact, multiple pregnancy is considered as a complication, not a great achievement. So multiple pregnancy associated with a lot of problems during the pregnancy, like diabetes, hypertension, and a lot of things. So I think these related myths regarding not able to carry 1 baby is something that we need to counsel the patient and make them understand. And I'm sure they're going to understand that twins is not always the order of this.
Yes, thank you so much, Dr. Mahesh. Dr. Jayesh, I want to come and ask you. There's another myth that IVF technique is only for those who can conceive who cannot conceive naturally. So is that true? And are there other perks of conceiving through IVF?
See, it has been said that if you are having a long-standing infertility, you are not getting a pregnancy after certain years. Of course, people do have that last treatment is getting again for IVF. In between, there is a bridge treatment, natural intercourse and IVF. In between, there is a bridge treatment. It is a part of the ART nowadays. It is called IUI. So putting the semen inside the uterine cavity at the time of the ovulation, that is also one of the way forward to get pregnancy. Now, when there is extreme level long-standing infertility, certain conditions like bilateral tubal block, certain condition like less than 5 million count, 0 count, these are the extreme, these are the indications where IVF is the only answer. And lastly, I can say something about it's not only to getting a baby, but there are some alternatives. So which are the other perks of IVF? That getting a genetic disease free. So there are a lot of monogenetic disorders. If you say something like repeated thalassemia disease, babies are born by the couple, both thalassemia minor couple. There are some Duchenne muscular dystrophy. There are so many monogenetic disorders which are in turn leads to the required help of a healthy embryo, right? So in this type of genetic disease, if you are a repeated genetic disease related abortion, in the community is considered as an abortion, loss of the pregnancy, all these things, preterm delivery, it has been found out there is some genetic disease abnormality. So it's not like that only to conceive, it also to get the healthy baby, where you can also apply the PGTM, so which is one of the part of the other perks of the IVF. Second part, nowadays I think so the advanced maternal, as Dr. Amit Patki says that you need to complete your family during 30s. But I know that everything we know, but we are still, we cannot complete in today's era because of some competitions. And I think so day by day in metro cities like Mumbai, Delhi, everywhere, people are married at around 30 to 33 and they will planning after 35. That will be days will come within a 5-10 years, shorter time. Still our in metro cities, still we are 30, 32, we are getting a planning of pregnancy, but that day will come where after 35 and age-induced abortions are common. Right? So if your age is more than 36, more than 37, then your multiple abortion, if this age-induced abortion, you can have also IVF where you can have a healthy baby and making a pregnancy. So this is also one of the part to use the IVF. And fourth part, if you have a recurrent pregnancy loss, though the data still not confirmed, I know that there are a lot of things in the medical science where data not confirmed, but clinical practice might help you. So if the recurrent pregnancy loss, yes, in that condition also sometimes it is making some genetic link is there, some CNV is there, copy number variables are finding out, some genetic translocations are there. Even all these conditions to reduce means to get a healthy baby, that is also one of the IVF. Now, last part, which is more important, that as you are saying, rightly said, that what is the future of IVF, and that is what we observed, that might be it is called in a cancer patients, I want to say, the using of the some alternative treatment, the cancer patient, breast cancer incidence is 31-32% and 15 to 60% in the younger women before they plan the kids, and they can go by the egg freezing. So this is also part of the IVF, right? So they have a egg freezing, and after completion of their the cancer treatments and everything, and after through 3 years or 4 years when they are become healthy, what about the happy life, right? So it's a healthy life, but what about the happiness? So happiness can be created, I think so, can be created by this type of all the cancers, even in the male or even in the female. If 80% cancers are curable, if they are detected at certain point where we can also have a egg freezing, even sperm freezing is also important in the male part, in the certain gastrointestinal cancer, before the any chemotherapy and everything, we can have a freeze the eggs. Might not we know that some disease of the female, and also I think so I'm coming out some campaign like freeze your future, right? Freeze your future. So that is also important for a certain ladies, because I have a lot of queries of the corporate from corporate sectors, those who still not decided for marriage and they want to freeze their future. So that is also one of the part of the IVF. So these are the all things, I think so. A lot of things are there. Genetics, the tissue freezing, egg freezing, and I think so. I already say to prevent the genetic disease. All these things will even I think so. The savior baby is still ethically how it's going on, I don't know, but you can also produce a savior baby. Right? You have a thalassemia major baby who is getting a treatment, and then you can produce a sibling which is actually a match to that baby, and you can also have a transfusion, bone marrow transfusions, and have a savior the existing baby. So the savior baby concept, these are the different part of the IVF, and I think so we all people, I think so, whatever the panelists are there, they are so experienced and they know everything, and they are all are serving and doing in a routine whenever it is required.
So there is something called a social IVF in addition to medical IVF, and I think Dr. Jayesh was enumerating all the reasons for social IVF, like egg freezing. It is also, we know that sometimes we need to do sperm freezing if the husbands are not in the town or they are both traveling, may not be present. So social reason for IVF is also there. Egg freezing for cancer patients, egg freezing for social reasons, and PGTA will also be one of the reasons for, not for patients who can conceive, but we don't want them to conceive naturally because we want to screen their embryos before we transfer. As regards your previous question of IVF pregnancies giving rise to babies with defects, now you must understand it is an inherent problem of the couple that you're looking. If you're treating somebody at 39, 40, 41, it is not the process of IVF, but it is the inherently found in these elderly women. And that is why they're termed as high-risk pregnancies, or even they may have abnormalities. But this has got nothing to do with the process or the procedure. It is the inherent reason why they have first come to you in the first place.
Thank you so much, Dr. Amit. Dr. Bharti, if you're here, one last question to you. Dr. Bharti,
I would like to say, see, you first question of yours was who can seek the advice, infertility advice or IVF when they're naturally not conceiving. So how will you define yourself, like when you need to go for a treatment, especially? So WHO, according to WHO, if you take 100 couples in front of you, 90% of the couples should conceive or conceives if they have an unprotected intercourse for 1 year down the line. So if they don't conceive in 1 year down the line, when she is less than 35 years. See, the woman's age is very important. If she is less than 35 years of age and they are trying after the marriage 1 year unprotected intercourse, they should conceive. 90% of them conceives. The 10 to 15% of the patients couples who don't conceive, those patients we should start seeking the advice or at least investigations. Now, more than 35 years of age, woman's age, she has only 6 months, not 1 year, but 6 months down the line, they should start at least seeking the doctor. Now, this is what the first question of yours answers. And then if suppose a patient is going, like you said, other perks of IVF, what different perks we have in IVF, is suppose a couple, a female comes, say, maybe 28 years or 35 years of age or 32 years of age, and she doesn't have the eggs. Her AMH is very low, which is very, very common in India. In Southeast Asians, we are 6 years before menopausal. So our ovarian reserve goes very fast down. So maybe a patient who is 28 or 30 years of age and she has a very low AMH, that is anti-Müllerian hormone, or almost negligible eggs are there. In that condition, she can go for egg donor IVF cycle, and that's very authentic. And that is another way IVF is being boomed. So many females who have less ovarian reserve, they can go for egg donor IVF cycle. So the same thing was actually for even surrogacy also. But now with this law, there can be a surrogacy, but it has to be altruistic. But then if suppose she doesn't have uterus at all, or she has been unfortunate that during the period of her previous pregnancy, her uterus has been removed, so she definitely has still chance to get the child through the surrogacy. So these are the different, other than Dr. Jayesh and Dr. Amit said, these are the few different points I just wanted to tell you. And you asked the third question, whether they have a premature delivery or they have any different obstetric complications if the patient is conceived through IVF. Surely, patients, because usually patients are more than 32 or 33 years of age when they come to IVF treatment, and naturally with age related, they have these all complications there. Because in the data, it has been, I think, it's been proved that they will have a more IUGR, hypertension, and then they will have a premature delivery possibility because twin pregnancy or multiple pregnancies. So these all complications could be there, but it is not that high that we should be bothered about not getting the treatment. Is that okay?
Yes, yes. Thank you, Dr. Bharati. Just another one. We often see in the movies that there's a myth that the eggs get, the sperms get exchanged, like in the movie Good News.
No. Now that is actually fiction. Actually, they just wanted to, see, how will you get entertained unless if you see plainly, if you talk, how many people will listen to our talk also? Something fiction has to be there unless and until there will not be a curiosity of the patient. But it doesn't happen like that, because nowadays so it is very double witness it is, and usually it doesn't happen unless and until patient gives the consent for the donor sperm. We do not use the sperm donor, or it will not happen that this one goes to there and that one, because everything has been labeled. So people are very responsible. They know that these are the gametes. So it just sometimes might be somewhere it has happened, but that gets highlighted. You all know that. Good things doesn't spread so fast, but the bad thing spreads so quickly.
Everything is coded and there is double witness. If only you believe in the movies that hero in real life can manage 4 rogues, then you should only believe this.
Very true, very true.
Thank you so much, everybody, for joining this panel. We talk about the infertility myths, misconceptions, and coming to the session's end, just a quick lines from everybody. Maybe we can just conclude this, how awareness, we have discussed that awareness is one of the important things. We need to talk about infertility. We need to bring about a change, and how education is important, and not only information from the online is important. Thank you thank you everyone for joining and helping us create awareness about infertility and the myths. I would like everyone to also, the listeners to, you can also tag us, use and share us with the hashtag Let's Talk Fertility, with a pledge to create awareness and to advocate best practices around IVF. Thank you so much, everyone. And I would like to give up to Anisha. The next discussion would be about the future revolution of IVF, the new normal in human reproduction. Over to you, Anisha.
Thank you very much.
Thank you.
Lovely.
Thank you very much.
Thank you. Thank you all.
Thanks to all our experts and to Riddhi for conducting this very interesting discussion. And there's more coming up. Like Riddhi mentioned, we're going to talk about the future of IVF. Now, the increased demand for IVF.
Can we leave? Hello? Can we leave now?
Yes, please. Thank you.
Yeah, thank you.
The increased demand for IVF due to socio-demographic trends and increased supply facilitated by new technologies have converged to transform the way a substantial portion of humans reproduce. This session will highlight the societal and demographic trends driving increased worldwide demand for IVF, as well as an overview of emerging technologies that promise to greatly expand IVF utilization. Please welcome the experts who are joining me now to discuss the future revolution of IVF, the new normal in human reproduction. Please welcome Mr. Anubhav Prashant, COO, Apollo Cradle and Apollo Fertility, Mr. Vinesh Gadya, Senior Partner and Chief Executive Officer for India and Emerging Markets, Black Cap Equity Management, Mr. Abhishek Agarwal, Chief Business Officer, Birla Fertility and IVF CK Birla Group, Dr. Shitesh Murdia, Chief Executive Officer, Indira IVF Hospital, and very soon we'll be joined by Dr. Shomesh Mittal, Chief Executive Officer, ART Fertility Clinics. A warm welcome to all our experts. Thank you so much for joining us today to talk about what the future holds when it comes to assisted reproductive technologies. Now,
can somebody open the camera for Vinesh? I think his camera is blocked. He just put a message in the chat.
All right. So I'll ask the technical team to please help out.
Yeah, that's working.
There he is. Mr. Gadya is with us. So one question that I wanted to start with each one of you to understand, what were the learnings? When the pandemic broke out in March 2020, IVF procedures were halted because they were seen in selective programs, and they were just halted. And this brought a lot of heartache for patients because they have been waiting to start their families. And soon enough, these elective procedures were started. But for clinics, for hospitals, they had to deal with this time where they had, on one hand, exasperated patients, and on the other hand, stalled revenues. So what was the learning from this period? I would like to ask all of you to very quickly, in a brief fashion, tell us what was the learning from the pandemic period. Abhishek, would you like to go first?
Thank you so much, Anisha. Am I audible?
Yes, please go ahead.
Thank you. I think the pandemic was a challenging phase for the complete healthcare sector. But IVF as a specialty, and at least what my experience has been seeing the three waves go by, was somewhere taken a little bit by surprise. While hospitals have large workforce and there is a little bit of backup that you always have, in smaller single specialty operations, as most of the IVF clinics follow, you will see that staff conservation, while ensuring that the patients are provided continuity of treatment and service, come at loggerheads. And it required for us extreme amount of agility, almost daily troubleshooting different situations at different centers of operations. I think one big learning for all of us in healthcare has been that online consultations, way to engage with patients while they are at home, somewhere was a savior for patients and also for the doctors and teams providing them treatment. So that was one big takeaway. And I think the second big shift, at least in my experience, I've seen post the pandemic as well, is that infection control and the ways of working in healthcare in India, at least, have changed permanently, and they have become better and stronger than what we saw pre-pandemic.
So that is definitely to the benefit of the patients, so long as they are patient themselves. Chitesh, what were your learnings from the pandemic, especially for the ART segment, where there was once a significant disruption and then resuming of all your work?
No, I think the switch off and switch on for IVF labs is a very difficult operationally, I would say, in the embryology lab, because we are tuned to be running 24/7, 365 days a year. So to switch off your operations, get all your machines out, and then to switch on again and get the calibration and everything back on track, the people working back on track was something that took a lot of time internally for us to start training, start making SOPs on how to start working, especially with the COVID around, and a lot of reports coming in that COVID virus could spread through these sperm samples, through the embryos and other things. So I think that was big learning. But I mean, apart from the operational, the HR, the various cost issues that everybody might have faced, I really want to acknowledge everybody in the community, in the group. I think every employee took a step ahead and realized the difficulty that the organization is going through. And I think everybody supported so well the entire organization, the entire company, that we were able to see through that first phase when we were asked to shut down. I think second phase was a little better, I would say, in terms of operationally, when the government allowed the clinics to still function. But first wave was really bad.
Brutal. Anubhav, what was the experience like? And I'm sure the experience wasn't pleasant, was rude, but what were the learnings? What have we understood now? That and how can we prepare for something like this in the future, keeping our patients' interest in mind?
Yeah, hi Anisha. Hi everyone. I think the big learning for everyone was you can never be completely prepared, no matter what plans you have. I think life will throw surprises. So it's important that you start looking back at your processes, start looking at your people from a continuity perspective, because from a business perspective and from operations, it's important to keep the show running. And especially if you're involved with patient care, how do you, like Abhishek said, how do you continue to ensure that patients were connected, the doctors and the patient connection was ongoing, and you continue to ensure that patients who were undergoing treatment, they were able to finish it off. And while new patients who were getting anxious and jittery, their nerves could be calmed down and said, we will come back to you as and when normality resumes. And also, like the other panelists said, safety has now become a primordial concern for everybody, not just for our staff, but also for our patients. So it becomes a new normal for all of us as we move along. So which has also meant changes at the operational level, both from a business side, both from a clinical side, as well as on the lab operations as well. And to safeguard certain off tracks that can happen, a lot of those technological safeguards are being put into place by everybody to ensure that we don't have these surprises in the future.
All right. Dr. Mittal, what is it like for you? What were your learnings from the pandemic?
Thank you so much for this inviting me. I'm Dr. Sumesh. I've just joined the IVF panel. I think the people sitting here are much more wiser when it comes to IVF side. For me, it's a new journey, although I have been in healthcare for pretty long. So for me, if you ask me, I think what I've been hearing now from IVF point of view, my view is that same is the problem which entire healthcare faced. There's bad to it, there's good to it. The bad part is that in the IVF side, it's people who can still wait for some more time. So the business will get suffered very badly. So that's one big thing which is there. And unlike other healthcare verticals, the revenues are not that high that you can afford to lose that business, right? So to continue to your business. So I think hats off to the entire group of people around here that during this pandemic, like any other multi-speciality hospital, still there is a lot of profitability, and they can absorb the losses to some extent. But same is not the case in my mind to IVF sector. So I think it is a very difficult time for IVF field itself, but I think they've come out well. Second good part, if you ask me on the good side of it, is technology. I think IVF needs a lot of awareness, digital branding, medium, and all those. And healthcare that way went in a very positive trend. People have started using healthcare digital as a platform for online consultations to, reaching out to the people. And that is where I think the positive is yet to come, which has started to come already. So that is one plus thing which will happen. And next thing is definitely, yes, infection controls and other processes. Thanks to pandemic, I think it has shown everyone that it is very critical. And also more so with COVID going to affect your, IVF and other procedures and their results is another big thing which is yet to happen. We don't know what it is. So broadly speaking, I think it's a positive now if we go in a right direction. More so with ART law coming in and all those, I think everything will come in. So it's a very jittery time for IVF vertical as such. But hopefully, I think we are in a right trajectory now.
All right, Ganesh, what were your learnings from the pandemic outages?
Good afternoon, everyone. Happy to be here on the World IVF Day. Having spent my 3 decades in the career, I am excited to contribute to the panel. Okay, to your question, Anisha, I think every difficult situation brings out something good to learn for future ready. So out of many learning, I will pick up only 2. The pandemic and the closure made us realize that operational cost efficiency is such an important aspect. So if we keep our business operationally cost efficient, we will be able to survive the rainy days. I think one of the most important learning as a CXO position in IVF business was that it made us more operationally cost efficient, and it has made us more future savior, future ready. Second big learning was that when suddenly the IVF practice was stopped, the interesting realization was that we can go where patient is available, though they cannot come to clinic, but it brought a very significant digital disruption. So during the closure time of IVF practice, at least I know most of my colleagues here would agree that we went full steam on digital medium, bringing out meaningful content, keeping a very strong connect with patient, and kept on keeping patient encouraged, motivated to take up the treatment as soon as the IVF practice was allowed. So digital disruption, cost efficiency was 2 big learning for me during the pandemic, which also helps us to be future ready. Thank you.
All right, so this brings me to my next question. The pandemic taught us we have to innovate. Of course, the SOPs, basic safety and sanitation and precautions have to be taken, but we have to innovate. And like Vinesh said about bringing the service to the doorstep of the patients has been done in many specialities. To what extent is this true for IVF? If not the entire procedure, because you need specialized intervention. For some tests, medicines, injections, can we have the concept of IVF at home? Anubhav, what do you say?
Well, like most of the specialties, I think, yes, this trend is there in IVF as well. And already, I think we see that a lot of parts, some parts of the initial treatment, like you said, the test, the initial screening, can be done at the comfort of the patients. And more so after the COVID, there is a tendency of couples not to step into the clinics or the hospital unless and until absolutely necessary. So yes, we will probably see some part of the IVF treatment moving more closer to the patients, more closer to where they would want an access, and you will see some bit of adoption happening at the centers. At the same time, there are clear aspects regarding the absolute procedure itself, the monitoring, which probably still needs to be done at a center, right? For which the patients and the couples will still continue to be required to come to the centers. And at the same time, as technology advances and we're getting into innovation where, couples can start monitoring their treatment offline, see the results, may not be required to come into the center for counseling, for example. in the future. So we may see an hybrid model coming in, but yes, the core of the science will still happen in the centers. The magic still happens in the IVF centers. So it'll be difficult to sort of take that.
Yeah. This hybrid model is evolving all through healthcare. I'm just trying to understand from the IVF perspective, Abhishek, what is being done digitally or being done at home? Are you still going to labs to get your test done? Do you have home kits? See, even for COVID, we have a home kit and an app, and people are not going to labs for testing of COVID. So are we doing that? Are women able to see when they are ovulating, or some of the other tests that they don't have to call a lab, and hence their expenses are lower? And when it comes to expenses, like if you don't have so much patient walk-in, are you saving on cost? And what about the investments of digital training your staff for digital interaction, or perhaps having more counselors who are available to speak to patients digitally?
Right. So, Anisha, I think there are two parts to your question. Taking the first one up, if you look at IVF at home as a concept and looking at the patient journey overall during the course of the treatment, as I think Anubhav very well articulated, there are certain parts which will never be online, at least what we understand right now practically. There is ultrasound that needs to be done. It's also in the legal and regulatory premise has to be done at an approved location. And then obviously there is a ovum pickup and there is an embryo transfer, sample collections of gametes for both male and female partners. That will always be offline, as we understand now. It is only the preliminary assessment that can go online, and that can go at the convenience of the home of the patient. And there, I think what we need to understand when a patient presents with an infertility situation, this assessment and this counseling that happens upfront is the most important part. Slowly, the doctors and the patients both have to mature up the curve in India of interacting online with the same efficacy, with the same impact, understanding each other as they would have done in an offline scenario. A lot of questions patients come up with when they are actually sitting with a doctor, which might or might not come in an online consultation, right? There is a little bit of hesitance to open up to discuss the complete situation. So while it is advancing, and we at Birla Fertility and IVF, we are also seeing more people who actually are coming from outside the cities of our centers to opt for this model, not as a substitute for an offline visit, but rather as an early intervention. I think where this concept of going online will help is not if we start changing the definition from IVF to a more holistic fertility treatment. There is a lot to do in infertility beyond IVF, and I think a lot of psychological support, a lot of pre-workup that a patient needs before they prepare for IVF has started to move online, and I think helping patients manage their diet, their fitness, solving endocrinology problems, all of that could move online very effectively. In India, we are seeing that at nascent stages right now. The uptake from the patient side is also limited. Technologically, it is not a big challenge. I think the
personal preference.
It's a personal preference, and what we pick up from the patient side is whenever there is a consultative requirement for any of us, we still prefer the human touch, the direct interaction over an online situation. So I think that's the trend in the psyche overall. Otherwise, technologically, I don't see a barrier for a large part of the patient journey.
Right. Vinesh, what has it been like in terms of cost for IVF centers, IVF chains? Because if there is less footfall, are you saving any cost, or how has it worked out?
Oh, Anisha, I was just thinking about the last question. I could not hear this question very well.
The question is, because some of these services have moved to an online mode, even consultation and initial pre-workup, what does this mean for cost saving for the management?
So I still believe that the hybrid model is not yet evolved well in India for us to identify the difference in cost structure. But overall, answering to your question, I would take an example from a company called Prelude in US. It's a digital app only for fertility, and today is invested by a private equity firm and has a valuation over $1 billion. So I think this model is coming where patient will be digitally connected on consultation for counseling for all the tests, and the app or the digital company connects patient with an IVF clinic on the back end, which is a brick and mortar clinic. As rightly said by all my colleagues, patient has to come to clinic. But coming to clinic will be very limited, maybe a couple of times during stimulation for sonography and for the actual procedure. So I see in next 5 years this becoming normal in India. The patient would start taking IVF treatment digitally and will come to clinic only when it is required. And once this model is evolved and it is established, I think there will be, of course, there will be a division of cost structure. As such, consultation counseling does not dilute too much of cost structure of IVF for the clinic. But more patient logging into a digital platform and then the platform sending patient to IVF clinic, I see it coming in next 5 years.
So does that mean, Vinesh, the business expands even more?
No, it should not expand. It's not more expensive for patient. It's very convenient for patient.
The question is for the group. If you have a platform where low spend, you're not spending to advertise on that platform, but people are, finding you on that platform. Does that mean more bang for your buck? You will get more patients and business expands.
Yeah, of course. It should expand. It's going on that way, and I am sure it's coming. I mean, for any new disruption, I would generally prefer to see what is happening in a mature market, what is happening in developed markets, so that it will come in India today or tomorrow in 5 years, if not 10 years. Then it's already there in US. You take example of Prelude, you take example of IVF Babel, a global digital magazine connecting patients with clinics. You take example of a homegrown company like Fertility Dost. So I think it's coming and it will definitely expand and help, because majority of IVF will happen from home, excepting 2 or 3 visits.
What do you think, Kshitij? What are your beliefs?
No. I just on the last question, I think nothing comes for free. So I mean, even if these
it's not for free. I'm just saying that a platform is because of technology.
Yeah.
People are discovering you without you doing the work.
Yes. So I being a doctor, I strongly beg to differ from all the panelists from the concept of IVF at home. And I think without compromising, till you have that strong conviction, 100%, that without compromising the quality of care that you can provide to your patients, whether it's in the hospital versus at home, I think it should not be a familiar thing for the patient or for the doctors. And I know the difference when you are consulting a patient digitally versus when the patient is in front of you with a file and you can go through the entire history. All said and done, the entire history would be digitally present on your computer or your laptop. But I feel that disconnect going through that history and talking to that patient simultaneously, back-to-back appointments and all. And I think many regulatory and other ethical concerns also warrant that certain procedures. I think the majority of the procedures, I would say, for a chronic disease like diabetes and hypertension, it could very well move to digital consultations, IoT devices giving you inputs from the patient at home, and then you suggesting some treatments out of it. But I still feel, that's my view being a doctor. IVF still best done at the clinic because there are many variables that you need to control. There are certain variables that you can't control, that's beyond your control of a patient or a doctor, that's fine. But even the minutest thing of giving an injection to a patient, what dose actually is being given, how careful you are in titrating that micro milligrams doses to the patient is very, very critical for the entire process.
Dr. Somesh, what would you like to say? Having that direct patient connect, is it a deal breaker? Because for patients, they have the convenience of doing at least a few things at home. And, the entire stress of going, meeting the nursing staff over and over again in 1 month's time is also quite stressful. From a practitioner's point of view, do you think this digital intervention helps?
So Anisha, like Kshitij, I am a doctor, all right, and I've been an administrator for last 25, 30 years. So I've seen the other side. I've been part of many startups which are there in different verticals. So now what my take on this is, as a doctor, if you ask me, yes, a patient should come to me. That doctor-patient relation when you meet is totally different. But if you ask me today, how the healthcare moved in India, just 2 minutes I'll take, is that when corporate hospital started, which is way back in 2000, that's the time when corporate 1995 odd is when corporatization of healthcare started in India, to my mind, primarily. Before that, it was doctors who were having nursing homes and others. So I'm talking about big corporate hospitals that started. So then what it gave one good part is that it gave what as a doctor we don't know much, on the other side of it, how a patient is managed, hospitality and all those came into being. I think where we are today in IVF space is something like that, which happened in the disruption at that time on hospitals is happening in IVF side now. Although IVF has been there through many chains in India for last 10 years. But I think now the push and the spend which is happening will lead to two things. Number one, technology definitely is the way forward in my mind. Now, how will I connect to answer Kshitij? I'm not saying that we should not take care of it, but I think there will be vertical which each hospitals might have, that rather than patient walking to you, you go back to them, right? And you do that everything same at their home by your trained staff, which is there, which means that a patient service and patient satisfaction is more important than getting that patient to your clinic. Until and unless a doctor has to see it, why can't rest all things be done at home? Government regulations of ultrasounds are there, but I think with the time to come, all this will also start to evolve and become much patient friendly. So everything will move, in my mind, as Vinesh was saying, to home, but with the technology in place, which is there, and all these fertility, those of the world and others, will definitely play a significant role, because there is a trust deficit in my mind. I, as a patient, if I'm there, I don't know today whether to go to A, to B, to C. So what I do, I go to all these clinics and make my judgment based on trust. Moment this fertility, those of the worlds and those kind of people come in, they will play as a trust builder for me, and I will go through them, that they will guide me which of the 5-6 centers are one of the best in that city. So I think technology and all these intermediators will definitely play a significant role, whether we want or not. So I think that is what the going forward would be.
Right. Anubhav, you want to add something?
Yeah, I'd like to come in here. So, for example, if you see most of us right now also, we treat a lot of international patients, where the primary workup is absolutely done on a digital platform. You connect with the patients, you assess them, you have a preliminary investigation, etc., done before they actually land up in India. And whether we like it or not, Kshitij or Somesh, we will have to continue to listen to patients, right? And if the patient wants us closer to their home, their doorsteps, we will have to. Secondly, even before ART law or ART new bill coming in, a lot of centers, including all of us, had IVF centers and satellite centers where patients' convenience could be managed. You don't have to come to the main center every day and day out, even for injections, for example. It can be done at a center close to you. After ART law, obviously, with level 1, level 2 clinics coming in, that trend will still be there, but definitely there will be in some hybrid. I think the best course for the sector is to be prepared for this. You're on mute, Anisha.
Right. So preparation is the best thing one can do, and keeping up with the reality of today is also quite important. Now I want to talk about how IVF treatment is growing in our country. We've seen many corporate groups backing IVF chains coming up now, as opposed to the previous practice of standalone fertility clinics, which were run by reputed doctors. And it was hard to get appointments, treatments, and they were expensive as well. So what is going to grow faster in the future? Do we see this trend of corporate groups, IVF chains increase their growth, be faster than the standalone ones, because of the reputation of the doctor here is very important, especially in this field. The reputation, the success rate. So that is what was the determinant when it came to picking up a center. But now with IVF chains, the costs are coming down. So that is also something that people consider. What do you think is going to happen in the future, Abhishek?
I think with the biggest change that it has happened in the recent past is the advent of ART law. And I think with first time the industry now being regulated properly and the law being enforced, it comes with a lot of processes, rightly so, and a lot of ways of working being defined by the policymakers. In such a scenario, it is very natural that the cost of running an IVF clinic is bound to go up. You will need to have more manpower versus a choice that you could exercise as a standalone clinic. There is defined manpower, there is defined infrastructure requirement, and there are also defined processes that have to be abided by. It's a welcome change and a move in the right direction for the industry overall. But looking at this context, I think it becomes a little difficult for an entrepreneur running their own setup. Of course, they will continue to do good work, and many of them will continue to grow. But a lot of them, I think, will find it difficult and will want to explore other avenues, and hence the corporate base setup in IVF is bound to grow faster than individual based practices. That's my view.
Kshitish, Dr. Kshitish, what do you think? What's the future like for standalone IVF clinics?
I think in the country, we need a proper balance between the corporate chains and the standalone clinics, because all said and done, these are doctors who have earned a reputation and name, and their outcomes are pretty good in the overall industry statistics, I would say. So I think a proper balance between both the things should coexist in the country going forward. All we need to ensure, both on the corporate side and on the individual standalone side, is governance, and then the quality of treatment that we can offer to the patients, keeping all the ART regulations in mind. And I think it's the only advantage with the corporate chains could be economies of scale and replicability that the corporate chains could put in, and the standalone centers might face little difficulty in doing it. But I think existence-wise, I think it's a good mix, and it should continue to be the same way it is in the country right now.
Anubhav, what do you think? The way corporate chains are growing, do you think there will be better standards, better technologies, better outcomes with ART treatments in the future if they continue to grow at the pace that they are? The concern, of course, is that some of their practices are not very ethical, they mislead patients, and that is why some of those concerns are there, and that's why you have an ART law as well.
The Indian outcomes have always been comparable to the best in the world. I don't, or none of us doubt the talent and the outcomes that our doctors and embryologists are producing. Yes, what the ART law has done is create a common minimum platform for everyone. So from a patient perspective, actually it augurs very well, because now as a patient, I'm able to look into an independent registry and see who's reporting what are the actual success rates of each of the centers against what one would like to claim, right? Which has hitherto been the trend in the industry. The second aspect, you can never take a doctor out of a medical profession, right? So the doctor will continue to be at the core of the science. And hence, like Kshitish said, we need those standalone centers to continue to flourish. Yes, the organized sector will probably continue to grow because it has a very smaller base right now. So what typically would be a 95-5 right now would probably become a 80-20 tomorrow. But I don't think the unorganized or the independent centers are completely going to move away to corporate world.
All right. So that's a variety of opinions coming in. I'm just trying to understand what happens to cost for patients from the patient's point of view. Management scale comes in because of these corporate chains of IVF clinics, because we are seeing a lot of interest by investors in backing these chains as well. They only do it because there is a real market. There's a real need of people to answer their healthcare needs. So when you see scale, do you see costs coming down for the patients, even if statistically their success rates may not increase, but because the cost is low, they can try many more times?
So I am a very firm believer of any business, not IVF, which is well governed, well organized, professionally managed, has a better future. It's nothing against standalone or for organized, but an organized business where it is managed professionally with better governance is of course better for patient. And I believe it also brings better clinical outcomes. That's my belief, because the whole business ecosystem is very well managed. In that context, ability of an organized chain of IVF to bring down the cost over a scale definitely is better over a standalone clinic. I don't have any doubt. While coming to the subject of cost, the kind of clinical excellence India is delivering and the kind of customer satisfaction we are delivering in India, I mean, along with my colleagues, I'm just putting it that we would have seen the whole world. I have seen best of the clinics Far East in Japan and best of the clinics in Western world. We are nowhere behind them in terms of infrastructure, clinical outcome, so much better in customer satisfaction and customer handling. In that context, we do IVF in about $2,000, $2,500, which is less than 1/5, 1/4 of the developed world. I don't think cost beyond this will come down in India, because we are on the top in clinical outcome and patient satisfaction, and we are on the bottom in terms of delivering the same service at 1/4 or 1/5 of the cost of a developed world. So I think cost, we are at optimum level in India and will not go down from what it is today.
All right. Costs are optimized at this point in time. What about insurance, Dr. Sumesh? Do you think it's still not covered? Most of the ART treatments are not covered by insurance. Do things change there?
So Anisha, I'll put it two different things. First, to answer your question, because I have little difference in the previous ones. But first, I'll answer this. I think insurance is far away at the moment. I don't foresee this happening with whatever knowledge I have in next 4 to 5 years. I don't see insurance going to address this out so easily. Why I'm coming to this is the bariatric, which is one of the another procedures, not of IVF, took long time. That's something which is straightforward, which is there. So I think it is, first we have to reach masses. There has to be more and more people. Awareness has to come. Volumes have to increase. And anything which have a bigger volume, bigger say of the public, then only the law will change and all those will push the insurance companies to start accepting this. So I think that question, to my mind, will take a long time. It will be out of pocket expenditure which will happen. Second thing, coming on the clinical outcome, while we are good and all those, but I feel with little knowledge which I've seen in last 2-3 months of understanding, we may be good, but trust me, in the world market, when you go and stand, are we still there in that market? I think we have to present ourselves that way. As an Indian, we have to present ourselves that we are good in clinical outcomes. That will come only with research. When we present ourselves that our outcomes, our innovations, others are following. Today we are following other people. So I beg to differ in it that we may say that we are 70%, we are 80% success rate. Reality is there's no benchmark on which we test ourselves. So that is where whole trust deficits is coming. So I feel we need to work a lot. This is the segment of healthcare which we have to pump up ourselves, bearing few doctors. I'm not naming that these doctors good result or not, but as an industry wide, there's a lot to do. And more centers now opening up means more and more early stage doctors whose results may not be good are going to enter and start doing work, which means our results are going to go downwards. That is where we need to have our SOPs in place. That's where we need to involve more technology. Our embryologist needs to be more trained. So I think it's a very challenging thing. While we say we are good, but because we are less number of clinics at the moment. The moment we all corporate world comes in, means we'll open up 100 clinics, right? And we'll say everywhere else, there is no benchmark of saying what is success. So I think it's a big challenge, and we need to accept this fact that we need to gear up much faster and take it to that level. So that's on the question which others were saying we are up to the mark. I feel we are below them. We have to accept that and take. That's what at least I feel, that we have to gear up ourselves. Sorry.
All right. You believe that we still can do better because the benchmarking is a little vague. But no doubt, Indian doctors have had good success in treating many foreign patients, and they have won the trust. They have delivered the goods, which is why more people from abroad continue to come to India. Whether the cost will be determinants of what happens in the future, it's all up for anybody's guess. Kshitij, Dr. Kshitij, what do you think will be the impact of the ART law on the growth of the industry? Because, before this, we had self-regulation. Self-regulation was obviously not working. They were unethical practitioners taking patients for a ride, making huge, unbelievable promises. Now we have a law coming in to rein in some of these unethical practices. What will be the impact on the growth of the ART industry?
See, I think we've been, and Vinesh and all Anubhav have been with us, and we've been discussing for the past 2-3 years, especially on self-regulation. And I think we as a group took a step that, let's start accreditation internally for at least of all our IVF centers, and let's adhere to a minimum quality standard, minimum way of working, structured SOPs, infection control, ways of reporting every outcomes, whether it is not just related to IVF, but there are many other things that you do during the entire IVF cycle. So I think scaling up your governance level internally, and don't think that it's the ART bill that has come up and somebody would come and audit you and check you and then you do changes to your practice. I think gone are those days. I think you need to start working and not start just talking about internal quality control or governance and other things. So I think that step has to be taken up by the corporates, and all the corporates are doing it. So I feel not a major impact among the corporates who are already following, and even the standalone centers would be following some of them. It's not that every standalone center is not following or doing unethical work. There are many standalone centers. I know personally many doctors who are following all those processes and policies. I think the future is only for corporates or standalone centers who are making sure that they are adhering to a certain basic minimum standard of working, and not just IVF outcomes. It's the way how you handle the patient right from the inquiry point, how you do the entire cycle, and how you interact digitally with them, how you service these patients. I think that will make a big impact. Overall, I think regulation for any industry, I think it shifts the load from more unorganized to organized. And I really don't like these words unorganized, because they portray the standalone center as if they are not doing anything, because all of us have grown from that level. We were all someday in life, we were all one single standalone center, and we've seen the journey now to this level of multiple centers, managing multiple centers. I think people who are following this, I think the business could shift from little bit from the standalone centers or the unorganized sector to the organized sector. And obviously it will bring up a huge cost for people who are not doing these kind of audits or strict checks and compliances within. So I think the overall market could shift, but I don't see a real challenge in the growth of the market, at least for the overall country as such, or for the organized sector. No. You're
right.
on mute.
Right. So Abhishek, how do you see this new ART law? And while Dr. Kshitij is saying that many standalone centers have good ethics, but if you don't follow the rule now, they have penalties to pay, and it is risky now. So does this lead to a shakeout? And does it increase costs for standalone centers?
Yeah, but let me answer the question you had asked, Kshitij. It's an interesting one, actually. Whenever an industry gets regulated, there is a natural scare that the market being regulated will now become either economies will suffer and will shrink or will become stagnant. I think in this case in India, where we sit only at 1% of people who require infertility treatment turning up, a large part of that reason is not just awareness, supportability, or accessibility, but also the lack of trust on what happens in IVF. And somewhere with a regulated industry, that trust will slowly go up. And I fundamentally believe more people who need infertility treatments will now have enough faith and confidence to come up to an IVF clinic much earlier on in their cycle and much earlier, and I think more in numbers. So it will eventually expand the base of people availing treatments in India. So it's a positive step. It will lead to growth of the industry at an overall level. Coming to standalone clinics, the second question you asked, the cost as the law stands will go up, I think, if you were not compliant earlier on three things, and it varies from, I think, clinic to clinic. If you had manpower which was makeshift, which was not full-time, yes, the cost will go up on manpower. Infrastructurally, the law very clearly defines the minimum common infrastructure required in a level of a clinic. If you did not have that as a clinic, yes, your capital investment will go up. And operationally, to service the process requirements of the law, there might be a couple of hands more needed. So in a nutshell, the cost of running and operating a clinic will go up for everyone.
All right. What I want to now understand is, you've spoken about the growth, the compliance costs, etc. The other parameter is that the growth is going to be strong. We need trained staff. I mean, what good is an IVF center if your embryologist isn't good enough? What good is the IVF center if your lab isn't good enough? Right? So, Anubhav, what is the training investment required for the growth that you're foreseeing in the ART sector? Because there are doctors who believe कि हमने तो 30-40 साल काम करके इतना अच्छा नाम कमाया, इतना अच्छा हम काम करते हैं. आजकल के नए डॉक्टर आते हैं, क्या स्पेशलाइजेशन है, इनकी क्या ट्रेनिंग है, 6 महीने का वो सर्टिफिकेट कोर्स लेके ART शुरू कर देते हैं. So how do you counter these kind of problems?
So I think the new law is addressing both these aspects. One, the existing set of practitioners, both clinicians as well as embryologists, working in those centers. There is a provision which has been made on that, who can continue to get qualified and get registered under the new law. And at the same time, for new practitioners or wannabe embryologists, because suddenly we suddenly see a lot of surge in people wanting to become embryologists, because everybody sees growth happening, and which is good for the space. There is a common minimum, again, a guideline which has been laid down very clearly, who can become an embryologist, who can qualify to become a gynecologist, working in an IVF center. So I think those lines are fairly drawn. Obviously, they will continue to get evolved as we move along. So yes, that poses a big manpower challenge for everyone, because if all of us were to do what Kshitij has done at 100 centers plus, it obviously requires a lot of manpower, a lot of good manpower, and you just cannot depend on doctors and embryologists available out there. You will have to, every center or every larger chain will definitely have to focus on creating their own training program, reskilling program, and continuous training program to ensure that you have good adequate pool available. And obviously the pool would be made available for the entire industry. So yes, you will see a lot more training programs, a lot more fellowship programs coming up, both at the university levels. I think there is a lot of plan from the universities also now start offering courses both for clinical as well as embryology fellowships. And similarly on the private sector side, you will see a lot of centers opening up for not just for the in-house practices, but also creating pool for the industry at large.
Vinesh, are enough investments being made by corporates who have these IVF chains, because they know the demand is going to go up, so might as well start training people now? Are they making enough investments, or is it going to be poach the best, whatever the cost?
My strong belief is that in corporates, all of us are making a lot of investment in making ourselves future ready. I'll give you an example. I was one of the founding member of one of the earliest corporate in India in 2011. And very early, one thing what we realized is the shortage of embryologists we will have in India. Even today, if you ask me, India has highest number of gynecologists in the world, 35,000 plus. Half of them aspire to become IVF specialists. So to get 6,000-7,000 gynecologists to become IVF specialists through a one-year fellowship program is not going to be difficult. India has one of the best colleges in healthcare administration. We will get good staff to manage hospitals. So we have a lot of talent in India. The biggest shortage will be embryologists. And way back in 2011, we had set up a very robust training program with our Spanish partner who are the world leader in IVF. And we trained, today I can feel proud that there are at least 100 plus embryologists in India, which were trained in my previous organization. Even today, if you ask me in my current position or in current company, what we aspire to start is a school of embryology with a reputed university in India and abroad. So we all are aligned and we will put in a lot of effort, investment for trained manpower required for a very robust growth, which is going to come in this decade in IVF in India.
All right, very quickly, we are at the close of the show and our summit. I'm going to take a short concluding remark from all of you. Today is the World IVF Day. Kshitij, let me start with you. How do you foresee, ART treatments in the future, and what hope do they have for patients?
I think for the future, what we are looking as a group, and everybody should be working on it, is entirely digitizing the entire patient journey at multiple touch points, so that one, we can serve the patient at ease. Second, we have all the records with us, because now it's become a mandatory requirement to submit all the records to the authorities every month. So I think one aspect is on that. And second, very important aspect, we are looking at how do we move more and more subjectivity to objectivity, wherein all the clinical decisions, the embryology lab decisions could be objectively made through machine, which would bring about much more transparency, and how we can pass that data to the patient so that they also realize what is the decision making happening in their cycles. So I think one is on digitizing the patient journey, second is moving towards objectivity, and third, I think I'll mention the another important thing is to have technology being used to the best to reduce the complications, which could involve electronic witnessing that all the corporate chains are quickly adopting. So any kind of goof ups, I think the last panel that was being discussed at the last 5 minutes, I think that is very important. Using technology to reduce complications of any nightmares that could happen in the lab.
Okay, or errors. Dr. Sumesh, what would you like to say in conclusion? How do you see the growth and the future of the ART industry?
So ART industry in India, I think here it's just a start in my mind. I think it's a big thing to happen. If anything in healthcare, I think it's an IVF which is going to go to the next level. That's one. From our side as an ART fertility clinics, I feel what we are focusing on is just one and one thing, that is an outcome. We feel outcome which a person can trust, that's the one which we are focusing on, which is an outcome driven. And third thing which is important is accessibility and affordability. We are working very hard to make sure that it is accessible to each and everyone. Outskirts, how we can do it using digital platform technology, that is one. And on outcome, we are very, very strong. We want to focus on outcomes, whether we need leaders from outside to come and train us or others, especially embryologists and others. That is our focus on number one, which is there. And we are not cutting cost in that at any corner, whether it's a media which we use it, whether it's a technology in the labs which we have internally. I think that's where we need to spend time to get our trust. So we are working on that, I think. But overall, I think IVF is here to go in a very next level. 2.0 is already started. All the best to all of us.
Right. Videsh, what would you like to say in your concluding remarks?
So Anisha, on the World Fertility Day, I would like to conclude from my side is that on the one side today our economy is growing very fast on demographic dividend of highest young population. On the other side, we have alarmingly reducing fertility replacement rate. I think as a fertility industry, we have a lot to contribute, helping 50 million plus infertile couples in India to achieve their dream of parenthood in the most transparent and ethical way, and possibly the most affordable way. which will help our young population keep growing, which will help our Indian economy keep growing. It will help India to become a little more happy and to contribute to our happiness index along with the economy. There is so much which we can contribute in the coming decade to the country and to the world.
All right. Abhishek, what would you like to say in your concluding remarks?
I think in agreement with my fellow panelists so far, but one important thing I'll add on is we need to start looking at IVF more holistically and broaden the definition in the true sense of ART to other ranges of fertility treatment. Number two, I think using technology to improve success rates for the patient, not just for IVF, but overall end outcome for a couple. And number three, reducing the cost of treatment for infertility.
Right. And that will be good news if it becomes more affordable and accessible for patients. Anubhav, what would you like to say in your concluding remarks?
Yeah, 2022 is already a game-changing year. I think with the new law coming into the country, I think we will continue to look at this as a pre-22 and post-22. And adding to that, India has always led in terms of the cost innovation. So it's time that we look at that from the industry as well, and continue to ensure that the treatment is accessible and both affordable for the patients. And from accessibility, again, from all our perspectives, we will have to, I'll say, evolve the way we reach out to our customers, the customers reach out to us, they access treatment, and then how we deliver treatment. So on hybrid model, whether we all like it or not, is bound to come. So let's all be future ready.
All right. Thank you all for joining us and sharing your thoughts, your beliefs, your vision for the future. And let's hope 2022, like many of you believe, is going to be the inflection point. A lot more coming up, a lot of good news for patients struggling with infertility coming up. Thank you all for joining us today for this panel discussion and sharing your thoughts with us.
Thank you.
Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you, everyone.
With that, we come to the end of the IVF Summit. The world's first IVF baby, Louise Brown, was born 44 years ago on July 25th, and this is the day we are celebrating the IVF Day, the World Fertility Day. We've had a host of experts talk to us about all aspects of fertility, ART treatments, and the way forward. We hope that technology and innovation takes ART to all those who are struggling so that they can fulfill their dream of parenthood. We'll see you again. From all of us now, it's a goodbye from the IWD. Bye-bye.